NSSA Spine 2024, hosted by Krishna Institute of Medical Sciences in association with Korean Spinal Neurosurgery Society, British Association of Spine Surgeons, Brazilian Spine Society.
This conference has a mission which commits to provide the world class educational experience which also prepares the lifelong learners and leaders with integrated knowledge and surgical skills, aiming to build a collaborative and sustainable environment that cultivates 21st century surgical skills and fosters pioneering research and scholarship.
Without further ado, let's dive into promising schedule. Before beginning, I would request Dr. Manas Panigrahi sir come onto the stage and just give a brief note for opening it. May I request Dr. Savitri Shastri sir please come onto the stage for opening notes, sir.
Check. Good afternoon, everybody, and welcome to Hotel Marigold in Hyderabad and the NSSA Annual Conference 2024. My name is Savit. I am the organizing secretary of this conference, and I'm also the person you can contact for any issues. We'll see how best we can sort them out. I was told that Well Begun is half done, so we are almost on time, and we hope for a fantastic session over the next 4 days. And thank you so much for being here, and we look forward to the talks.
Thank you, sir. I request Dr. Manas sir to come onto the stage for opening notes.
I'd like to welcome you all and thank you all for coming on a working day. We had planned to start on a half a day so that people can travel in the morning and be there for the sessions, and then go back on Sunday. For youngsters who want to learn, they have to spend the weekend in the hospital to learn, whereas others can go back and be with the family. So this is the first time we tried this concept, and the executive members of NSSA agreed for that, and we'll see how it works out. And I know there will be a lot of few hitches and glitches while going through the conference. And if anything is there, please tell us. Me and Savita are there to sort out if it's possible in our hands. I request the scientific committee chairman, the president-elect Professor Selvan, to come and open the session for today.
Good afternoon to all. Thank you, Dr. Manas, for arranging a wonderful conference here and initiating with style. And this is the 27th conference of NSSA, but first of its kind in Hyderabad. So on behalf of NSSA, I am very proud to welcome you all to this conference and make it a great success. And behind this conference, there is a confluence of struggle by the organizing team. And we know the difficulties, how they bring it out in a successful one. I must congratulate them well in advance on the inaugural session of the conference, and I declare the scientific program open. Thank you.
Thank you, sir. We are just moving on to the scientific schedule. I would request Dr. H.S. Bhatia sir, Dr. G. Prakash Rao sir, Dr. Rajesh Alugolu sir to come onto the stage for chairing the session. Thank you, Dr. Vasan sir, for coming forward for chairing the session.
Welcome to all the delegates. And a good start. We are starting with the spinal dysraphisms, starting with the some topic development. Probably we can go for the their topics at later stage. Without much delay, I just request Dr. Kaushik from Calcutta present about his spinal dysraphism embryology basis of management.
Good afternoon, and thank you NSSI for inviting me here, and also thank you Dr. Manas and Dr. Suchanda for inviting me to this wonderful conference. You know, the spine has recently gained a lot of popularity, especially in our part of the country, whereas now it has become a symbol of revolution. And some brilliant junior doctors had the spine to present one spine model to our police commissioner, which had a great, profound implication. So with this opening note, my talk is on how the spectrum and surgery is linked with embryology of the spine. As you know, by the developmental calendar, the spine develops very early in life. So many a times before the mother comes to know that she is pregnant, spinal maldevelopment has already occurred. This is the importance of having a preconception counseling, asking the mother to take Folvite while planning for pregnancy rather than after attending the first antenatal clinic. And as you know, there are two types of spina bifida, open and closed. And the important stages of embryonic development are the early embryonic development, followed by gastrulation, where there are two layers of embryos are formed, ectoderm and endoderm, followed by the neural tube formation, that is the primary neurulation, followed by the disjunction, where the neural tube separates from the cutaneous ectoderm, and the rest of the spine is formed by secondary neurulation, followed by neuronogenesis and migration and skeletal development. So the key steps for spinal dysraphism pathologies are three, where four. Number one, where the germ layers are established, that is gastrulation. Number two, where the neural tubes are formed, that is primary neurulation. Number three, where the neural tube separates from the cutaneous ectoderm, that is the disjunction. And lastly, when the secondary neurulation forms. Gastrulation occurs typically around gestational ages 2 to 3, primary neurulation around gestational age 3, and the secondary neurulation around gestational ages 7 to 8. So what are gastrulation defect? This is a 7-year-old child presented with dragging of feet while walking and urinary urgency and neck pain. As you can see, there is a cyst in the ventral part of the spinal column, which is a neuroenteric cyst. A neuroenteric cyst is an endodermal connection, a connection of the neuroectoderm with a primitive endoderm, that is the yolk sac, where there is a persistent neuroenteric canal with some sort of bony anomaly. Usually they present certainly and at a juvenile age. Occasionally they present with myelopathy, as in this case. Typically there is a scalloping of bone, and naturally astrocytoma is a close DD for this kind of cystic lesion in the spine. Treatment is surgery. You can approach from posterior, anterior, lateral sides. Usually with the help of an intraoperative ultrasound, we go from the posterior part, cut the ligamentum denticulatum, rotate the cord, then the ventral cyst, and there are usually formidable adhesions within the cyst. What is important for the parents to know that there is a high rate of recurrence, because that accessory neuroenteric canal is very difficult to identify, especially in the cervical and dorsal region. You require a surveillance MRI, redo surgery, occasional ventral approach with anterior instrumentation in cases of recurrences. This is another case, 11-year-old child born with a tuft of hair in the back and progressive difficulty in walking and progressive scoliosis. And as you know, this is a split cord malformation. The split cord malformation, there are two types, as you know, type 2 and type 1. Type 2 occurs when there is a persistent ectoendodermal adhesion. So while the notochord is formed, there are two notochords which form. So there is a single dural tube, and there are two notochords leading to type and a fibrous band separates these two chords. So there is a splitting of notochord in type 2. As compared in type 1, there is a persistence of the accessory neuroendodermal canal. That is, from the endoderm, a canal goes up, which is infiltrated with mesenchyme, and that canal divides, later transforms either into the bone or to cartilage, and divides the neural tube into two hemineural tubes. So there are two dural tubes in a type 1 split cord malformation. So the patients present again with symptoms of tethered cord, usually in the juvenile age, and you require a neuromonitoring guided surgery. And the point is to note that after a wide and long laminectomy, you have to be very careful while handling that bony spar. Otherwise, it may cause iatrogenic paralysis. And the drilling of the spinal cord always involves some degree of blood loss. There are vessels anterior to the spinal cord. And another most important things, at the end of the drilling, you will find there are some degree of ventral adhesions, which again you need to search for and remove. Otherwise, the detethering will never be complete. High retethering rate occurs if you don't do an adequate ventral decompression of a type 1 split cord malformation. Primary neurulation defects are common meningomyelocele and encephalocele, which we encounter in day-to-day practice. As you all know, that there is a, sorry, it is going other way around. So the only thing is that we have to operate early, and early postnatal surgery in an open meningomyelocele, even it has some degree of skin cover, can reduce the disability, especially the hydrocephalus and Chiari, to a lot of extent. So it is we don't have an antenatal provision of an antenatal meningomyelocele repair in our country. So postnatal repair is one of those things that we should do very early. Again, skin closure, especially neonate, is an issue, especially for the young neurosurgeons who are really operating on very small infants. Be generous to take help of plastic surgeons. Be generous to do some flaps like VOI flaps or other rotation flaps, so that we give an adequate skin closure and avoid wound adhesions and CSF leak. The disjunction defects are due to defect in separation between the cutaneous ectoderm and the endoderm. And disjunction defect are of two types. If you have an incomplete disjunction, where you have a connection between the ectoderm and the neural tube which is separating from the ectoderm, this is a dorsal dermal sinus. That is, a cutaneous ectoderm goes to some extent and connects to the neural tube. And in a premature disjunction, while the mesenchyme gets infiltrated, while the neural tube is yet to close, so you have an intra and exospinal lipoma. This is a 3-year-old child present with progressive paraparesis with sharp deterioration and presented with recent fever and neck rigidity. As you can see, the cord is hyperintense from the lumbar to the cervical region with lot of adhesions and septation with gross changes in the kidney. So this is an infected dermal sinus leading to the intramedullary abscess, which is the most severe sequelae that you can have. So for a dermal sinus tract, if you operate as soon as you diagnose, and you don't leave it for any other investigation or the child to grow up. Other thing is to identify a case of limited dorsal myeloschisis. In the case of limited dorsal myeloschisis, as you can see that the dura is tented up like this. It is the neuroectoderm which is tented towards the ectoderm, cutaneous ectoderm. So always there will be a dural tenting. And many times previously, especially they were operated by pediatric surgeons as a simple meningomyelocele. But we now know that there is a entity called a limited dorsal myeloschisis. Only there is a tract that goes from the dural tube up to the skin. So while operating, you can just detether by dissecting away the tract from the over the dural tube. They presented various cutaneous abnormalities like this cigarette burn appearance as shown in the picture below, all in some cystic swellings like in which may be difficult to differentiate from an meningomyelocele. This is a common spinal lipoma. Again, the dilemma is that when to operate. Again, it has now been proved that if you sit on this lipoma for a long time, there may be an irreversible damage in bladder function. So we operate reasonably at the age of 3 to 6 months. There are various varieties of spinal lipoma, as you all know, and especially the transitional ones and the chaotic ones are very difficult to operate without a neuromonitoring. Those you can defer up to 6 to 8 months so that you can have an access to neuromonitoring for complete removal. And only important point that intraoperative neuromonitoring is heavily needed in this kind of lipomas, complex lipoma surgeries. And what is very important to identify is white line. The lipoma inside the spinal cord is like a mushroom. It goes in and then fans out. And you need to find out this white plane and dissect it radically from this plane. If you have a neuromonitoring, it is very, once you get the hang of it, you can easily differentiate and protect the nerve roots, and then we can completely take out the lipoma. To operate on a redo lipoma or a leftover lipoma is a big hassle. So the first chance, like any other, like all other branches of surgeries in neurosurgery, this is the best chance to detether. Another thing of lipoma surgery is that after excising the, I will take a 1 minute. Excising the lipoma, you have to do a 360-degree detethering, both in ventral and both sides, so that adequate detethering occurred. Secondary neurulation defects are tethered cord, terminal myelocystocele, and caudal regression syndromes. The first two can be easily taken care of. You all do every day, day-to-day practice. And tethered cords must be again operated as early as when detected for the fear of silent bladder dysfunction. And for the myelocystocele, it's a big surgery. The outcome is quite poor, but again, you can do a reasonable good job. And myelocystocele, since it's already have an hydromylia inside, this is very difficult, especially during closure. Again, you may have to ask for plastic surgical help during the closure of a meningomyelocele. Caudal regression syndrome, as you all know, comes as with a plethora of anomalies, plethora of anomalies, especially with agenesis of sacrum and deformation of the pelvis. But with adequate rehab, they can usually carry a reasonable wheelchair-bound life. The complex spinal dysraphisms, as we see in any higher center, are quite common, where we have all these embryogenetic, the combination of these embryogenetic malformations. So once you know the embryology, you can have a lipoma with a split cord. You can have a lipoma with an LDM. So that to study the MRI, you do a good quality MRI. If the first MRI is not a good quality, you repeat a 3-test MRI. You enlarge it in your camera or a monitor, study, and read it before you go in and plan your surgery accordingly. Again, these are some pictures of complex dysraphism. We require a team to handle all these spinal dysraphisms. A neurosurgeon cannot do this alone. And remember to do ultrasound KOB in all cases and take help of the nephrologist is required. Since the postnatal surgery is not done, antenatal surgery is not done, what we now advocate is to correlate with the gynecologist and do an antenatal counseling in antenatally detected spina bifida cases, plan a seizure, and then transfer to the nearest neurosurgical center on the next day and operate the day after. That is on the day 2 of the birth. That is the best we can offer in our setup, that is in Indian setup, that we should all try to practice. Thank you for your kind attention, and I welcome all of you to the NSI Con 2024 in December in Calcutta. Please join us there.
Thank you, Dr. Kaushik. That was a very nice presentation on the embryological basis of the disease, which is actually very difficult for many people to understand. You made it very simple. We will take the questions at the end for you. Now I call upon Dr. Naveen Mehratra sir to present his talk on pathophysiology of tethered cord syndrome.
Can I make some announcement? So people who finish in time, 10 minutes, they'll have the question immediately, 2 minutes. People who cross time at the end. Okay. Starting. So respected chairpersons, dear friends and colleagues, a very warm welcome and a good afternoon to you. I think after this spinal dysraphism, we go on to tethered cord syndrome. So what is tethered cord syndrome? So tethered cord syndrome is a stretch-induced functional disorder of the spinal cord that typically involves the lumbosacral cord due to the fact that its caudal portion is anchored by an elastic structure. So how does this happen? Stretch phenomena. So usually the spinal growth is more than when the spinal cord growth, then it happens, or there is a forceful flexion and extension. So as we have seen by Dr. Kaushik, so spinal dysraphism and tethered cord are the two very loosely used terms. So that's why the tethered cord is classified or categorized into three. The category 1 is a typical tethered cord syndrome in which the symptoms are produced on the traction of the cord because of the tethering side which is above, which is below, and the contracting side which is above. And usually the symptoms are reversible, and this is the type 1 which we are going to discuss the pathophysiology for it. Then examples are classical, the thick and fatty phylum which we have seen. The category 2 in which the neurological disorder lies between L1 and S1, and the symptoms are because of tethered cord as well as because of the disease per se at the local effect. And the results of when you operate are partially reversible, and they may require multiple surgeries to untether. The third category is, which is usually see when we see the reports, are of that of the patients with myelomeningocele, which have got a higher level, and the patients are paraplegic with incontinent. So these are not to be considered as tethered cord. So now what is the pathophysiology? So the basic pathophysiology is an impaired oxidative metabolism which causes the electrophysiological changes within the cord. So what is oxidative metabolism? So oxidative metabolism is a simple chemical reaction which happens in the mitochondria of the cell to produce energy or ATP. So what is the role of that ATP? So that ATP, the neurons are very active cells and they require this ATP for the normal neuronal function as well as cell survival. So whenever there is an impairment in the oxidative metabolism, it causes pathophysiological changes which results into the impairment or the functions. So the basic is mild to moderate spinal cord tethering will produce symptoms of pathophysiology which is likely to be that of an hypoxemia, and prolonged stretching will produce symptoms which are likened to that of prolonged ischemia. So what happens is, if this oxidative impairment is happened, can we somehow measure or quantify it? Yes, we can do it. So whenever there are changes in the oxidative metabolism, they are signaled by recording shifts in the reduction oxidation ratios. And these shifts can be measured non-invasively by reflection spectrophotometry. So what happens when these oxygen is reduced? What happens? The cytochrome A and A3 is reduced, and the ratio of between reduction and oxidation it increase, and the oxygen energy production is reduced. So what happens is, during the oxidative metabolism, which happens in the mitochondria, they use cytochrome A and A3. It is the domain where oxidative metabolism happens. So whenever there is any changes, their quantity reduces. So in hypoxemia or in ischemia, when the number reduces, in hypoxemia, if it is mild to moderate, it reverts back when we do surgery or when these conditions are reversed. And if the ischemia is prolonged beyond 10 minutes, normal recovery is usually not possible. So now how do we see that? We have done the experimental studies in which the CAT model has been used and the acute traction has been put. And what they found is, when they put low traction, that is around 2 grams, there was a small shift or reduction in the cytochrome A and 3. And when this traction was removed, the oxidative shift went back and the normal recovery happened. And when they increased the traction or weight to 3 to 4 grams, there was again reduction in cytochrome A and N3, but was moderate. But on removal of the traction, the recovery eventually happened. But when the traction was increased to 5 grams, so there was a prolonged reduction in cytochrome. And then even when the traction was removed, the complete recovery was never happened, or it was an incomplete recovery. So since we know that tethered cord is a chronic phenomena, so what happens if we do a chronically traction or increase the weight?
So the similar experiments were carried out in the cat with a 3 and 5 gram weight, and they observed the behavior at 1 month, 3 months, 6 months, and 9 months. So what they observed that the cats with 3 gram weight, they recovered much earlier than with the cats who had a 5 gram weight, and the restoration of the mitochondrial activity paralleled with the physical reactivity. So if we have a physical activity and we can parallel it with the mitochondrial activity, so that is how we can physically say or say that this is an improvement. And the cause they have put as plasticity is the one that plays a role in the recovery of that. So what are the observations? So observation was that the greater the traction weight, the greater was the elongation of the spinal cord. And the more than the elongation of the spinal cord, the phylum was greater, which increased in length on the size when the traction plate was put as compared to any cord segment. And traction produced no elongation in the spinal cord, which was cephalic to the attachment of the lower paste of the dentate ligament. So this is important in the clinical symptoms, which I will be saying in the subsequent slides. Another thing, what they observed in the light and electron microscopy, there was no histological evidence of cell damage. And the metabolic and neurological dysfunction, they reversed when the untethering was done. And similarly, they also observed the glucose metabolism was altered in patients in the experimental animals when the cord was tethered. So how do we explain the pathophysiology and the clinical symptomatology? So there are a few things which are very peculiar for tethered cord. And the one is why lesions are restricted to the lumbosacral cord. So the impairment of the oxidative metabolism and elongation of the spinal cord in the animal model was found only below the attachment of the lower pair of the dentate ligaments. And typically it happens in the humans between T12 and L1. The second thing is why does incontinence become irreversible or before the earlier and motor sensory dysfunctions used to get. So the conus medullaris is the most vulnerable to traction, and because of its proximity to the caudal fixation, that is the segment of the cord gets usually affected, and after repeated repeated stretching, it shows the histological damage. Then the third question is, why are sensory deficits often distributed in a patchy pattern? So tethered cord lesions are mainly located in the gray matter where 90% of the mitochondria are found. And in experimental studies it has been shown that with deoxyglucose, they have demonstrated that the intact function of the white matter. So once the white matter is intact, the sensory symptoms usually do not manifest or they have a clear-cut level. Then why do symptoms vary in intensity as they progress? So what we have seen is that the patients who have tethered cord, after some activity, they deteriorate, but when they take rest, they usually improve. So what they have found is that after the insult or the stretch, there are areas of degeneration, but there are also areas of regeneration, which usually explains that why the recovery happens. So if the patient or the child takes rest, the patient usually improve. Then comes why are scoliosis and exaggerated lumbosacral lordosis common in tethered cord syndrome? It has been seen that the spinal cord remains in the least intermedullary tension when it is just in the concave manner. So that is the position or scoliosis develops because of the adjustment of the paravertebral muscles to maintain that posture. So to conclude, the pathophysiology of TCS is or the tethered cord is associated with impaired oxidative metabolism in the affected spinal cord. And this interpretation is supported by studies of mitochondrial redox activity, impaired glucose metabolism, and decreases in blood flow, and deterioration in the interneuron potentials, which has been experimentally detected in the tethered spinal cords of cats and cat models. So cords in the patient with TCS, they show similar mitochondrial and neurological changes. Thank you.
Thank you, Dr. Naveen. Excellent presentation for the biochemical aspects of the tether cord. Any questions from the audience, please?
See, the trophic ulcers and trophic changes are quite common with the tethered cord, unlike other conditions. Do you have any specific explanation for that?
So the trophic ulcers usually they are, if you see, sir, this is the typical type 1 tethered cord syndrome, which is classically we have a fatty phylum or a caudal. So we usually see these patients who have got a myelomeningocele at a higher level. So in that size, that is the category 2 or category 3 are there. So what I've explained typically is the TCS, which is category 1. So in those patients, we usually do not get these trophic ulcers.
Neurological reasons, not interested in which group.
Mm.
But,
Yeah, in those patients, what have they seen that usually they usually do not have the viable neurons. They are usually being replaced by the dead or fibrous tissue. So that is why there is no sensation and they develop these trophic ulcers, sir.
Now, you said scoliosis is a protective phenomena, but scoliosis should increase the length of the cord. No, stretching should.
No, sir, what happens is that normally when we either the cord can remain straight or it can remain along the concave portion or it remains along the convex portion. So studies have proved that when it remains along this concave portion, that has got least intramedullary tension. So once it attains this posture, so these muscles, they go into this posture to facilitate this concavity. So the length overall doesn't, that is the tension which remains the least in this posture. So that is the reduction of the tension.
So it is something as similar to in a 400-meter race. They do not make them stand in a single straight line. They make it in an oblique way. So that is the actual simplest explanation for why the scoliosis occurs in case of this tethered cord syndrome. Then it is a natural phenomena which is there for short period of time, and when it exaggerate, it itself become a menace. Any other questions? So Muthukumar.
With the pressure source, I think he pointed out the stretching experiments which Dr. Naveen pointed out refer to Yamada's experiments where the mild and moderate stretching produces reversible changes in the spinal cord, whereas severe stretching or prolonged stretching produces irreversible changes. So most of the pressure source are due to prolonged or severe stretching, which are irreversible. The clinical implication of that experiment which you quoted is that mild and moderate neurological deficits, mostly mild, some moderate neurological deficits are reversible. Severe neurological deficits like pressure source, fixed foot deformities are not reversible. And as far as scoliosis, there's a lecture at the end of this particular session.
If there are any more, no more questions, thank you, Dr. Amin. I invite Dr. Suchananda Bhattacharji to speak on disorders of secondary neurulation.
First of all, I take the opportunity to thank Dr. Savither and Manasa for this opportunity. I know how hard they're working for this conference, and this is a vast topic, and I may overshoot, but I'll try to keep in time. So just to give an overview of what neurulation is for the younger friends, it's the formation of the vertebrate nervous system in embryos. The notochord induces the formation of the CNS by signaling the ectoderm evapate to form the thick and flat neural plate. The neural plate then folds on itself to form the neural tube, which will then later differentiate into the spinal cord and brain. That's what all of us know. So it happens by two mechanisms, primary or the secondary. In primary, it increases inwards until the edges come in contact and fuse. And in secondary, the tube forms by hollowing out of the interior of a solid precursor. So that is what it is. So these are the two diagrams which we have seen for ages. So let's concentrate on secondary neurulation. That's my topic. So you can see this. We have something. Anyway, doesn't work, I think. So this secondary neurulation, these cells, they'll finally form the rest of the spinal cord. There are 4 stages if you look at it. First, there will be a solid cell mass, and then all the cell mass will become vacuolization. They all will become a single tube like this, and then they will be they will form a cord-like thing. Then from this, the part of the caudal cell mass undergoes retrogressive differentiation, and then finally they differentiate to form what we know as phylum terminal or terminal ventricle, the tip of the conus medullaris sacrum, and the coccyx. These are all formed by anything below the S2, we have to know is formed by secondary neurulation. A ventricular terminalis of the central canal, if found in very young and in the fetus, they are not abnormal. They are a normal thing which we have to keep in mind. So, as we all know, this statistics 1 in every 1,000 established pregnancies can have a neural tube defect. And there were landmark papers in 1949 where they said that it was a multifactorial etiology, but now more or less it is said there is a multi-gene predisposition together with the role of environmental factors such as diabetic or folate status, which are responsible for neurulation defects. So, what are the defects of secondary neurulation? We have to understand this from an embryological perspective. There could be failed junction with the primary neural tube. There could be hypoplasia or arrest of secondary neurulation at a certain level associated with disturbed activity of the mesenchymal tissue. There could be duplication of the cell mass. There could be failed ingression of the primitive streak. There could be focal limited dorsal neurocutaneous dysfunction. There could be neuromesenchymal adhesions or failed regression spectrum of the medullary cord. So I'll go one by one. What happens when there is a failed junction with the primary neural tube? There could be a junctional neural tube defect like here, and then here, see, this junction is free. They did not meet each other, the primary and the secondary neurulation. Stenosis of the surrounding bony structures called segmental spinal dysgenesis, or there could be arrest of the secondary neurulation. So there could be vertebral bony defect, there could be failed formation of the spinal cord with blunt corners, retained medullary is a regression of the spectrum of medullary cord, hypoplasia of the caudal mesenchymal tissues, which can lead to other things like anorectal, genitourinary, and abdominal wall abnormalities. Now, there could be even duplication of the caudal cell mass, what we have seen, where they will lead to focal double vertebral columns. Hyperplasia of midline caudal mesenchyme will lead to septum formation in the hindgut, and if there is a lateral caudal mesenchymal tissue, there could be other like anorectal, genitourinary, and abdominal wall anomalies. So failed ingression of the primitive streak, if it happens to the caudal streak, then you get a transitional myelomeningocele. And if there is an ingression of the distal medullary cord from ruptured terminal balloon, you got a caudal or terminal myelomeningocele. Pulling of the medullary cord towards the surface, which we commonly see, is, as Kaushik has also mentioned, is called limited dorsal myeloschisis, whereas pulling of the surface ectoderm to the medullary cord side is called a congenital dermal sinus. So now next defect category is neuromesenchymal adhesions. When there is adhesions with the cranial part and the distal part of the medullary cord, you can get a lumbosacral lipomatous, what we call it lipomeningocele of transitional type. If it is at the tip of the medullary cord, you get LLM of the caudal type. And if it is of the pulling of the attachment to the neural site, and there is also a regression of the medullary cord, you got the LLM of the filar type. So if there is now failed regression of the spectrum of medullary cord, then you get all the problems related to the phylum. Like you have a thick phylum, you can get a filar cyst, and at the stage of medullary cord attached to the sac, then you get a retained medullary cord. It could be either cystic or the non-cystic type, or you can get a retained medullary cord with low-lying conus. You can get a terminal myelocele, or you can also get a terminal myelocystocele. So now retained medullary cord. This is a new thing which everyone talks about, and this has been described only after the neuromonitoring era has come. It's a robust, it just looks like the spinal cord structure that continues to the cul-de-sac. Simply, it looks like a low-lying conus, which we see, but it has a non-functioning component. The non-functioning conus is indistinguishable from the functioning conus on neuroimaging, or even when you open up in surgery. It's only the intraoperative neuromonitoring which will say whether there is a signal or there is not a signal. If there is no signal, it's an RMC. If there is a signal, it could be low-lying conus. So that is the most important thing which you need to say. And these RMCs are known to present with spinal stigmatas like the craters, the hypertrichosis, hemangioma, skin tag, dimple, etc. All those which you see in split cord malformation as well. So, but the main point is that MRI or open field doesn't say. The IONM only identifies based on electrophysiology whether it is a low-lying cord or this one. So there are various types. It could be a normal type, or it could be a tapering with an enlargement, or it could be an hourglass type. There's a conflict here. Some may call it a junctional defect, but it is also an hourglass shaped, has already been described. Then retained medullary cord. These are the various types which can see So because of time, I will not be saying. But let us know the difference. What is important for us to know is that RMC, the shape of the corners is altered, but in tight phylum, the corner shape is unaffected. It could be a low-lying conus as a differential diagnosis. It could be low-lying or a normal conus in tight phylum, usually associated with tethered cord syndrome, usually associated also with tethered cord syndrome. Histological findings will show a glioneural cord along with fibrofatty elements and ependyme-aligned central cavity. Whereas in tight phylum, there is no evidence of any glioneural elements. So limited dorsal myeloschisis, my friend Kaushik has already said there are two types. It could be a normal one or a secular type. These are the two types, two varieties. You can see a normal streak-like thing where the cord is pulled towards the ectoderm, and here it could be the secular things that could be of various types of secular shapes, which could of the various types. So the major differential diagnosis for LDM is a congenital dermal sinus. Both are closed. It is a closed defect, that is an open defect. Fewer chances of infection for all reasons known. The dermal sinus has more chances of infection. Intrathecal thects clearly visible in LDM, whereas not visible in dermal sinus. Clearly seen as hypointense round structure added to the dorsal aspect of the spinal cord. Attachment variable and not clearly visible. Dorsal tenting of the spinal cord seen almost in all the patients, whereas it's hardly seen in a sinus. Tethering is more common. In dermal sinus, tethering is less common. Dermoids and epidermoids, as we know, are associated with dermal sinus. So this is an example of this one by from one of my friends. I took this slide and of an LDM. And this is a sign where you can see besides that there is also a dermal sinus. And on surgery, it was like just a third up to the dura. So myelocystocele, this again a defect of secondary and usually results from defective secondary neurulation that affect the CSF flow dynamics. The inner terminal syrinx communicates with the central cord of the spinal cord. There are some examples of myelocystoceles like this. And then let's come to LLM, which could be of various types. Is beyond my this one to describe each one individually, but you can see the diagrams. It could be this. These are the ones, this, or these are the various types of LLM. And you can take this as a pick to know what are the various types of secondary neurulation defect leading to LLM. So these are the various classifications which you can refer to from the literature. And these are some examples. I'll skip that since I am out of time. So this is a case of a terminal lipoma. Again, this is a case of a terminal lipoma with dermal sinus. Then tight phylum terminal. Again, that is already spoken, shortening and hypertrophy of phylum terminally. There's a retrogressive differentiation defect, and on imaging it is by the thick phylum due to fibrous or fatty infiltration. You can see the fatty streak over there in this T1 weighted image. So that could be a phylum terminally or a junctional dysraphism, sorry for this. And so this could be the stigmatas which I spoke about, which you can as well see in retained medullary cord. And these are some examples I'll skip through. Now this is a cortical regression syndrome, which is common. That is type 1 and type 2 are the different types, and both are there will be a sudden abrupt end of the spinal cord as high as D12, and there's an association of vertebral ablation in most of the patients. An abnormal part of the caudal sinus is unaffected in true notochord formation, but in fetus also you can find it out when you see a low crown rump length, and at the later stage there may be you can find this V pattern and diagnose a caudal regression syndrome. Very rare, but I just have seen 2 cases so far. Unfortunately, I did not have the images. Sacral agenesis given by Peng's classification into 5 different types. Segmental with caudal regression, they can affect combo defects can always happen in all the spinal dysraphism. This is here you can see hemisacrum with other defects. And in conclusion, I'd like to say that understanding of secondary neurulation is still evolving. Correct identification leads to better prognostication. Surgical treatment is the management of choice as of now. Asymptomatic incidentally observed also needs to be explored. Case registry and dissemination of knowledge is required, as this cannot be reproduced and studied in. Thank you.
A little time, so I have a question. I just like to know what is the relation with the ACM in secondary neurulation case. Evidence of malformation.
Tell you whether it is more or less. I did not come read any literature on that.
I think I'd like to move to the next one. Split cords malformation by Dr. Raghavendran.
Morning, everyone. Pleasure to be here, and I thank Professor Manas sir and the organizing team for giving me this opportunity. Today has been given as split spinal cord. But what pathophysiology, the types, management, why the difference between the types 1 and 2. Looking at the epidemiology, rare 4 to 5% of all congenital spine anomalies seen in 1 in 5,000 births. Usually stable, it is considered as stable with a female preponderance and 2 peaks of age of presentation 4 to 7 and 12 to 16, and it constitutes almost 1/3 of all spinal dysraphism surgeries. And this is what basically it is. The type 1 has 2 dural tubes and 2 split hemicords, whereas the type 2 has a fibrous septum with a single dural tube and 2 hemicords. May be symmetrical or asymmetrical depending on the. So my references are this one from the AIMS paper, 300 cases at AIMS for 16 years of follow-up. In the Panks paper, 3,000 complex spinal cord malformations, of which 185 they are seen as of mixed types or composite types. So the type 1 has a bony septum with the 2 dural sacs and 2 hemicords. And it is a bony septum. It's most common in the lumbar region, followed by thoracolumbar region. Whereas the type 2 has a fibrous septum. It has a single dural tube with the 2 split hemicords, and is a fibrous septum. And myelomeningocele monkey, which has now been considered as dorsal bands, they can be present intra or extradurally. They are nothing but the non-functional paramedian nerve roots with a fibrovascular bundle, and it is very essential to look at the MRI critically to locate any dorsal bands, and that has to be released. Otherwise, the detethering is not going to be complete. And most of the cutaneous markers, you can see hypertrichosis is most commonly seen, almost 60%. When you see a fawn style, it is specific. The other things are dermal sinus, subcutaneous lipoma at various percentages, sacral dimple. Most important aspect is the sacral dimple has to be a significant sacral dimple. You cannot take this, the usual dimple that is seen in the coccygeal region as a sacral dimple. It has to be a significant one. And all these cutaneous markers are actually non-specific, but they indicate definitely there is an underlying spinal dysraphism. The clinical symptoms varies in adults. Backache is seen in 30 to 50% of patients, whereas the most common presentation in adult is progressive neurological deficit. Urinary retention and incontinence is seen from 1/4 to 1/3 of the patients. Pain and hyperesthesia is seen in 10% of the patients. And associated findings, when we look at an later age of more than 10 years, 70 to 75% of patients will have abnormal urodynamics when tested, have motor or sensory asymmetry between the left and right side that is seen in almost half of the patients. And many patients will have what is called as the neuroorthopedic syndrome. It is a triad of limb length discrepancy between the right and left, associated with muscular atrophy and also clubfoot. The defect is usually symmetrical, but it can be asymmetrical also in certain situations. The left and right asymmetry, the limb size and length discrepancy is seen in 12 to 15% of the patients, and the smaller limb is usually associated with the smaller ipsilateral cord. When the neurological deficit is asymmetric with no limb length discrepancy, then it usually indicates the presence of a hydromyelia in one of the hemicords, and clubfoot again is seen in 15 to 20% of patients. Other associated anomalies can be low-lying cord, kyphoscoliosis, syringomyelia in 25 to 40%, along with fatty phylum, dermoid cyst, dermal sinus, neuroenteric cyst, and lipoma. As per embryology classification, it is a problem of the gastrulation and not neurulation. It's an error of gastrulation. As already mentioned, it is the problem in the trilaminar layer formation, where you can see here, this is the type 1 formation, there is an adhesion between the ectoderm and the endoderm, which results in two heminotochords. They progress to form two hemineural tubes, and the mesenchyme comes in between, forms a layer here, and then the cells from the meninx primitiva come into the picture. These cells of meninx primitiva actually cause this formation of the medial dura, which is the most important structure in a split cord malformation, also the lateral dura, and also forms the bony spur along with an hypertrophic neural arch, which is usually seen in as type 1. So it is these meninx cells are incorporated into the endomesenchymal tract, whereas when you consider this type 2, it is too late for the meninx cells arrival, so that they are not incorporated in the endomesenchymal tract. So there is a formation of a single dural tube with a fibrous septum in between, because it arrived late, and there is, most importantly, no hypertrophic. It is a normal neural arch that we can see. What about the ectodermal derivatives in type 1? They are dermal sinus tract, but they usually attach to the bony spur and are not the cause for tethering. There is no tethering effect. May have dermoid cyst, but it is always in the extradural compartment. Whereas in the type 2 variety, it always attaches to the fibrous septum and is a significant contributor to the tethering of the cord. And also this dermoid cyst in type 2 is always intradural and can present with cord compression and myelopathy symptoms. So clinically, it can vary from no deficit to motor, sensory autonomic trophic ulcers and spinal deformities, and we can have this spine deformities and kyphoscoliosis. So imaging we have to do, as already dealt, MRI, brain. Type 1 we have to do. This is type 1. This is type 2 where we have seen, and this is a composite SEM where we can have the fibrous strand along with the bony spur that differentiates. The associated things may be lipoma, dermoid and epidermoid. And coming to the management, is prophylactic or should we wait for the symptomatic? If you look at this, the short-term studies, follow-up studies have maintained that there is no difference between the operated group and the non-operated group in asymptomatic. But if you look at this carefully for type 1 SCM, over the years, this is a 40-year period follow-up, definitely they go from grade 0, which is normal, to severe weakness and bladder involvement, which definitely says that prophylactic management is indicated in type 1 and also in type 2. This line, the linear may not be as steep as in the type 1, but yes, over a 40-year period follow-up, many patients develop this grade 3 severe weakness and bladder involvement. And this is basically the surgical technique. This is the sacral dimple. This is a significant one. It gets attached to the bony spur. It doesn't go into the intradural compartment. And this is after the removal of the cyst. And we finish the drilling of the bone completely as much as possible extradurally. Then we open the dura and then proceed with excising the medial dura. That is the most adherent part that may contribute to the tethering. And if you look at this, this is what is. What is attached, the medial dura that has to be removed in the median cleft. And this has to be taken out and drilled out completely if there is a residual in the intradural compartment. And this is the picture after completely drilling out the bony spur and the dura is reconstructed into a single tube. When you come to the type 2, fibrous septum on many occasions can be attached to the anterior dural wall, in which case if it is not removed, then the detethering is not going to be complete. So this is the fibrous septum which has gone into it with the split cord that has to be removed. More importantly, you need to look at the MRI carefully to look for these dorsal bands or myelomeningocele monkey. You can see here, it is one band which is attached to the dorsal region. There is another band here which is attached to the dorsal region. This is another band. These things have to be definitely removed or cut, and otherwise the detethering is not going to be complete. And as also, this is one of the case, a rare presentation. Patient presented with myelopathy, had a type 2 malformation. There is a dorsal band which was compressing the spinal cord. And after excision of the dorsal band, you can see that dimple which has been caused by the compression, and the patient recovered completely. And I make it a point to always remove the phylum terminal, lest it should not cause retethering at a later date. The take-home message is, split cord malformation surgeries are tolerated well. There are very fewer complications. Neurological worsening in the post-operative state is very rare, except in cases where there is a retethering because of inadequate detethering done during the first surgery. As previously mentioned, the first surgery is the best choice. Bowel or bladder symptoms may remain stable or may improve, but pain relief is always good. And the vertebral deformity, as has been previously mentioned, at some stage usually progresses and spinal fusion may be necessary at a later date when it is indicated. Thank you so much for the opportunity.
That was a very nice presentation, Dr. Raghavendra. Any questions from the floor? So I'll ask you one. You very nicely mentioned that the initial drilling or complete drilling has to be extradural.
Yes, sir.
Any other precaution or any other caution that you take or inputs from the scans that you take from the cranial end or the caudal end as how you want to drill the spur?
Usually, sir, the top-down rule is what I follow. The top-down rule is I start drilling from the superior aspect and slowly come. Always, when we drill, the cord slowly gets ascended up. But of course, it doesn't come immediately. I do a top-down drilling. The other aspect is I always look for the dorsal bands. And the third thing is, sometimes I've seen the medial dura is attached and adherent to the medial aspect of the hemicords. That has to be detached. And even if he had completed the drilling of the bony spur extradurally completely, after opening the dura, you sometimes tend to see that there is a small residual bony spur at the inferior most aspect. So that also has to be taken care of. And of course, IONM is a must nowadays.
Have any policy about timing of surgery?
So timing of surgery, as I have mentioned earlier, the surgery, the possibility of worsening is definitely avoided.
Fairly.
Usually wait for 3.5 to 4 kgs for the child to develop. That is what we have. We go by the birth weight.
I got a technical question I want.
Yes, sir.
How about the dural closure? Because when we sometimes take the dorsal dura, and also sometimes we also open quite a bit of ventral dura. The dural closure at the end of the surgery after the detachments. Do you like to say something on that?
So the dural closure, there are two things we have to do. There is an anterior defect also on most of the occasions. The posterior dorsal dural closure is not a problem. Many times it is really difficult to do that anterior dural closure. And I have had a few cases where the child developed CSF leak, and almost all these patients have settled down with a lumbar drain over a period of 48 to 72 hours.
Yeah, see one point, because earlier we were trying, initially I was not having that experience long years ago. Then we started doing the fascial lata. And after this, we still to cover it with the fascial lata on the ventral aspect. Tug it and tug below the, I'm talking about ventral to the cord, straight cord, and then put back. That worked out very well. This is very old technique. But now recently there are so many materials are coming out, but I'm not sure about it, how they are.
No, so generally I don't use those materials. The problem there is when the medial dura is adherent to the medial aspect of the hemicord, we don't get that much to do an anterior dural repair. That is where it becomes difficult.
They're more adherent.
Yes, more adherent. If they are less adherent, you do have a flap.
Yeah.
Then it is easier to do an ventral dural closure. But generally I don't prefer to use this additional materials like fibrin glue and other things. Usually they settle down with the lumbar drain, sir. That's what I have seen in my practice.
Do you follow the criteria of 3.5 kgs even for SCM type 1, where you have this bony abnormality, you have to drill, it might be a long surgery, blood loss? Because recently I got a child with SCM type 1 and there is a very thin meningocele. So what advised is we do the meningocele repair first, and then once the child is about 5 to 6 years, 6 months, we can do the bony stuff. So I just want to know the timing for type 1s.
As far as the blood loss is concerned, I don't think that is an issue. We have never had an issue with the blood loss. That is one thing. And generally we take it up. 3.5, 4 kgs, maximum 5 kgs. But the mother has to be diligent to identify it at that particular age. Mostly it is the non-identification they present to us at a later date.
comfortable you are?
Sir, we have used, sir. We have used.
Do you use lumbar drain even distal to the closure, or you
Distal to the
use,
closure, sir.
I mean, proximally, like a
Distal to
dorsal
the
cord or
closure, sir.
something?
Distal to the closure, sir.
Thank you, sir.
Thank you.
The next speaker is Dr. Venkatesh Raju from Coimbatore. He will speak on spinal dermal sinus.
Respected Chairperson, senior colleagues, and dear friends, very good afternoon. At the outset, I thank Professor Manas and his organizing team for giving me this opportunity to share my experience on one of the uncommon form of occult spinal dysraphism, that is the spinal dermal sinus. The literature reports the incidence of 1 in 2,500. Though it looks simple, the early diagnosis and management of associated abnormalities is very essential in this disorder to avoid a catastrophic complication at a later stage. So, in a more simplistic way, the embryology, the formation of the whole neural axis, can be divided into two broad categories in the primary and secondary neurulation, where in the primary neurulation, the neural tube formation occurs at the age of 3 to 4 weeks of gestation. And in a secondary neurulation, the caudal cell mass forms the caudalmost part of the neural tube that occurs in the 5th to 6th week of gestation. In little bit detail, the area of surface ectoderm overlying the notochord thicken and forms a neural plate. This produces further forms into the shape of a groove, and further dorsal bending creates a tube. So the formation of the neural tube is primary neurulation. During this stage, an area of focal fusion of failure and non-disjunction of surface ectoderm with the underlying near normally formed neuroectoderm produces this dermal sinus tract. So this tract is obviously gets lined by a keratinized stratified squamous epithelial cells. Similarly, a focal failed fusion of a neural tube with the near normally formed surface ectoderm and an area of disjunction produces a tract of the limited dorsal myelochysis. So obviously this tract consists of glioneural structure. Sometimes the mixture of these abnormalities can coexist. Similarly, this focal non-disjunctional disorders can coexist with premature disjunction and disorders of aberrant gastrulation, so that a lipoma, a split cord malformation, and a neuroenteric cyst can coexist with the spinal dermal sinus. These abnormally formed tracts usually gets noticed before the age of 3 by the presence of a cutaneous manifestation. Usually a pit, a sinus is the most frequently associated malformation, and it is frequently associated with the surrounding hyperpigmented area. Sometimes hemangioma, a skin tag, and subcutaneous lipoma and hypertrichosis can be the presenting manifestation. The 40% of the patients may present with the neurological deficits. In 25% of the cases, the discharge from the ostium may be the presenting manifestation. Sometimes local inflammation, abscess formation, and recurrent meningitis may be the presenting features. Coming to the location, in 60% of the patients, the sinuses are seen in a lumbar and lumbosacral region. The remaining is equally distributed between the thoracic and cervical region. So we can see sometimes these sinuses are very faintly visible, and this is a fairly visible sinus, and occasionally the sinuses are very obvious by these cutaneous manifestations. This is one of the rare occurrences where there are two dermal sinuses in a patient, one in a cervical and another one in a dorsal, lower dorsal region. The MRI showed a intramedullary dermoid in the lower dorsal region, and extramedullary intradural dermoid in the cervical region. Depends on the location of the external sinus, the direction of the tract varies. In a case where the sinus is in the lumbar and lumbosacral region, it usually takes a shape of a V, where the tract descends from a skin location to the interlaminar location, then it gets ascends and ends in an intradural location. In the thoracic region, it usually takes a horizontal direction. In the cervical and region, the tract is usually either upward or a horizontal direction. So we need to look a sagittal MRI to track this tract, because we have to remove the whole tract to prevent a recurrence. Even these sinuses are indolent or asymptomatic, we have to treat these patients because the tracts are lined by the keratinizing stratified squamous epithelial cells. It secretes a material which gets accumulated in this tract and sometimes forms dermoid cyst. So this material often gets inflamed either by the chemical nature of this accumulation or by the secondary bacterial infection, so that it will produce a irreversible damage. So we need to treat this disorder once it gets diagnosed. So before treating these patients, all patients should go a proper evaluation. For this, the MRI is the gold standard. So we have to image the whole neural axis to not to miss any associated abnormalities in the whole neural axis. So in some cases, it is necessary to use a contrast. This is an axial MRI where we can see a tract which goes into the intradural location. The MRI is very useful in demonstrating the tethering of the cord. Further, it is very useful in demonstrating the dermoid and abscess formation associated with it. Sometimes it may reveal other abnormalities. This one is a neuroenteric cyst where the tract goes into the canal, and this cervical cord is compressed by the anteriorly placed cyst. Coming to the surgical technique, two important principles is very essential. One is to completely we have to untether the cord. The second one is we have to remove the epithelial elements in total to prevent the recurrence. In achieving this point, this surgical exposure is very essential. So the whole length of the tract should be exposed from a cutaneous level to the intradural location. So in achieving this, we need to do a laminectomy adequately. So the wider laminectomy is essential in cases those who are presented with a dermoid and epidermoid cyst to prevent instability at a later stage. Sometimes we can do either we can do a laminoplasty or skip laminectomy. The most important part of the surgical procedure is the intradural exploration. Every patient presenting with this defect has to undergo a intradural exploration to detether the neural structure and to deal with the intradural lesions. In some cases, if there is a thickened phylum terminal is present, we need to cut that. So that to achieve that, we need to have a proper caudal exposure. Ideally, all these patients should be operated under microscope. In cases where it is necessary, we have to use intraoperative neuromonitoring also. So when a surgery which is properly performed in a case where there is no intradural epidermoid and dermoid, it is usually uncomplicated. This is we have applied a elliptical incision around the ostium, so the tract is traced to the interlaminar location. The tract is entering into the dura. After opening of the dura, we can see the termination of the tract over the neural structure. Then dividing the tract, there is a raw area was created. So if it is very large, then we can do a reneurulation with the 6-4-prolin to prevent a retethering. This one of our video where the tract is being explored and it is ending on the intramedullary dermoid cavity. So for want of time, I am skipping that. So even in surgery is properly performed, the outcome is depends on the neurological status during the time of presentation. So those who presented without deficits, they will remain neurologically intact, and those who presented with a deficit, 2/3 will improve and 1/3 will they remain stable, even though there is no improvement. So this is our experience. We have 21 patients during 2006 to 2023. Almost all our patients underwent a proper evaluation. So we have operated all our patients. We had 15 patients in a pediatric age group and 6 patients in adult age group with a male-female ratio of 1:1. So we encountered totally 13 sinuses in a lumbosacral location, 6 in the cervical and 6 in a dorsal and 2 in a cervical region. So all our patients had a tethered cord. So intramedullary dermoid we have seen in 5 patients. Of them, 2 presented with abscess. These patients operated in an emergency situation. All other patients were operated under elective manner. So before conclusion, I want to put these salient points. Every patient we should look for a thickened phylum terminal. So it has to be divided if it is present. If there is a dermoid cyst or epidermoid cyst, every attempt should be made to remove the capsule so that we can prevent a recurrence, because the risk of resurgery is more than the initial exploration. We have to anticipate extensive scarring. In some cases, that may be due to the previous subclinical infection. Though hydrocephalus is rare, sometimes it may be present because of the previous meningitis. Finally, these lesions to be differentiated from coccygeal pits where the management is totally different. At the end, we need a high index of suspicion in diagnosing these disorders, where these patients has to undergo proper MRI evaluation, and all the patients we need to do an intradural exploration to deal associated pathologies, because the outcome is related to the neurological status, the presentation. So all these patients need to be diagnosed at the early stage, and surgical management is an important part in dealing these patients. Thank you. Thank you for the opportunity.
Thank you, sir. That was a very nice presentation. There are no questions from the floor. We go on to the next talk by Dr. Ramesh, Lipomyelomeningocele overview.
A very good afternoon to the seniors and colleagues. At the outset, would like to thank Dr. Manas sir and Dr. Savit sir for the opportunity. It's an in-doubt case, Lipomyelomeningocele. As embryological classification is the most important thing to understand the surgical aspects and why and what to treat and when to treat. So, as most of our seniors have covered the embryo, I'll be very short in embryology. So, the 3 stages: gastrulation, primary urination, and secondary neurulation. So, a process of bilaminar disc forming into trilaminar is called gastrulation, from where the third layer forms and neural ectoderm starts growing. Neural folds forms the tube and gets disjunction. So same thing explained in these figures. So thickened ectoderm, which slowly forms a neural groove, which forms a tube, and it slowly this is normal disjunction. If there is a premature disjunction, then the mesenchyme enters. There can also be an incomplete disjunction. This mesenchyme enters too early to form. Right hand corner is the normal, where the before then this left hand side is the abnormal, where the averted lamina and the mesenchyme enters. So there forms the interface between the cord and the fat, subcutaneous fat. So three things to be seen. Is there any meninges herniation? Where is the lipoma and cord interface? So because in this you see lipoma cord, and then the lipoma cord interface is at the level of the spinal canal, not into it, and the meninges are normal. That is the reason it is called as lipomyelocele. If there is a herniation of meninges also, then we know called as lipomyelomeningocele. Sometimes there is only fat taken inside, so that is the dorsal lipoma. So these, as Suchanda madam rightly pointed out, that dorsal lipoma is the primary neurulation defect, whereas transitional and caudal are the secondary neurulational disorders. Same, this is only intradural, especially dorsal lipoma. So you can see here lipoma cord interface is at the level of spinal canal. So there is no meningeal encroachment, then it is called as lipomyelocele. Then another point to be seen is enlargement of subarachnoid space. You can see the interface is outside the canal and the enlargement of subarachnoid space and with the lipoma cord interface. It is called lipomeningocele or lipomyelomeningocele. Same thing. You have to see 3 points: expansion of subarachnoid space, where the meninges is also herniated, and where is the cord lipoma junction. So it was first described by Johnson, but it was termed lipomyelomeningocele in 1971. So it is incidence is 1 in 4,000 live births with a slight female preponderance. The most common presentation is the subcutaneous mass, fatty mass, usually non-tender, and superficial mass is usually lobulated and unencapsulated, where the deepest become fibrous. This is the cause for tethering. Other things which we can see is the hairy patch or the hemangioma, dermal sinus, in dimple. So symptoms are due to tethering of the tethering. What exactly happens? The tethering will cause limited cord movement, which during especially flexion extension of the back. This is a repeated limitation will cause chronic stretching, results in ischemia, results in neurological symptoms. So in infants, most commonly due to tethered cord syndrome, as they grow, then they have a orthopedic, neurologic, and urological issues. More higher the incidence is usually seen in the if the mass is towards one side, the incidence of deficits is more onto the ipsilateral to the mass, and elder the kid, chances of having muscle weakness and gait disturbances. So it can be associated with scoliosis, club foot, muscular atrophy, limb length discrepancy. So diagnosis is nowadays is done antenatally because of increasing use of ultrasound, but there is no communication, so there is no raised alpha fetoprotein level. After birth, ultrasound has a advantage of inexpensiveness, easy of use, and repeatedly we can use, and also have an ability to differentiate fat, spinal fluid, and spinal cord. But only disadvantage is our eyes should be able to see, that is operator dependent, and measles they can leave very small lesions. As you know, they can see any widening of the spinal canal or the occulta. So MRI is a diagnostic of choice. You can see T1, T2, especially cord interface, lipoma, whether dorsal, transitional, or the junctional defects, and especially to the extent of the lipoma, and also whenever associated with other lesions like dermoid and epidermoid. Urodynamics, especially in the elder kids, it will help. Not in children with they are not achieved toilet training, objective urodynamic functional assessment will be helpful. What it can be spasticity, it can be flaccid, it can be dysenergetic. 3 types: spastic, flaccid, or dysenergetic. So just a small. Everyone says urodynamic. What exactly we see in urodynamics is sphincter is seen when there is a command to void. Then the sphincter relaxes. So with the same time, the trachea starts contracting. Then this is called the have a flow. This is a kid, the 5-year-old with a Lipomyelomeningocele, they have detrusor overactivity. Once surgery, the detrusor overactivity decreased by 80 to 90%, and we have presented this in Tel Aviv in International Society of Pediatric Neurosurgery in 2018, along with Subodh sir. So what are the options left? Conservative, operate. So when if you are to operate, when to operate, and how much to resect. So we all know there's no conservative is more detrimental. So this article has clearly differentiated management that patients expected to have poor prognosis, asymptomatic and symptomatic. For symptomatic, there's no doubt you should go and operate. But patients expected to have poor prognosis who are children with other congenital major defects, poor general condition, and total paralysis of limbs, then it becomes more of a social value. Then attendance has to be taken into. Then symptomatic patients, there's no doubt because of the progressive tethering and neurological and neurological. So earlier the surgery, better is the outcome. Now then comes the asymptomatic. There are some people who says conservative, some people who says favoring surgery. Whoever says conservative says asymptomatic may become symptomatic. There are chance of surgical site, hydronephrosis, UTI, but but so many studies beyond doubt has proven that surgery is more helpful, and more the waiting time, the higher the chances of deficits. Preoperative neurological condition is more important. So surgical release is the most of the studies has shown that surgery is the good thing to be done than waiting. So even the workers are Keating and co-workers have shown more older the children, they have more urinary issues, and more by 5 years, 85% kids deteriorate. The better to operate is the child when child started sitting and having a flexion extensions. It usually happens around 6 months, or weighing 6 kgs. These are our, if you can see, this child came at 10 days with a subcutaneous mass. We told them to get operated, but if they come every once in a month, until the child now it has named in 2 years male, the rings has increased to the dorsal level. Now they have come for a rush saying that child had a weakness. So deterioration, if not operated, is a rule. So surgical intervention is a better outcome. Principal goals of surgery: to detach, decompress, and to reconstruct. Ionum has become a synonym. What we regularly use. We also monitor ANS and also sartorius, rectus femoris, gastrocnemius, as seen in the picture. So it's all tethering. So first you're just throwing to the surgical procedure. Of time will just to disconnect the fat, detether the cord, then closure with to prevent the SF leak. Circumferential dissection, try to achieve the plane, and near total dissection is warranted. If there is any ionum, then it is required. Run with because of lack of time. So one level above the level of the fat, so that we can see the normal structure first. Slowly disconnect all around and dissect the sac, remove the fatty. So slowly dissect the fat from the right and left side and reduce the burden. If there is any tethering, so leave the. If you feel that it is more detrimental, then a bit of fat can be left than causing a deficit, and closing appropriately to prevent, with having a good cord sac ratio is more important to prevent retethering. Just slip the video in view of time, but without intraspinal lipoma is beyond our presentation now. But just to complete, can be dorsal, transitional, and caudal. as shown. So just skipping the because of lack of time. This is a short video where lipoma has been. So very good article by the none other than Daxling Pang, which came out, which explained when to remove, how and why and when to operate. They say total resection is mandatory because it shows 98% resolution, but partial will cause 50% again retethering. So to give an opportunity, should always remove. And also having very good cord sac ratio prevents retethering. So early surgery is a better outcome. Always total resection mandatory if feasible, and good cord sac ratio. Thank you.
Thank you, Dr. Shigakuri. For want of time, I think we'll move on to the next speaker. Interesting urological evaluation of patients with spinal dysraphism by Dr. Arvinda Panda.
Thank you so much for giving me this opportunity. I'm a urologist among neurosurgeons here. So I'll be talking about the urological evaluation of patients with spinal dysraphism. The question again, why evaluate? Now, because of you all and because of your technique, long-term survival of patients with open spinal dysraphism is now routine. And without treatment, 10 to 50% of these will have abnormal upper tracts and renal failure, which remains even now the most common cause of death. So when you talk of neurogenic bladder, it's not a disease in itself, but a manifestation of these neurologic lesions. It's secondary to the dysraphism. And it's extremely diverse, heterogeneous presentation. It can present with simple loss of bladder contraction. On the other hand, you can have extreme overactivity, a very poorly compliant bladder causing renal failure. The long-term prognosis also is varied. It can be minimal discomfort to renal failure and death. Extremely varied. And if you look at the normal storage, if you look at the normal bladder, what does the bladder do? The bladder, the low urinary tract serves three functions, very simple. Low pressure storage of urine, emptying of the bladder when socially acceptable, and urethral competence. This is very simple. So our aim is always trying to go back to making it normal, to maintain a low pressure safe bladder reservoir, adequate emptying so the patient can, if possible, self-void or do clean intermittent self-catheterization. We screen for associated urological abnormalities and thereby enhance the quality of life. So when we define the safe bladder, we define it as, this is very important because this is finally the goal of urological treatment in MMC. Low pressure reservoir, which is less likely to have reflux or poor compliance, no functional obstruction to drainage from the ureters. The obstruction is always functional. It's never anatomical. There should be no upper tract dilatation, and so renal failure or pyelonephritis would therefore be unlikely. And this pressure that we take as low pressure is arbitrarily taken as 40 centimeters of water following Magyar study. But now we know that lesser the better. We consider any pressures more than 20 centimeters of water in the bladder to be abnormal and may result in increased risk. So this is that paper. This is quite an old paper. It was published in 1994, where it said 40 centimeter. We now accept 20 as a better value. All of you know the innovation. I'm going to focus on the spine now. So these suprasacral spinal cord lesions, maybe trauma, maybe transverse myelitis or infection or tumors or AV malformation, result in a particular spectrum of injuries, result in a poorly compliant bladder and detrusor hyperactivity. While the lesions which are lower down in the sacral and the subsacral spinal cord, they result in a completely different sort of presentation. But having said that, if you look at the spectrum of urinary tract dysfunction, MMC, there is you have detrusor overactivity with the dysynergic sphincter in 38% of cases, and the inactive detrusor with the synergistic sphincter in only 32% of cases. But having said that, these are all classical presentation. We do not always have these classical presentation. I will present a very simplified classification which will enable you to understand how exactly we should proceed. Now, if you look at this, this is the bladder, and the sphincter is that round donut below it. The thick lines are hyperreflexive, the thin lines are hyperreflexive. So only four different type of variations are actually possible. A hyperreflexic detrusor and hyperreflexic sphincter. This is actually the most dangerous combination, which is often seen in a suprasacral cord lesion. And on the other hand, you may get also a hyperreflexic detrusor with a hyperreflexic sphincter. Again, the patient will not void, but the upper tract are not at so much of a risk. And then again, you have hyperreflexic detrusor, and then you have finally you have the chorda equina lesions, which is hyperreflexic detrusor and the hyperreflexic sphincter. So if you look at these, you have these sort of distinct differences in presentation. But I want to emphasize these are classical signs, and mixed patterns are much more common. You can have a chorda equina lesion, and you can have a melanoma in the sacral cord, and you can have a traction on the upper cord presenting with a very mixed pattern. Therefore, urodynamics is often mandatory for us to exactly know what is going on in the bladder. There is one more reason for UDS. So bladder dysfunction occurs early. As all of you know, that bladder dysfunction may actually occur earlier than sensory or motor dysfunction. If we do a UDS early enough, it is potentially you can detect dysfunction when motor and sensory duration is not yet apparent, and then you can decide on whether you want to operate or you still want to observe the patient for some time till the child grows up. And what we know is now delayed management of the neurogenic bladder has 3 times higher risk of VUR, non-febrile UTI, and annular deterioration. So how do we then evaluate? So when you talk of UDS, we try to reproduce the patient's symptoms during the study, and we try to correlate these symptoms with the findings that we get, and we look for the risk factors: poor compliance, high pressure detrusor contractions, DSD, and of course we document the disease of the lower urinary tract. So always before UDS, we try to frame the urodynamic question, a good history, physical examination, a voiding diary if that is possible in an older child, and review the imaging studies. So the history, of course, very important. See the mentation, nature of the neurologic disease, current medical treatment, and the nature of the lower urinary tract symptoms, the duration. Look at the previous neurologic history. Does the patient have UTI, or is the patient on CIC? Look at the symptoms: storage, voiding, incontinence, very important. And of course, look at the bowel habits, because it is important and imperative that we treat the neurogenic bowel as well as the neurogenic bladder at the same time. And then have a focused neurological assessment. You do this all the time, and basically test for the reflex and sensation also. And my previous speakers have already mentioned the cutaneous stigmata of spinal dysraphism may be present in many cases. So again, this is important. Always evaluate the upper tract. So ultrasound with a post-word residual urine is mandatory. All patients as they come to you, as they present to you, and get a baseline creatinine. Voiding diary, this is something that is very important if the patient can void and the patient is self-voiding, particularly in patients who are not really overly symptomatic. So check the daytime frequency, check the nocturia, because nocturia is abnormal. If the child gets up more than once in the night to pass urine after having attained continence, that's abnormal. And look at the functional bladder capacity, which is the largest volume of urine voided in a single micturition. See the total 24 hours urinary production and total fluid intake. So this is how we actually measure the voiding diary. You have an intake column and output column and a leakage column, and you explain to the patient how to do it. Check if the patient, again, if he has a lesion above T10, there may be autonomic dysreflexia. This is something we need to know, and we need to tell the patient, because this can be very distressing when it actually does occur. And there are many reasons why this can occur. So again, UDS is a very general term. Measurements of any measurements assesses the function or the dysfunction of the lower urinary tract. And invasive, when we put in the catheters, when we actually insert something inside the body. So invasive urodynamics should not be performed without precise indication and without framing the urodynamic question. This is most important. So when you talk about invasive urodynamics, the cystometrogram, pressure flow studies, and then synchronous video urodynamics with the pressure flow studies with the EMG. This is actually the gold standard. Most patients with bifida should undergo this if available. So we insert catheter. This is just to give an overview. We insert catheters, 2 catheters inside the bladder, one for filling and one for measuring the bladder pressures. And we insert a catheter inside the rectum for measuring the abdominal pressure. If the patient has some problem and we cannot insert abdominal catheter into the rectum, we can even put it in the stoma. It's the same thing. We just have to measure the abdominal pressures. So what we really get is, I'll just tell you, the pressure relationship, we measure two pressures. We measure the bladder filling pressure, so-called PVES, and we measure the abdominal pressure. And the PDET, which is actually the actual bladder pressure, is actually a derived formula where we subtract the pressure from the abdominal pressure from the vesical pressure. So the vesical pressure is abdominal pressure plus detrusor pressure. If you want to know the detrusor pressure alone, you have to subtract the abdominal pressure from the vesical pressure. I hope this is clear. We measure two pressures, and the pressure that we really need, the detrusor pressure, is a derived value. PDET is PVES minus PABD. And this is very important, synchronous video CMG. This is the most sensitive way of actually detecting it. So DESD is something we all need to know. If it's a suprasacral lesion, very likely that you can have a coordination of detrusor and the straighted sphincter, and this puts the upper tract at the risk. And there are three types. The third type is the most dangerous. If you look at the EMG here, the EMC has a sort of crescendo pattern where the sphincter is actively contracting when the bladder is contracting as well. This is the type which is most likely to damage the upper tract. So if you take something back from this talk today, these are the two slides I wanted to take back. So if you look, when we do a UDS and we see at what point of time does the pressure rise beyond the threshold. The threshold I've taken as 40 here. It's better to take it as 20. So you can say if we fill the bladder by 100 ml of saline, the pressure have risen more than 40. So this is the time it takes for your patient to get 100 ml of urine in the bladder is the safe period for the patient. So this generally, if you consider 1 ml per kg body weight, it will maybe take 1.5 hours in this particular hypothetical situation. And then similarly, the safe volume is the volume which is required for the pressure to rise beyond say 40 or 20. We should take it as 20 ideally. So if you look at the aerodynamic curve, you can actually make out the safe volume and safe period, and you can therefore advise your patient to do CIC before this is reached. We can of course add anticholinergic and beta-3 agonists to make this even better. So urodynamics, remember, is as reliable as the person who evaluates and reports it. So again, all the guidelines will say that you have a baseline UDS for all patients, and if it's a high risk patients, and this is very important, after you operate, is the follow up UDS needed? So bladder function is usually stable, but do remember, all of you know, secondary tethering is observed in 14% of patients. So if there's a late change in bladder behavior, it indicates late retethering. So this is sometimes which can sort of consider. And do urologists always follow these guidelines? Actually, if you look at one of the studies from Netherlands, only about 10 to 11% actually did follow it. So it's important that you too are aware, so you can ask your colleague to actually evaluate when required. To conclude, diagnose accurately, aim for a safe bladder and prevention of infection. Long-term surveillance with UDS every 1-2 years in high-risk patients. Patients with DSD, patients with poor bladder compliance. These are high risk. And those who have reflux. Low-risk patients, you may, after the initial baseline UDS, follow up with screening of the upper tract and renal function. Thank you so much.
One question by Dr. Muthukumar.
Thank you, Dr. Panda.
Yes.
That is one of the best presentation on this topic I've heard.
Thank you, sir.
Made a very briefly, you showed a slide that bladder is an unreliable witness. Yes, slide was there only for a second.
So yes,
what do you mean by bladder being an unreliable
Sir,
witness?
the bladder has a limited response to disease, no matter what you have. If you have BPH and you have obstruction, secondary obstruction, you are going to have frequency and urgency. If you have overactive bladder, again you're going to have urgency. You may not have obstruction. If you have a neurogenic bladder and you have a detrusor neurogenic overactivity, it will also have a similar urgency and sometimes leak. So all these are very different diseases, but the bladder has only a limited response to disease. It can only respond in these many ways. So that's unreliable. You really cannot know from the bladder symptomatology what actually is the disease process. That is why I say UDS is necessary, particularly in cases of spinal dysraphism. Purely from the MRI, we can assume this is suprasacral, this is sacral or subsacral. It's probably going to be like that, but it's impossible to be 100% sure. That's what I meant.
Minor bifida tethered cord syndrome is one condition where there is a same patient may have in the same segment both UMN and LMN side.
Yes, sir, correct. Absolutely.
So these bladder classifications, how relevant are they to patients with spina bifida?
So which classification, sir?
Of course, these classifications like this UMN type of.
Sir, it is mixed in most cases. That is why we have to have a high index of suspicion. And I have seen, we just operated a patient yesterday where we are planning for a transplant. This patient had a poorly compliant bladder, and I believe that when a patient has a poorly compliant bladder and it's late, even when the create goes up to 1.5, 1.6, we need to advise something separately. Sometimes even a conduit. It can preserve the upper tract and that. So it's very important that we high index of suspicion. We sort of counsel appropriately and do whatever we can. I mean, you guys are doing a great job because now we have great survival. It's not like the 70s and 80s.
How reliable is the urodynamics in a newborn child? Because
newborns are
likely to have
newborn very
physiologically spastic bladder.
Newborn, it is very difficult, sir. Even children less than 1 year, I'm not sure how reliable it is.
So I am asking this question because most of the time when the mother brings the child, the mother says the child is passing urine normally. I show them the scan, the bladder is distended. This is important to document because post-operatively after 1 year, the same parents will come and tell me that when I brought the child to you for surgery, the child had normal sphincter function. Now the sphincter is gone. Everything will be attributed to surgery.
Yes.
The only evidence I have is a distended bladder. So I tell them, but is there any way to document it urodynamically?
Sir, less than 1 year it is difficult. Even less than 2 years, we do cases less than 2 years routinely. But even then, we only document a filling CMG. We don't have voiding because if the child actually cannot respond, you can't have to ask the child to void. Only a filling CMG we do. And if it is normal, like normal compliance, we say the compliance is normal. And we, of course, we ask the child, when the child voids, we try to get ultrasound to see the PVR. That's the only two things we can see. So this is actually urodynamics is actually soft science, I must say here. It's not hard science. If we are able to replicate those symptoms during the study, it is fine. If we are not, it doesn't mean it doesn't exist. It may still exist. It's only that on that particular day, that pediatric patient, you could not show anything. And in a child, it's even more difficult because you are bringing inside a new environment. Machines are there, people are there, wires inside, tubes inside. Quite difficult.
Thank you.
Thank you, sir.
Thank you very much. Lack of time, we cannot take the next question. Sorry. We call upon Dr. Vishaka Khapre to present her topic, Untangling the Maze of Complex Spinal Lipoma Surgery.
We all know that complex lipomas are quite, there are a lot of controversies in treatment of complex lipomas. They are like intricate puzzles, and there are multiple pathways whether to treat whether to treat conservatively, whether do surgery. In the surgery also, the timing matters, like whether prophylactic or we should treat it when symptomatic, whether aggressive total resection should be done or partial. So all those, there are a lot of controversies. The dead ends are like complications which can be really permanent sometimes, and hidden traps are the risks. So just before going to the I'm just trying to simplify the management. So before going to the treatment, I'll just tell you the anatomically how they are different. So the dorsal, the complex lipomas are usually include 3 categories: dorsal, transitional, and chaotic. In that, dorsal will have they are dorsal to the spinal cord. Transitional, they'll have a dorsal component which is dorsal to the conus medullaris, and they also involve the cauda. Whereas the chaotic, they have the dorsal component as well as the ventral component. And in the dorsal, they are horizontally placed. The fat plane is horizontal, whereas it is oblique in fusion line, oblique in the transition, and there is no clear demarcation in the chaotic lipomas. And in the dorsal lipomas, the root entry zone will always be lateral, similar is the case with the transitional. And whereas in the chaotic lipomas, the fusion line will be seen only only rostrally, no, only dorsally, but not caudally. So they'll be mixed actually. Nerve and lipomas will be mixed. So now coming to one by one question. So surgery versus no surgery for asymptomatic lipomas. So this is a very nice outcome analysis done by Pang et al. Whereas he has shown that there are two study groups. They have shown that almost 33 to 40% chance is there whether the children are not treated. So and it was worse with the girls with the transitional lipomas. So prophylactic surgery is always recommended in asymptomatic lipomas. So the next question is whether partial resection or total resection. So it is seen in many studies that large amount of residual fat will be left in the partial resection. It causes, it creates a broad sticky area which provokes new adhesion and which becomes, and which leads to earlier and firmer retethering. So always total resection is recommended in all symptomatic lipomas. Now the next, here again you can see that the progression-free survival is always good in total resection cases, whereas it drops down to the partial resection cases. The next question is the partial resection worse than no surgery for asymptomatic patients, and should it be strongly discouraged? So as I just mentioned, because especially for the asymptomatic lipomas, it is seen that the progression-free survival rate further drops down to the as compared to the partial resection. So when it is not treated, it is better, but when it is partial resection is done, the progression-free survival further drops down. So always it is better to do resection than do partial resection, even in asymptomatic cases. Now the question comes for chaotic lipomas. What's the way for it? So the chaotic lipomas, it's the only exception where you can see whenever the surgery is done, the progression-free survival. This is for dorsal and this is for transitional lipomas. For both of them, the progression-free survival is good. Whereas for chaotic, it has really dropped down even with surgery. Whereas when you compare, when it was treated with non-surgical treatment, it was little better, but it is rather further dropped down when compared to the dropped down when the surgery was done. So it suggests that for the chaotic lipomas, whenever it is asymptomatic, we just have to follow it up with MRIs. Only when it becomes symptomatic, then only do surgery, because of the progression-free survival rate is not good even if we do surgery. So as we all know, we all investigate, going to the management, we investigate these cases with the MRI, the urological evaluation just now told by Dr. Binanda. And then here it is very important to counsel the patient and give them the realistic expectations. Intraoperative monitoring is sine qua non for this surgery, and surgical step planning also we have to do before the surgery. This is intraoperative monitoring. Now coming to the steps, as initially first we do it in prone position. Incision always we take a curvilinear incision with a broad base inferiorly. So step one is exposure and dealing with the extraspinal stalk lipoma. Here we have to be less aggressive in removing the subcutaneous fat. Don't give more stretch on this stalk because it is attached intraspinally, and do wide laminectomy because the dural and lipoma attachment can be much more lateral. Then the next step is unhinging of the hammock. So at both sides, this is a crotch area. So here the dura and the lipoma will be attached. So on both sides, we have to unhinge this first. And we have to do this very slowly because the root entry zone will be just distal to that. Now we will see these nerve roots once we unhinge it. And then comes to identification of the fusion line. Here, one important thing is sometimes the fat will overhang the root entry zone. So you have to cut that fat first, identify the thighs of the nerve roots, and then do the knee dissection, and then go for the actual lipoma resection, where we have to see the fusion line. See, whenever you are doing the resection, go in the white fibrous plane, and then if there is any bleeding over there, be careful about the just with the minimum cautery settings, you can coagulate it. So from rostral, start with rostrally, then go caudally. Here important thing is for the chaotic lipoma, there are special considerations here. Always identify the caudal roots and placard also first before the before doing the dissection at the conus, and then leave the ventral fat to the placard alone with its pia. So pia unviolated. So never touch the ventral fat. Only do the dorsal lipoma resection in the chaotic lipomas, because the main tethering factor is the dorsal lipoma and not the ventral lipoma. So now this is pia to pia neurulation. Here after neurulation, always check again with MEPs, because sometimes because of the tight neurulation or the drop in MEPs can occur, then you may have to release some sutures, resection of the phylum if present, and the lastly expansile graft duroplasty. So these complications like new neurological symptoms, CSF leak, neuropathic pain recurrence can occur. I'm just going to the few representative cases of that what I have treated. So this was a child with a 2-year-old child with a swelling of the lower back, and it was at birth also the MRI was done, but the swelling drastically increased even on the MRI also, and it became to a huge lipoma here. A child had mild weakness in the left foot, and UDS is normal. So you can see first, this is the dissection at the fascia level. This is after laminectomy. This is after durotomy. And here dissection of the lipoma. And here this is after neurulation. I'll skip the videos with the interest of time. This is the second case. You can see there was a lump in the back. It was slowly increasing in size. The child presented at little late, 7 years of age, and the child has urinary urgency, and ultrasound showed mildly distended bladder, and there was reduced compliance in the UDS. This was a case of actually a chaotic lipoma. Here, after excision of the dorsal component, you can see the the ventral component of the fat here. It was not touched, and this is after neurulation, and this is after the dural closure. So to conclude, total resection of the complex spinal cord lipomas and the complete reconstruction gives much better progression, much better long-term survival free, symptom-free survival than partial resection. Partial resection causes new adhesions between the raw surface and the dura, leading to earlier and firmer retethering, leading to the worse prognosis again. Prophylactic total resection is recommended for all asymptomatic dorsal and transitional lipomas, whereas it is not recommended for chaotic lipomas. And chaotic lipomas should be asymptomatic chaotic lipomas should be closely observed without surgery until the symptoms develop. Thank you.
That was a very nice topic, Vishaka. The chaos is now spreading. And I just wanted to, I have no experience of using a laser, but it is said that lasers are better for this chaotic lipomas. I want to know your opinion. Anybody else?
So even I don't have experience, but I have heard in few talks that lasers cause some amount of thermal injury. So nowadays, everyone is again recommending to use the scissor.
Anybody else? Any other questions or comments?
Yeah, no, means thulium laser has less of thermal injury, means less than the carbon dioxide what is used. So means Caesar is always better, but then laser is better than using bipolar and all those. So when you have bleeding, no, you have to again coagulate. So you cannot compare telling Caesar is better, but when it bleeds, you have to do something. Then you're landing with a worse thing. No?
The idea why Pang recommended scissors is that not for laser is what she meant. The not to use lasers probably for dissection, not for coagulation. Am I right, Dr. Vishnu?
Yes, yes. That's what I also.
To reach the white plane and to maintain the white plane, that gritty feeling you get when you cut a meningioma, the same gritty feeling you'll get when you are in the white plane. That feel which you get with the micro scissors, that is the key to maintaining the plane. If you use a laser or anything else, that feel will go. That's the key, is to feel that with your micro scissors, you should be able to feel that slight gritty feeling as if you are cutting a some meningioma. That feeling should be there. Of course, I don't have a laser, so I don't use a thulium laser. Thulium laser. So I use the bipolar when there is bleeding. It's very low setting. Many times small bleedings will, you just put some Surgicel with some cottonoid and then go to another area, come back, this will stop. There's no need to cauterize.
If there are no more questions,
thank you, sir.
I think thank you, Dr. Vishaka. We'll go for next speaker. The recurrent or residual tethered cord by Dr. Ramesh.
Tethered cord syndrome, the definition already discussed by the previous speakers. What I mean that recurrent or residual tethered cord is secondary tethered cord syndrome or multiple repeat tethered cord syndrome. After a primary repair of a spinal dysraphism, a small percentage of patients present with new onset of neurological symptoms and deterioration that is defined as secondary tethered cord syndrome. Even after the secondary tethered cord syndrome release, some patients present with again this tethering, so they will be treated by treated for tethered cord syndrome. They will be called multiple repeat tethered cord syndrome. Coming to the clinical presentation, the incidence of retethering is a time-dependent event. It increases 3.2% per year. It's 0% at 2.1 years and 57% at 18 years. The presentation of retethered cord syndrome is more at 6 to 13 years of age. It corresponds to the period of growth. These patients can present with neurological deterioration, orthopedic deformities, change in bowel function, and urinary tract function deterioration. The motor, sensory, blood, and bowel components of these recurrent tethered cord syndrome patients can be assessed by using NEM neurological motor scale. It starts from 1 to 5. 5 is normal, 1 is severe deficit. In the same way, the ambulation of this patient can be assessed by using Hoffer's ambulatory scale. 5 is normal, 1 is non-ambulatory. Coming to the factors associated with recurrent tethered cord syndrome are younger age at untethering is the significant factor associated with worse long-term neurological outcome. If you take other factors like number of previous untethering surgeries, sex, anatomical level, degree of untethering, or they have no effect on surgical outcomes. But if some others discuss that the diagnosis Lipomyelomeningocele have more associated with tethering. The reasons for tethering in these cases are scar tissues, short nerve roots, and fat or lipoma. Coming to the natural history of secondary tethered cord syndrome is unclear if these patients are not surgically treated. There is a lack of data regarding the magnitude of deterioration and the time extent in which this deterioration takes place. Coming to the investigations, we have MRI, CT, urodynamic studies, and electromyography. Routine postoperative MR magnetic resonance imaging following a primary surgical untethering is not recommended for all cases. It is recommended for complex Lipomyelomeningocele and in children with preoperative terminal syrinx. But most physicians do perform MRI 6 to 18 months after following a surgery. The common findings are low-lying conus. Tethering can be a dorsal or ventral tethering of spinal cord to the subcutaneous scar tissue or to the inner surface of the spinal canal. can be syringomelia and also dermoid. Retethering basically is a clinical diagnosis, not based on MRI. So the presence of tethering in MRI, it's we cannot select the patient based on the MRI finding. So the MRI finding should be classified as clinically relevant and clinically irrelevant. But MRI will be helpful to determine the exact location of tethering and to identify the presence of other lesions. X-ray and CT can be helpful to identify the scoliosis or other bony abnormalities. International Continent Society guidelines recommends the use of urodynamic studies in suspected voiding dysfunction. Among the urodynamic findings, detusor overactivity is the most significant indicator for early diagnosis of recurrent tethered cord syndrome. Coming to the electromyographic study, there is a difference between retethered group and non-progression group. In retethered group, you will see that abnormal spontaneous activity in new muscles, but it will be absent in non-progression group. There is no difference between these groups in nerve conduction study. These are some of the cases operated at our institute. You can see the low-lying cord tissue, adhesions. Coming to the treatment, what are the indications for surgery? Progressive or new onset motor and sensory symptoms, worsening of neurological bladder, and progressive scoliosis are the indications for surgery. What are the aims of surgical intervention? Debulk and disconnect the fibrous tissue that tethers the cord to the thecal sac, complete circumferential untethering of spinal cord, reconstruct the thecal sac to allow the spinal cord and nerve roots to be bathed in CSF, reconstitute the neural tube whenever possible to reduce the surface area of the potential contact between the cord and the dorsal and lateral dura mater. Always use EMG in all the cases. Surgery is most effective in reversing pain, urinary and motor symptoms, but it was not as effective in reversing the sensory symptoms. Windows et al. Has devised a grading system to assess the completeness of surgery for this tethered cord syndrome patients. For all these grades, extend from 1 to 3. So there are 3 gradings for spinal lipomas, dysraphism, as well as fibrous adhesions. 1 means complete untethering, 3 means incomplete untethering. Coming to the complications, dysaesthetic leg pain is the most important, and it happens due to inadvertent sectioning of dorsal nerve root. It's quite disabling and occasionally refractory to medical treatment. Other complications are CSF leak, meningitis, pseudomeningocele, wound complications like wound dehiscence and infection. It's very difficult to draw a conclusion about the relationship between the graft type and risk of CSF leak. Urinary complications like aggravated dysuria, urinary tract infection, temporary urinary retention also mentioned in literature. Coming to the neurological outcome, if you see the various studies like Herman et al., Bowman et al., Haber et al., Alholo et al., and Hayase et al., you can see a gross difference in the motor, sensory, gait, and bladder improvement between different studies. And also over the time, whatever improvement happened deteriorates. The reason for the discrepancy among the various studies is the subjective assessment of function and use of various criteria to identify the changes by different authors. Fang et al. Has observed and reported 89% of neurological deterioration happen over the year 12 years if the patient did not undergo surgical intervention. Same way, Kulkarni et al. Observed 43% of patients deteriorate over the period of 10 years. Therefore, neurological deterioration can be expected in majority of patients who did not undergo surgical intervention. This is my experience. I have operated only 12 secondary tethered cord syndrome cases. Presentation seems similar to other authors. To conclude, retethering of spinal cord is a known phenomenon after primary surgery for tethered cord release. Awareness of early signs and symptoms of retethering and interpretation of MRI are mandatory for a good outcome. Second surgery should be done at trained and experienced personnel. Circumferential untethering of a spinal cord have to be done to have a good neurological outcome. Awareness should be made among referral population, general practitioners, pediatricians, and obstetricians. The treatment of recurrent tethered cord should be carried by a trained neurosurgeons, especially in developing countries like India, with there is no specific referral guidelines. Recurrent tethered cord syndrome requires mandatory follow-up after a second surgery with multidisciplinary team. It requires a long-term follow-up and annual checkup to prevent renal damage. These are my references. Thank you.
Out of time, we'll go. Move to Muthu Kumar.
When bladder and bowel is involved,
yes,
you do the surgery. Which symptoms will resolve first? Do you have any statistical evidence?
Most of the authors agree pain is the best, showing best improvement compared to bladder bowel. Following surgery for secondary tethered cord syndrome or re-tethered cord, bladder improvement is not observed by many others. So they agree all have improvement in pain, like pain or back pain.
Then bowel first.
Urological or bladder the bowel improvement, the least one.
Thank you. And go for the next speaker, Dr. Muthu.
Thanks for the opportunity. I chose this topic because there has been a spate of publication in recent literature suggesting that there is no need for detethering children with spinal deformity and spinal dysraphism. Whether this statement is true, that is the purpose of this particular presentation. In case a detailed 30-40 minutes presentation, I tried to condense it in 10 minutes. Now, why is spinal deformity important in children with spina bifida? Apart from the other factors like loss of sitting ability, skin breakdown, etc., the restrictive pulmonary deficits that can occur in children with severe skeletal deformity, spinal deformity, can cause cardiopulmonary deficit. When we talk about spinal deformity in spina bifida, we have to understand there are two types of spinal deformity in children with spina bifida. One type is the developmental or the paralytic type, which occurs in children with myelomeningocele, especially high thoracic myelomeningocele, where there is a paralysis. These children have a normal curvature at birth. They have normal vertebral bodies. Only bony defect you find is still the posterior spina bifida. But once the scoliosis sets in, it becomes very progressive, rapidly progressive. The other type is the congenital type due to vertebral segmentation or formation deficits like hemivertebra, which is present at birth but progresses slowly. Why is it important? Because about 20 to 30% of children with congenital scoliosis will have intradural anomalies. And traditionally, we have been taught, and this is what is being practiced, is that all these intradural anomalies should be addressed before the spinal deformity is corrected. Because once the spinal deformity is corrected, scoliosis is corrected, the spine is lengthened, and the tethered cord, due to any reason, can aggravate the neurological deficit. Now, before we go into this topic per se, just to refresh our memory, skeletal maturity is extremely important. And to assess skeletal maturity, this is the grading that has been used. Research grading, this ossification of the iliac crust from 0 to 5. Grade 0 is totally skeletally immature. Grade 5 is mature. I'll be referring to this grading in between during my presentation. Now, what about what happens when a child with spina bifida and spinal deformity is found? Now, do all these patients progress at the same rate? No. If a child has a deformity of less than corpse angle of less than 40 degrees, the chance of progression is only 30%. Whereas if the deformity corpse angle is more than 40 degrees, the chance of progression is 2.5 times of that. And another factor to be noticed is the younger the child, the more skeletally immature the child, the greater is the chance of progression. Whereas the more skeletally mature the child, the lesser is the chance of progression. Another two important factors to remember is that curve progression is more. That child is going to have a extensive intramedullary syrinx. Syrinx has a very high potential for progression of scoliosis. And in patients who develop with myelomeningocele and scoliosis, non-ambulatory patients, which are probably patients with thoracic myelomeningoceles, they have more risk of progression of scoliosis. Now, on the basis of my search of the literature, I have divided the evolution of spinal deformity surgery in children with spinal bifida into three phases. Phase 1 is two-stage surgery. Phase 2 is concurrent surgery. Phase 3 is direct deformity correction without correction of intraspinal anomalies. Phase 2 was what was practiced until the turn of the 20th century. This is what initially 3 to 6 months before the spinal deformity surgery, the intraspinal anomaly will be corrected. But people found that this surgery itself is associated with complications like CSF leak, retethering, another anesthesia, plus the fact that all the bony landmarks are erased, so it becomes difficult for the deformity surgeon to place the implants. Now that led to phase 2 around the turn of the century. This not only due to the fact that he realized the limitations of stage surgery, but this also incidentally coincided with the widespread use of intraoperative neuromonitoring for spinal surgery. Now, what does the literature say about this? Mehta et al. Did compare that. I think this is from Mayo Clinic. They compared the single-stage surgery and two-stage surgery, and they found that the two-stage group, that is stage 1, stage 2 group, had more blood loss, greater cumulative operative time, higher incidence of dural tear, or higher incidence of retethering, and surprisingly lesser deformity correction. And another publication, many of these publications are incidentally from China, and this publication showed, once again, did a concurrent surgery. But I would like to highlight that when we read the journal article, you just should not look at the conclusion. We have to dig deep into the data and look at the tables. If you find the table, you find in this particular, the mean age is 29 years, which means most of these patients are skeletally mature. There is very little risk of deterioration. Second factor is traditional idea we have of spinal deformity surgery is elongation of the spine using just extending the spine. That is very rarely practiced, very limited practice in a limited way these days, because now deformity surgeons resort to various forms of osteotomies, including vertebral column resections, which are actually spine shortening osteotomies. In fact, 2015 pediatric neurosurgeon by name Andrew G. from Texas Children's Hospital, for recurrent tethered cord, he suggested vertebral column resection. If you cannot release the tethered cord, you just shorten the spine. That's what he suggested. So when we read such studies, we have to remember this. So this is a study from Turkey, which also came to the same conclusion. But once again, notice many of these patients underwent extensive spinal osteotomies, which are spine shortening surgeries. And this is important because this is split cord malformation is a very tricky proposition. To do a deformity correction without or concurrently is very difficult. And this is what this Chinese group did. And they found only 2 patients had transit deterioration. And one of the important points we have to remember is that these studies have certain limitations, which I'll point out later. When you do a concurrent surgery, first we have to place the spinal implants, and then the intradural portion of surgery should be done, because otherwise the bony landmarks or placement of screws will be lost. Of course, if you have navigation, that problem is sorted out. Now, phase 3, how did phase 3 direct deformity surgery come into vogue? This is because of a incidental serendipitous finding. In 1998, surgeons in Hong Kong, they did what is known as a fulcrum bending test to find out how flexible the curve was. So they placed the child or the patient in the lateral position with the bolster of just right underneath the apex of the curve to find out whether it was flexible, as shown in the slide and the picture below. And incidentally, they found even children with patients with intraspinal anomalies, they did not deteriorate. That made them suggest, why should I do a detethering surgery? I can straight away go and do a direct deformity correction surgery. Is it true? That's what we are going to find out now, because this is what is being aggressively propounded in the literature. Now, this meta-analysis by Ahuja showed that deformity correction may be performed safely and effectively in patients with congenital scoliosis with lesser complications and shorter operative time. But then, this is the limitation of the surgery. Sometimes I wonder whether the journal reviewers do a good job, even when they publish in a top-notch journal. The direct surgery group had a higher, they are older, And majority of the patients had only tight phylum terminae. They did not have complex problems like a type 1 split cord malformation. And many of these patients underwent a spine shortening osteotomies, so that we cannot generalize these findings to all patients with all types of intraspinal anomalies across all age groups. Now, this is another publication, once again from China. They did 3 types of procedure. This is a very reasonable option. When they found the patients did not have neurological deficit, when the curves were not very severe, just did a posterior spinal fusion. When the patient had neurological deficit with less severe curves, they did a pedicle subtraction osteotomy. Whereas the patient had neurological deficit with very severe curves, they resorted to extensive procedures like a vertebral column resection. And this is a very highly quoted in paper in deformity, this particular topic, but this paper is fraught with many limitations. This paper claims that even patients with type 1 and type 2 split cord malformation can undergo surgery without causing any neurological deficit. Look at the limitations. They have excluded all patients with neurological deficit. Only patients without neurological deficits were included. Patients who undergone extensive spinal osteotomies like vertebral column resections have been excluded because those are the patients who are likely to have severe deformities. Therefore, we cannot extrapolate these findings to all patients with split cord malformation. Therefore, we should not say that split cord malformation need not require any correction before deformity correction. And most interestingly, if you dive into the tables, you find that majority of the spurs are located not at the apex of the scoliotic curve, but above or below the curve. Because if it is located at the apex, then the chance of deterioration is more. Now, this is a middle path that was adopted by Samir Elbaba's group. They said that asymptomatic patients with congenital scoliosis are more likely to benefit from fusion with osteotomies. The corpse angle is less than 30 degrees. You just untethering the cord will either arrest the progression of scoliosis or sometimes it can even reverse. If the corpse angle is more than 30 degrees, or either a concurrent procedure or a stage procedure should be done depending upon the surgeon's preference. So concluding, these factors should be taken to consider in the decision making: the research grading, severity of the deformity, the rigidity of the curve, the type of intraspinal anomaly, the type of procedure, and when to operate and how to operate. When to operate, skeletally immature children with corpse angle of more than 40 degrees should undergo immediate surgical intervention, or at least as early as possible. Skeletally mature children with corpse angle of less than 40 degrees, we can have a wait and watch approach. And corpse angle if less than 30 degrees, just tethering alone will arrest the progression of scoliosis. Corpse angle is more than 40 degrees, especially in patients who have had thoracic and upper lumbar meningomyelocele, detethering will not have any effect. For patients with type 2 SCMs, direct deformity correction is possible. There is ample evidence in the literature that for patients with type 2 SCMs, direct deformity correction can be done. Now, which is staged, concurrent, or direct, risk categorization need to be done. Children with high-risk children with type 1 should undergo, with neurological deficit, can undergo concurrent surgery or stage surgery, depending upon what the surgeon's choice. There is ample evidence, as I said, in the literature that type 2 HCMs can undergo direct deformity correction. And the current evidence in the literature supports either concurrent surgery or direct correction in selected cases, patients almost always with INM. Thank you for your kind.
Thank you, Muthukumar. Excellent presentation as always. I've been involved with this work a lot in Pune Sancheti Hospital, the Center for Scoliosis Surgery. And we get most of the patients where I'm involved and I'm called to do detethering are those with a low-lying conus. And the whole question is that the scoliosis surgeon first has to decide how much lengthening he anticipates.
How much correction?
How much length correction. And if that correction anticipated is more than 1.5 centimeters, then they insist on the division of the phylum. I'm not involved. I don't do scoliosis surgery. I'm called for the division of
Neither
the phylum.
do I.
Yeah.
I don't do deformity correction.
Yeah. So what I've learned from them, or what I've seen them do, is that if they are going to get a very big correction, or there is a double curve, then they will insist on the division of the phylum before surgery. Of course, I'm not talking about patients who are having myelomeningocele or diastematomyelitis. I'm talking about those where before scoliosis surgery, they do an MRI and they have a low-lying conus. So that decision is based a lot upon how much correction they are going to get. Recently at AIMS, we had an operative workshop where, along with me, even Professor Kolesov had come from from Russia, who has done more than 8,000. This same question was asked to him. He says he never bothers about the phylum. He just goes ahead with the corrections. And according to him, it is a kind of bogeyman that the patient is going to get neurodeficit after scoliosis correction. But I think a middle path is very important. The surgeon should know how much he's going to stretch the cord. Now with intraoperative neuromonitoring, of course, there is an additional way to find out what you are going to do. But I agree with you. The question remains unresolved as to whether one should detether first. But many times I just go and I take a small incision down at the sacrum, just at S1 level, and I finish off my part, and then they proceed with their surgery.
My answer is that if you go through the literature, they talk about detethering and spinal deformity correction. Look at the tables. They have lumped together all malformations. Recurrent malformations, spinal lipomas, intraspinal dermoids, phylum terminal, even Chiari malformations are lumped together. All these have different tethering effects. For Chiari, you are not going to bother. For phylum terminal, especially if it is going to be, it's not going to be very low lying, if the curve is not very severe, you're not going to bother. Whereas if the patient is going to have a single or double curve with a 70-degree corpse angle and the bony spur is sitting at the apex of the curve, that is a risky child. So risk categorization has to be done. Second factor is a beautiful, I don't know whether I saw Dr. Sajesh Menon today morning, whether Dr. Sajesh Menon is here. Sajesh Menon and Suhas Uday Kumaran, they have published in Journal of Neurosurgery some 10 years ago, concurrent surgery for deformity correction and intradural tethering. And one of their conclusion is that if this concurrent surgery can be done, provided they are at two different sites. For example, as you rightly pointed out, if there is going to be only a thickened phylum, you are just going to make an incision in the S1, cut the phylum, and do most of the deformity correction is going to be in the thoracolumbar region. So these two are separate incision sites, right? So these are there. They have done some risk categorization. It's a beautiful article, but it's not pertaining only to tethering cord, entire neurogenic scoliosis, but small series of 10 cases, but beautiful one from Amrita, worth reading.
Before we close, one aspect you said was, in some cases, just do detethering and the scoliosis will get corrected.
Pardon?
You said that you detether and the scoliosis in very mild
Only in children with myelomeningocele with the scoliosis curve less than 30 degrees, it will either get arrested or occasionally reversed, not completely.
My friend Atul is not here. He would have said do the C1, C2 and the scoliosis will go away.
Thank you very much, Dr. Muthu. And just I want to raise one issue. We are talking about all the post-operative or management things. Nowadays, we are getting a lot of problem with the prenatal ultrasonogram and other things. And we are getting the reports saying that low-lying cord in the ultrasound in fetus or some meningocele, myelocele or whatever it is. And they come for your counseling. The gynecologist will send to you. So what should be our stand? See, recently I got a case referred for counseling saying that the cord is ending at L5 in a baby of, I think, 24 weeks. So they want a counseling. How can we answer or how can we expect or anticipate?
I land up in this mess very frequently, sir. So what happens is it is impossible for anyone because the radiologist will say that as per the sonography, the child is moving the lower limbs, right? That doesn't mean the child has a 5/5 power, number one. Number two, there is no way a sonologist is going to find out whether the child has normal bladder bubble function. There's no way sonologist is going to find a normal bladder bowel function. As of now, with the available technology, it is not possible to grade the muscle power in the lower limb with using sonology. Number two, it is not possible to identify whether the child is going to have a normal bladder bowel function. Suppose we give clearance and the child is born with a deficit, then the entire blame is shifted to the neurosurgeon. So my take on this subject for the past several years is very clear. I use a very particular specific sentence almost it is there in my computer. With the available neurosonographic findings, it is not possible to prognosticate the neurodevelopmental aspect of this child. That's it, period. It is up to the parents and the gynecologist to decide, because we don't have any scientific evidence to say whether this particular child with this given ultrasonographic finding will be normal or not. No, we don't have.
One aspect. Other aspect.
If the child is
Ask about
precious,
the
if the
MTP.
child is precious, if the child,
MTP, if there is a meningocele or meningomyelocele, they just ask whether the child is going to be normal, whether we should go for MTP or not.
there are much worse situations where they refer to this cavum septum verige, all those unsuspected arachnoids. There are worse situations where it's very difficult for us to. The child has a very frank myelomeningocele, and the sonologist is myelomeningocele. Sonologist says that lower limb movements are not good, and the mother is not able. I mean, the lower limb movement is not good. Then obviously you have to advise termination.
When the fetus is not having a problem that is not compatible with life, we can say
Yeah, that's right.
MTP. But meningomyelocele is not.
Meningomyelocele, no.
We
That
cannot
is
say that
up
it
to
is
the
compatible with life.
parents to decide. That's exactly what I'm saying. We can only say the child. We cannot suggest termination of pregnancy. There cannot be anything written in our notes as termination of pregnancy. We are not the
That we
competent
can
authority.
do, but the counseling part.
Counseling part, we have to tell them this child is likely to be born with neurological deficit. It is your call. That's exactly what I do.
That reference which you mentioned of that Alibaba, what was his name? Alibaba?
Middle bath.
L.
Middle bath.
Yeah, he talks
bath.
about intrauterine repair of
Samir Baba is in Florida. Okay, he does intrauterine surgery for myelomeningocele. Please understand that many of these things cannot be extrapolated from Western countries to here. There are certain religious denominations, name obviously cannot be mentioned, who are extremely against against abortions. So those groups, if you go to Latin America, the maximum number of intrauterine surgery for meningomyelocele is being done in Latin America, because most of the Latin Americans belong to a particular religious denomination which believes that abortion should not be done, right?
Yeah.
But come to my place, people of all major three religious denominations, the most orthodox of them, the moment you tell them the child has a congenital deficit seen in the scan, irrespective of the religious denomination, whether they are orthodox or liberal, they'll go for termination.
Not only that, the intrauterine surgeries, they are not encouraged even the developed centers. I don't think it's really encouraged.
It is being pushed by certain groups, obviously for religious
but with very poor results, or don't think it is advised.
One more thing, for intrauterine surgery, I will say in Bombay, they are doing for hydrocephalus third ventriculostomy. But about meningomyelocele, we don't know so far.
Yeah, meningomyelocele still not, but Baba, that group is doing very aggressively, particularly for open meningomyelocele, not the closed ones. Now, in terms of the question of how we are going to, do the convincing talk with your parents, I was asked by Sanjay to write something about an article which we can say something about this prenatal, that is the intrauterine ultrasound and its social implications and the problems we are going to have. As he rightly point out that we cannot assess the neurological outcome when the child is going to get born. If you say that no, the child is okay, it's a closed one, we can always continue the pregnancy. But believe me, So rightly pointed out, lot of abortions are happening without you and me knowing, and you and me giving the guidance to the patients, but still they abort it. And I have written it. I have written it a few years ago in one of the journals about this particular thing, of a neurosurgeon's perspective on this. As we all had that the so-called the sex determination ultrasound, which was first came as anatomical. Ultrasound came into pregnancy for first anatomical. Then became big problem in India was the sex determination. And the government came with a very huge bill passed in the parliament. And finally, it became very tough as far as the sexes now cannot be told. Similarly, I have a feeling that this is going to come into this picture because the number of abortions are increasing. Parents are getting the results from the radiologist, and straight away they decide whether you give a good one or not. I am following so many patients. As I said that I also get the consent, and we also do the secondary surgery. Secondary surgery means after birth, right? So intrauterine, you do the MRI, you do all this movement test. You can do the movement ultrasound test, and then subsequently you operate if it is a closed one. But if it is open one, then it is a problem. That's where the Elbaba group is planning to come forward with intrauterine surgeries.
I think to add to that, Parthiban, if you remember Professor Sharad's criteria in the past of not to treat open spinal or myelomeningocele, one of the criteria in that was a female child. Because the female child with a higher defect invariably succumbed. They had almost 100% mortality. And 50 years ago, Professor Sharad, who was a pediatric neurosurgeon in UK, recommended certain criteria which patients should not be treated. And one of them a female child. And the same thing must be applied in ultrasound also. I feel that if it is a female child, her chances of survival are going to be very poor if she is having a lower mid-dorsal, lower dorsal defect. But that apart, this thing about the legality of the ultrasound, the most important thing which people are missing, that in 2006, Government of India has passed a law where now the property is not divided only for the males, like in the times of Ramayana and Mahabharata. Now all of them are equal partners, all the siblings. So that fear why they used to kill the female child is not, it has to spread to people that the female child is going to have equal rights in the property.
The same. See, this is the point I have raised it. We are close with this. This is the point I have raised it, and the so-called the ultrasound, okay, during pregnancy is going to create a huge impact in our practice.
Last comment by Dr. Raghavendra, and we'll close this.
See, we have almost every fortnight we have this MTB board with the Institute of Obstetric Gynecologists. I'll make two observations. One is the incidence of spinal dysraphism has remained stable, not because of the folate. It is wrongly attributed. It is because of the early termination after identification. That is one. And the recent guidelines, what we follow is if the child is viable and the mother's life is not threatened, we cannot advise termination for a viable child. Unviable child, it is a completely different issue. For a viable child, we have to allow the pregnancy to continue and deal with the dysraphism after birth.
Thank you very much. Thank you for the opportunity. We close this session.
Thank you, sir. Thank you all the speakers for sharing your experience here, and thank you, chairpersons, for running the show. Now we are moving on to the second session on dysraphism. I would welcome Dr. Vinu Gopal, Dr. TV Srinivas, Dr. Marcos Wagner for chairing the session. Sir, please come on to the stage. There is also a small announcement. A car owner by 4424, it is a Baleno. They have left the car at main portico. It is obstructing. We request him to kindly hand over the key. The security is standing in the hall. Thank you.
Good afternoon to everybody. Now let us start the second session. Now I invite Dr. K. Praneeth to start his presentation, Changing Trends and Future of Children with Spinal Dysraphism. Dr. Praneeth.
Good evening. So I'm Dr. Praneeth. I'm working as a pediatric neurosurgeon at Rainbow Children Hospital. So my talk has already been started the discussion has already started. So I would be discussing mostly on antenatal management and rehabilitation. Much has been taken care about surgery, and give a small note on primary prevention. So as it has been discussing, the TIFA scans are so commonly done now, and now and then we get these patients on a routine basis. We see these patients in our OPD showing antenatal detection of spinal dysraphism, and parents are bothered about neurological morbidities and what would be the associated anomalies. So, and how TIFAs are going to impact the prevalence of spinal dysraphism is a hot topic. And as I speak with my colleagues in pediatric cardiology, they see that with the increasing TIFAs, they are not seeing complex cardiac abnormalities nowadays, and most of the cardiac abnormalities in the children are milder. This might be a sooner or later a situation with spinal dysraphism where there is a prolific adoption of termination of pregnancy once the diagnosis is done, because the insurance never covers, and most of the patients have to bear from their pocket for the surgery and for the rehabilitation, and we really know what is the situation of rehabilitation in our country. So most commonly practiced indications for termination with or without consulting a neurosurgeon is usually open neural tuber defect, a severe caudal regression, or a spinal dysraphism with severe ventriculomegaly more than 15 mm diameter of atrium at its maximum. So can increasing utilization of TIFAs decrease the incidence of open spinal dysraphism or severe spinal dysraphism? It's a possibility which can occur, but still we have a issue with low ANC registrations and TIFA availability and adherence. When we detect the patients with spinal dysraphism, it is essential to do a fetal MRI if the patient is in a window period of 18 weeks to 24 weeks where they can decide about termination, to know better anatomical details and associated extracranial and extracranial anomalies which will impact the decision making whether to continue the pregnancy or terminate the pregnancy. The special consideration where the fetal MRI has to be considered are where the maternal body habitus or towards the obese side, where the evaluation with sonography is less, where there is oligohydramnios, anteriorly placed placenta, posteriorly placed spine, or where there are complex anomalies difficult to assess the spinal issues in clear. So in these cases, a fetal MRI can help us in decision making what to do next. So these are the usual images. This is an ultrasound showing a cyst with some neural elements entering into the cyst. The fetal MRI of the same patient showing the terminal cord entering into the cyst, and this is postnatal MRI. There is lot of difference in the clarity of the image, but it is how would we take decision about what to do, who would be the person for the fetal surgery is what is our next discussion. So fetal diagnosis and postnatal outcome of closed spinal dysraphism is, if we discuss, and this is an interesting paper showing a scary result that about 1/3 of them have posterior fossa anomalies, about 50% of them have CNS abnormalities, about 90% of them have neurogenic bladder. We can't deny these results, and really spinal dysraphism has got such kind of a high morbidity, and when it is associated with Urological malformation 2 and impaired motor function, the outcomes are going to be very dismal. This is how the fetal medicine people evaluate the spinal evaluation. If there is a defect on the cranial aspect, it is called cranial dysraphism. Usually there is a direct indication for termination of pregnancy. These patients are not going to do through the intrauterine period itself. And when there is a cranial sign, which can be called a banana sign or a lemon sign, which is associated with Urological malformation 2, and 98% of them are associated with spinal dysraphism, and mostly when it is associated with a cranial sign, it is considered to be a open spinal dysraphism. This is what the fetal medicine people understand about the spinal dysraphism. So once there is a lump, you have meningoceles and the rest of the thing, and if there is a major defect, caudal regression syndromes are understood. And once they have a diagnosis, whether it's open or closed, then a fetal MRI is done to confirm the same. So this is a patient with a Arnold-Corey malformation. A similar picture you can see on the ultrasound with some ventriculomegaly. We can see a meningocele at the back. So what would you do? It all depends upon at what age they are presenting, whether you terminate, continue pregnancy, or do a fetal repair. So mom's trial has told after a RCT that intrauterine repair is useful in resolution of hindbrain herniation, lower shunt requirements, better motor, bowel, and bladder functions. But this is done when there is a singleton pregnancy, gestation is between 19 to 25 weeks, and the defect is between T1 to S1 associated with hindbrain herniation, amniocentesis to document a normal karyotype before going towards it, and the age of the mother should be more than 18 years to consent for the intrauterine procedure. The approaches being the open traditional approach where they do a laparotomy and a hysterotomy, which is usually done in the upper segment of the uterus. And now there is a use of fetoscopic surgeries where they do completely fetoscopic or hybrid where it is associated with a laparotomy followed by a fetoscopic procedures. So eventually the laparoscopy or fetoscopy sounds very fancy and it might be preferred, but it's not so, because what we are considering is a preterm delivery, PROM, need for cesarean, uterine dehiscence, and need for detethering after the birth. So with fetoscopic surgery, it is seen that PROM rates are more, uterine dehiscence rates are more, and revision surgery after birth is more. So fetoscopic surgery is not a euphoria. So it has to be taken with a pinch. Hybrid procedures are being tried by those groups who are trying the fetal surgery. The future of fetal surgery, it would be like transamniotic stem cell therapy is being studied in animals where these mesenchymal stromal cells from the amniotic fluid or placenta are used, and it is shown that it can have a partial or complete skin coverage, decrease ACM rates, have a neuroprotective effect on the element fibers which are exposed. Human umbilical cord patch has been used in these intrauterine repairs to cover the skin defect when it is not possible. The other things being human amniotic stem cell, fibroblast growth factor in gelatin scaffolds, fetal autologous skin grafts, and pedicle transposition grafts are all used for this closure of the skin defect. Coming to surgery of spinal dysraphism, I can't say anything new after Dutchlink Pang's landmark papers. Moving to the rehabilitation, we should be beware of this person, Elon Musk, trying to do all the crazy things which were thought to be impossible. Yesterday's post shows about this blindside device where he wants to show world to patients who don't have optic now. Just the visual cortex seems to be enough to show them the world. So it is a much simpler problem with these spinal dysraphism patients when you can apply technology and you have enough resources to rehabilitate. So you need to have a complete plan for these patients with spinal dysraphism right from the antenatal to the adolescence, where you have imaging, urodynamics, sphincter control acquisitions, re-dethetherings, orthopedic deformities, psychological support to parents, children, and sexual functions and transition to the adult. This is a long journey which you start with the small children, and you should be committed and trained to help them out. Motor rehabilitation has physiotherapy, orthosis, and deformity corrections where it is required. So these are usually how you assess a child able to walk along the all terrains, flat foot, requiring the sticks or crutches or the frames. So how we will be taking a call. If it is a low thoracic, then you would be requiring a trunk hip orthosis, and it a high lumbar. It is these things which can help in reciprocating gait orthosis. Robotic exoskeleton is coming in high up to help these patients with high deformities, where they can help in preventing the muscle wasting and improving the bone health. Osteoporosis is a very common problem in the patients with lower thoracic or higher lumbar deformities, because their bone health deteriorates because of being bedridden, and they can have osteoporotic fractures. So these are all orthotics which can help a patient to utilize his upper limbs. And in these knee ankle orthosis can be useful, and the foot and supramalleolar orthosis. Neurogenic bladder it is well discussed by Dr. Panda. I would not add anything much to it, but I would say that sacral neuromodulation has been attempted in patients of spinal dysraphism, especially when they are ambulatory, to improve the continence. Similarly, a bowel management program, a two-pronged oral and rectal interventions can be utilized, and there has been a report of using sacral neuromodulation to improve the fecal incontinence in patient with spinal dysraphism. The normal folic acid prevention, which is advised, is 0.4 mg, but it has to be given pre-conceptional. And in patients who had a previous history of spinal dysraphism, it is 4 mg to 1 to 3 months before the conception. Fortification of folic acid and B12 is being tried in the staple food, which is not yet into practice. Diabetes mellitus or gestational diabetes mellitus should be diagnosed early and better controlled to prevent neurological abnormalities. This is a study which was done in 2015, where it shows that fortification of staple food by folate can reduce the child mortality by reducing the folic acid dependent spina bifida occurrence. Take home message: in increasing diagnosis, we should be adept with all the possibilities in intrauterine. We have to give them a possibility. Now it's not a big problem. They might travel to US or Latin America, get the intrauterine repair done. Our society is moving forward. We have to be updated with it. So COPE in India, where they have to pay from their pocket, is still a bit controversial, and how it would be relevant, we have to see. Rehabilitation has to be considered an opportunity to sort all the possibilities. And folic acid prevention, we have leaders in the society, neurosurgery. So we have to concentrate on this because it can have an impact on child mortality, overall improving the societal responsibility. Thank you.
Thank you so much. You have given an excellent overview of the fetal surgery, fetal neuro radio diagnosis, which is an upcoming field. And you have even touched upon the rehabilitation of such patients. So because of lack of time, we can take one question. There are no questions. Shall we move to the next speaker? The topic is spinal dysraphism, our experience. Dr. Marin Mary, Bangalore.
Good evening, everyone. I'm Dr. Marin Mary, Senior Resident in the Department of Neurosurgery in Rajarasham Medical College, Bangalore. My topic for the day is spinal dysraphism at our institute and our experience. Aim and objective of the study was to evaluate the clinical presentation of the patients with spinal dysraphism, associated congenital anomalies, surgical management, and the outcome of the patients with spinal dysraphism. It was a retrospective study conducted over a period of 84 months from July 2017 to 2024 in our department. There were a total of 16 patients which were selected in our study, of which 5 patients were male, 11 patients were female, of which infants were 1, 10 patients were preschool going children, which was 1 to 3 years of age, and school going children were more than 3 years of age, with a maximum age of 9 years. And all the 16 patients, the site of lesion was lumbosacral region. We also evaluated mothers with folic acid intake, in which 5 patients' mother had taken folic acid and 11 patients' mother had not taken folic acid, of which we also considered the patients whose siblings were affected with the same complaints, of which 2 patients' siblings were affected, 5 patients' siblings were normal, and 9 patients were not applicable because they were the only child. Among the various presentations among these patients were swelling over the lower back was among the 4 patients. Incontinent bladder was seen in 6 patients. None of the patients showed bowel incontinence. Upper limb weakness was seen in none of the patients. Upper limb deformity was not seen. Lower limb weakness was seen in 3 patients. Lower limb deformity was seen in bilateral lower limb deformity was seen in 2 patients. Right lower limb deformity was seen in 2 patients. Left lower limb deformity was seen in 1 patient. Spine deformity, scoliosis was seen in 2 patients. Hydrocephalus was seen in 1 patient. Hypertrichosis was seen in 12 patients. Sacral dimpling was seen in 10 patients. and dermal sinus was seen in 3 patients. Bilateral foot sensory loss was seen in 3 patients. Trophic ulcer bilateral foot was seen in 2 patients. Left foot trophic ulcer was seen in 2 patients. Coccygeal ulcer was seen in 1 patient. There was gait deformity noted in 3 patients, with none patients showing Chiari malformation. These are a few pictures showing of our patients here, where we can see the first picture here, where we can see the child having a spine deformity with a lower sacral swelling, with a leg length discrepancy, with scoliosis and trophic ulcer over the coccygeal region, over the plantar aspect of the foot and the lateral aspect of the foot. There's another patient of myelomeningocele which was seen with skin puckering was over the neural placode was noted. There's another patient where skin puckering and tuft of hair of the punctum was noted over the dermal sinus tract. Dermal sinus tract, skin puckering and tuft of hair. The diagnosis which we had for our 16 patients, lipomeningocele with spina bifida with tethered cord. Dermal sinus with tethered cord was seen, lipomeningocele with spina bifida with tethered cord was seen in 4 patients. Dermal sinus tract with a tethered cord was seen in 3 patients. Tethered cord with diplomylia was seen in 1 patient. Diastomatomylia with was seen in 1 patient. Meningocele with tethered cord was seen in 1 patient. Tethered cord was seen only in 5 patients. And spina bifida with myelomeningocele with neural placode of the neural placode was seen in 1 patient. Surgeries performed for these patients were excision and repair of the defect was done in 9 patients. Laminectomy and detethering of the cord was done in 5 patients. Laminectomy and dissection of the fibromyalgia stalk was done in 4 patients. Excision of the dermal sinus tract in 3 patients. Reconstruction of the closure of the neural placode was done in 9 patients. PP shunting was done in 1 patient. There's a few images of our patients which was done, which is the case of myelomeningocele, where we can see the neural content defect seen exposing to the skin surface from L4 to S1 level. And there's an axial section where we can see the posterior column spinal defect seen. There's another axial section where we can see the neural placode content exposing to the skin surface. Another image of our patient of lipomeningocele where we can see the extradural hyperintensity node of the subcutaneous plane into the intradural content. Axial section showing the hyperintensity of the subcutaneous plane and in the intradural content. Same image where we can see the continuity of the hyperintensity of the subcutaneous plane into the intradural content. There's another patient of ours which we had a combination of 4 in 1. That is dermal sinus tract, which is noted here, along with syringomyelia, along with tethered cord at the S2 level, along with diplomylia the same patient had, syringomyelia in the axial section, diplomylia noted in the T2 section in the same patient. Surgical procedures that we have done for these patients were, this is the patient for myelomeningocele where we had inside the skin around the skin puckering. Skin was excised. Neural placode was exposed and reconstruction of the end closure of the neural placode was done. There's another patient of dorsal type of lipomyelomeningocele. Here we had exposed the subcutaneous fat from the subcutaneous tissue. This was a fibrolipomatous stalk that was seen, which is extending into the dura. The extension of the fibrolipomatous stalk and the lipoma was excised. Decompression of the cord was done. Detethering of the cord was done, along with primary dural closure was achieved. There's another case of the same patients whose investigation was shown previously, where we can see there was a skin showing the dermal sinus tract. On excising the dermal sinus tract from the skin to the subcutaneous plane, the tract was followed through the interspinous process extending into the dural space. On dissecting the dermal sinus tract, it was noted to have a CSF leak, the glistening white we can see down, to have a CSF leak confirming that the intradural extension. The extension was noted into a subarachnoid space which was decompressed. On superiorly, it was seen to have the child to have a diplomylia, but the child did not have any bony spur or did not have any fibrolipomatous septum. Detethering of the cord was done for the same patient and laminectomy was achieved, post which the skin was closed. Post-operative complication among our patients, one patient has CSF leak for which we had done conservative management for the same. Due to failure of the conservative management, we went ahead and did a surgical secondary closure of the dural sinus tract, of the dura, secondary closure of the dura. And none of the patients developed hydrocephalus or retethering of the cord in the future. None developed fever, meningitis, seizure, or wound infections or any BP shunting blockage. Among the post-operative outcomes, all the 100 patients had good satisfactory outcomes, such as improvement of the bladder incontinence in which the CIC frequency had reduced and the social life had improved. The child had started going to the school again. Partial regulation of the sensory function over the bilateral foot, improvement in the gait and complete healing of the trophic ulcer or the bilateral foot with reduced size of the trophic ulcer when the coxal region was noted. No patient experienced a deterioration in symptoms and no mortality was recorded. Conclusion of our study was that the spinal dysraphism, one of the most common congenital disability in children, with open spina bifida being more prevalent than the closed type. Myelomeningocele, the most common form of spinal dysraphism, accounts for about 80% of the cases. Though this study uniquely comprised solely of the closed type, including a notable case of spina bifida with myelomeningocele covered by a layer of skin over the neural placard. Additionally, the study also documented a rare instance of a combined condition involving the dermal sinus with tethered cord with diplomylia and syringomyelia. From the current studies, conclude that spinal dysraphism is a complex disorder influencing the multiple system of body, thus requiring multidisciplinary approach of management and better outcome. However, surgery remains the cornerstone of treatment to prevent the further complications. Meticulous post-operative care is equally vital. The pivotal role of the family support cannot be overstated, crucially contributing to the patient's overall well-being and rehabilitation. Earlier the diagnosis, earlier the treatment, earlier are the chances for the recovery from the symptoms and prevention of any neurological, urinary, or orthopedic disability.
Thank you, Dr. Mary. Spinal dysraphism is a challenging disease, even for Brazil and for India, all countries that have big populations. So, thank you. Any questions? Okay. Thank you. Now let's go to the next speaker, Dr. Raul Raikar Balari. A study of the spectrum of spinal dysraphisms and its surgical outcome.
Good evening, everybody. I'm Dr. Rahul Raikar from TCC Ballari Medical College and Research Center. Today I am presenting a paper of study of spectrum of spinal dysraphism and its surgical outcome, our experience. Introduction. The term spinal dysraphism refers to a group of congenital anomalies of the spine in which the midline structures fail to fuse. They are commonly known as neural tube defects. Incidence of neural tube defect in India varies from 0.3 to 1.14 per thousand live births and varies in different population. Myelomeningocele is the single most common congenital malformation that affects the entire central nervous system. Various factors are attributed as causative agents such as hyperthermia, medications such as valproic acid, carbamazine, hypervitaminosis A, deficiency of folic acid, zinc, vitamin B12 during the preconception period, and genetic factors. Early recognition of these entities is important because neurological functions may be preserved only by early and appropriate surgical intervention. Coming to objectives, materials, and methods. Our objective was to study the clinical profile of the patient with spinal dysraphism and outcome of surgical interventions in these patients. A total of 30 patients with spinal dysraphism were studied in a tertiary care setting during the period of 2023 to 2024. Among the selected patients, the clinical profile, radiological profile, and surgical interventions undertaken were studied and outcome were noticed. All the patients were followed up for a period of 3 months post-operatively for presence of complications. Appropriate measures were taken to resolve the complications. After initial clinical assessment, MRI scan was done in all the patients to assess the type, position, and extent of the lesion. In the case of myelomeningocele without cord tethering, anatomical repair was carried out using standard surgical technique. In case of in cases associated with hydrocephalus, VP shunting was done, ventricular peritoneal shunt. In case of lipomeningocele, anatomical repair with excision of lipoma was done. In diastematomyelia, anatomical repair with laminectomy with detethering of cord was done. In case of dermal sinus, anatomical repair with excision of tract was done. These are few cases what we have done. This is the myelomeningocele. This baby presented with hydrocephalus and swelling in the thoracolumbar region. We did VP shunting first. After VP shunting, the patient underwent myelomeningocele excision with preserving of the neural tissues. No post-operative complication was seen in this patient. Meningocele. This baby presented with swelling in the lumbar region. Excision and repair was done. This patient, this is 7-year-old patient who came with complaints of back pain and both lower limb weakness. MRI was done and tethered cord was seen. Detethering was done. Post-operatively, his symptoms were improved. Even the back pain was improved. This case of lipomeningocele, this patient presented with only swelling. Post-operatively, no neurological deficits was seen. Our results of our study, age group of the patients, most of them were neonates. 44 cases were neonates. Infants were 15, and the age group is 1 to 5 years of 10 1 to 5 years were 10, and greater than 5 years was 1. Most of the cases were male patients, and female was 10. Clinical profile, type of dysraphism, that is, most of the cases were myelomeningocele, that is 23 cases out of 30. Lipomeningocele were 2, meningocele was 2, tethered cord were 2, and dermal sinus was 1. Most common location we noticed was lumbosacral, that is 24 cases out of 30. Cervical were 2, thoracolumbar were 4. The mean size was 27.33 centimeter square. Out of these patients, paraparesis, only 4 were pre-existing. 26 other cases were having normal power. We also had ruptured meningocele, that 14 patients had ruptured meningocele and 16 were normal, out of which 11 had hydrocephalus and 19 were normal. Post-operative complications among the patients, we had 4 CSF leaks for which a stitch was taken and the CSF leak was taken care of. Wound infections, we had 4 infections of the wound. Higher antibiotic was used and the infection subsided. Skin necrosis, 2 we had skin necrosis for which wound debridement and flap was done. Flap result was done and suturing was done. We encountered 3 ventriculitis, out of which 2 we couldn't save. 1 patient survived with use of higher antibiotics. Conclusion, among the spinal dysraphism, myelomeningocele is the most common birth defect involving the spine. Management of the patients with spinal dysraphism should be individualized, involving multidisciplinary comprehensive approach with judicious investigations and their interpretation, which should be followed by timely selective surgical intervention by trained hands, which will facilitate the recovery and preserve the neurological functions in majority of them.
Thank you, Dr. Praneeth, for your excellent presentation. Dr. Rahul. Thank you, Dr. Rahul, for your excellent presentation. Over to the audience. Any questions, please?
Did any of your case require the help of a plastic surgeon for reconstruction?
No, sir. We could manage it, sir. We could manage it. In the complications, we had four wound infections. We could manage it, sir. We could manage it.
Over to the audience. Any questions, please? Still some time is there. Okay. If there are no questions, we'll go to the next speaker.
Thank you, sir.
Thank you, Dr. Rahul. I invite Dr. Shahid Mohammed to present on clinical outcomes and correlation with changes on MRI after an untethering surgery for tethered cord syndromes and institutional study.
Good evening,
Dr.
everyone.
Mohammed, please.
Thank you. Thank you for the opportunity. Good evening, everyone. I am Dr. Mohammed Shahid, and I'm presenting my study which we did in our institute over the clinical outcomes, especially in the after detethering surgery in cases of. So, tethered cord syndrome is a primary tethered cord syndrome is usually the end pathway for most of the neural tube defects, and it can be most of the patients either primarily they will land in tethered cord syndrome later on, or they present with primary, and we need to repair them at the time of the detethering out as such. So we study these common presentations of the tethered cord syndrome and post-operative outcomes after detethering surgery in our institute at that is NIMS, Hyderabad. This retrospective review, which we included 25 patients who are undergone tethered cord detethering for tethered cord syndrome, and patients were taken from 2021 to 2024. So looking into the characteristics of the patients, like the age distribution is varied, and with most of the patients in the at least 21 patients will be below 15 years of age, and they can and it also present with at higher ages, like more than 30 to 40 also, like in adults also it is commonly seen. Then there is no female preponderance, as some studies have initially shown. Coming to what are the usual first presentations, what we have seen is the pain is usually the first presentation, and followed by scoliosis is also long-standing scoliosis is also very commonly seen in 6 of the patients, like out of 25 patients. And 10 out of 25 had initial presentation of pain. Some had, and 4 people had only swelling without any other neurological, either neurological or any pain-like symptoms. And only few and urinary disturbances or bladder dysfunction are usually late presentations. So, and the mean follow-up that at the time of from the onset of these symptoms and to the presentation is around 33 months, and can range up to 72 months also, like up to 6-7 years in cases of it. So pain is the most common. None of these surgery cases we had any carry malformation or hydrocephalus associated with them. Coming to all the other spectrum of symptoms, pain is the most common, and as shown in other studies as well. So 64% have any sort of back pain or radicular pain, and 45% have some neurological deficits, either from sensory to motor. And if you see, and only around 1/3 of the patients have had a bladder dysfunction. And especially on imaging, there was a searings. We need at the presentation only we see 44% around having searings. And cord level was usually at the at the body of the L2 or the lower end of that L2, and most commonly L3 was the site for the cord. This is one representative image, one of the patients. It shows tethered cord, and there is a severe scoliosis associated, and along with the vertebral anomalies. So vertebral anomalies are also seen in around 20% of cases also. And what are the usual causes of along with the how they presented, like with dermal sinus tract lipoma, and without and these are the occurred neural tube defects, and none had this open neural tube defects as such, and 12 out of 25, around 50% didn't had any associated occult, or they're on MRI basis they were diagnosed with as a fibrous or fatty phylum only. 3 out of 4 spinal cord split cord malformations were type 2. Immediate complications, what we can sometimes see it's there is a chance of that immediate neurological deficit may improve, may worsen, but there was no such immediate worsening seen. But 2 out of the 25 had CSF leak. One required re-exploration, another managed conservatively. 3 had persistent pseudomeningocele. This is still so on how the outcomes are like pain. Pain was the most important, that had seen a significant improvement, followed by gait, and then sensor motor, and lastly bladder. So mean follow. So in contrast, bladder dysfunction shows improvement only in 33% of the cases. So can pre-op status predict outcomes? Irrespective of the primary cause, outcomes are similar after detethering. And especially one point to note is that serings may indicate a less likely improvement in the neurological outcome compared to other outcomes. So we had used IONM in 16 of the cases, but IONM may not. It's most of the surgeon preference and may not. So coming to the conclusions, pain and deformity is the most common presentation. Untethering of the cord in tethered cord syndrome results in significant clinical improvement, particularly in the pain and motor function. IONM choices, then serings is less likely to improve in result in improvement in bladder function. So this study is limited by the small size and short follow-up period. Thank you.
So, thank you so much. We have one question. In case of a tethered cord syndrome with a hollow syrinx, will a syringo-subarachnoid shunt help recovery?
We can after detethering there is there are less likely that serings may be improved. Like certain studies have shown that the serings may improve spontaneously, but there are other studies which doesn't clearly say. So we can wait and watch, and neurological improvement, if it is there persist, then we can later, and only if there is a progression of the serings or any neurological deficit, then we can go for subarachnoid syringe shunt.
The etiology of the syrinx in tethered cord is not outflow defect. It is because of the repeated traction and neuronal loss.
Yes.
That is why I don't think the syrinx is detethering the cord is the treatment. And whether the syrinx, even in his cases, he had bladder involvement in 36%, but syrinx in 44%. So there were a significant number of people who had syrinx but had no bladder involvement. Am I correct?
Yes, sir.
So the syrinx is actually a function of how much neuronal loss has taken place, and once that it has been detethered, I don't think the syrinx is important at all, and whether putting a syringe or subarachnoid shunt is, because doing that procedure itself might produce some neurodeficit.
Any other questions?
Sometimes you get references or in adult patients, especially 50 plus, who are having a normally positioned conus with neurogenic bladder. And they ask for a division of the phylum. What is your opinion, Mudhu Kumar? What is your opinion, Vinu, the other chairpersons? Have you had this kind of situation? Because neurogenic bladder, when there's an elderly person with 50 plus and his bladder disturbance, the first thing we think is about a prostate. But then sometimes after urodynamic, you get to see, and there were a lot of papers in literature of division of phylum terminae normally positioned.
I think it was 1994 when Jerry Oakes and Water published in Neurosurgery on normally positioned conus with tethered cord, which is what was just known as occult phylum term. In children, yes. If there is no other, if the urologist cannot pick up any other cause for the urological dysfunction, if other things sync with it in a normally positioned conus, phylum can be sectioned. Though in my experience, the results are not very encouraging. Right? That was first described in 94. And immediately after that publication, I went on and did a series of cases. The results were not very good. They stopped. Now, once again, it's coming back. That is number one. There is unfortunately, this prospective study was conducted, I think in Toronto or somewhere in Canada with, and that study did not prove that to be true. So there is no scientific evidence as such, but in adults, I don't think there is any, to the best of my knowledge, no evidence to suggest that there is a condition known as occult phylum terminal. If it exists only in children. That too, a big if.
What about whenever in doubt, opinion about doing a supine and a prone MRI for detecting these in doubtful cases where you are thinking of tethered cord? Any experience with doing a supine and prone MRI? We started recently with doing these things actually.
This is generally done. In fact, if we have a good sonologist who is comfortable with, who is well experienced, because sonography is used as dependent, whereas MRI is much more objective. We can also see. Read tethered cord, not in tethered cord, in read tethered cord, because after you untether, most of the time, 90% of the time, the conus will not go. It is going to see, especially if it is in L5S1. It's going to be there, and then the child has some symptoms. We have a doubt whether it's just a low-lying cord after untethering or whether it's in that case, if there is movement in prone and supine, definitely there is no retethering. If there is no movement, then it's possible tethering, but it's not confirmed.
Not confirmed.
Thank you so much, sir, for such a discussion. With this, we will come to the last talk of the day, of this session. Early onset scoliosis by Dr. Tarang Vora from Hyderabad.
Hi, so I'm a young pediatric neurosurgeon. It's been 3 years in practice. I'm still gaining more experience. My experience on early onset scoliosis is very, very limited. No surgical experience. It's predominantly bracing that I've had for 3 children so far. But apart from that, I've been an avid student of the subject. So I'm going to present an overview of early onset scoliosis rather than my experience on it. So whatever overview I'm presenting is based on whatever information I could collect from Scoliosis Research Society. I became a part of it a year ago. And let's start with what is early onset scoliosis. So it is defined as a curve greater than 10 Cobb degrees in coronal plane radiograph, diagnosed before the age of 10 years. During my training, I never read too much about early onset scoliosis, but being a subspecialized branch now, practicing a subspecialized, having a subspecialized practice, I have started to read up more and trying to explore more about early onset scoliosis. So it was fascinating for me to read up more about it, and it was interesting to find out the most rapid period of spinal growth is within the first 5 years of life, and then followed by that at adolescence, which are the 2 phases where scoliosis can worsen. The golden period of spine growth is within the first 5 years of life. For instance, the thoracic spine expands from 12 centimeters to 18 centimeters from birth to 5 years. That is a 60% of adult spine length during the initial 5 years of life. When we are looking at different types of early onset scoliosis, it is noted that in congenital scoliosis, the vital capacity of the lung is significantly diminished in comparison with idiopathic scoliosis. That is because the scoliosis and the curves are progressing at a much more rapid rate. It is present since birth. It has more effect on the pulmonology function. So when we are talking about early onset scoliosis in comparison with AIS or other forms of adult deformity, we are talking about pulmonary function. We are talking about progression of curves. We're talking about the height the child is gaining. We are not talking about so much about the deformity correction. So we're not talking so much about the pain. When we are looking at a graph of the spine's growth in the initial years, the maximum growth is within the first 5 years, followed by that at the adolescent period. The growth is more in the thoracic spine compared to the lumbar and the cervical spine. Why so? So this is a diagram which shows that most of the thoracic spine, when you're comparing the amount of disc that is present and the bone that is present, thoracic spine is made of 82% bone. The height of the thoracic spine is 82% bone and 18% disc. In comparison with the lumbar spine, it is 65% and 35% disc. So, but obviously when the bone is growing much more, we have more obvious early onset scoliosis affecting the thoracic spine. So when we are looking at the lung function, the growth of a child's lung and the rib cage volume, at the age of 5 years, a child achieves 31% of its rib cage volume, whereas 69% of the spine growth is already over by the age of 5 years. So it's like first the spine will grow, and it is after that that the rib starts to grow more, and the child becomes the pulmonary function, the vital capacity that the child has with the breathing. It expands more after the spine has grown more around 7 to 8 years of age. So why treat early onset scoliosis? The primary and the most important goal of treatment is to promote rib cage expansion because it is predominantly thoracic in nature if we are talking about the idiopathic cases. Second is to prevent progression of deformity to become much more complex with age so that it becomes easier for the adult surgeons or the adult deformity spine surgeons to correct it much more easily. This SRS, there is a classification for early onset scoliosis divided on the basis of etiology, curve angle, kyphosis, and the curve progression. So when we're looking at etiology, we're looking at congenital, neuromuscular, syndromic, and idiopathic. I'll talk about the etiology. So first is the idiopathic cases. The idiopathic cases are basically subdivided into infantile, that is below 0 to 3 years, and juvenile, that is 4 to 10 years of age. The syndromic cases, the neuromuscular cases, and the congenital cases. Another thing that we are looking here is thoracic insufficiency syndrome. So when we see a child with a Cobb angle more than 70 degree, that is the time that we feel that definitely there is some impact on the thoracic insufficiency. We have to refer to a pediatric pulmonologist to get the child evaluated on how the child's doing with lung functions. Looking at the etiology of the scoliosis one at a time. So when we are looking at idiopathic scoliosis, in the infantile age group, it's between birth to 3 years. That is the most common is left-sided thoracic curve. Why left-sided? Still there is no consensus on it, but predominantly thoracic because bone is more in the thoracic spine compared to the lumbar and the cervical spine. Boys are affected more than the girls, both in idiopathic, in infantile as well as juvenile. In comparison to adolescent idiopathic scoliosis where girls are affected more. So 20% of the children who are younger than 10 years of age and have a curve that is greater than 20 degree of Cobb angle on a coronal X-ray will have an underlying spinal condition. So it is mandatory that we get an MRI of the neural axis done, and most of them will have an associated, can have an associated Arnold-Chiari malformation, and untethering of cords and treatment of the Arnold-Chiari may in some instances prevent the progression of curve, and there are multiple publications on same. When we're looking at congenital scoliosis, there are of two types. There's failure of formation and failure of segmentation. The failure of segmentation are subdivided into the fully segmented, semi-segmented, and non-segmented. Why would it matter? So because if it is completely, that is non-segmented, for instance, it's a block vertebrae, it will not have any epiphyseal growth plates in between. So when a piece of chunk of bone is not having multiple epiphyseal growth plates in between, the curve is unlikely to progress much further because the growth is still pending. The growth is completely over since there are no epiphyseal plates in between. In contrast, in a semi-segmented or full multiple segmented bone, there are multiple epiphyseal plates that are still present below the disc on both the upper and the lower part of the vertebral body. And that is why the curve is more likely to progress more. And that is why this is a more likely candidate to require bracing or casting. Failure of formation is nothing but where the segmentation is okay, but the vertebral body is not formed properly. So predicting curvature worsening is what this is about, early onset scoliosis, predicting which patient will require a brace, which patient's curve is going to progress. This is what we are trying to figure out in early onset scoliosis. So anomalies of the thoracic spine tend to progress more. Fully segmented hemivertebrae tend to progress more. Hemivertebrae on the opposite side with a set fused vertebrae are more likely to progress more because this side there are epiphyseal plates, whereas on the other side it's completely fused and there are no epiphyseal plates. Block vertebrae, when we see, these are not the kind of scoliosis that are going to progress. So those are not the candidates for bracing or casting. Looking at the third type, that is the neuromuscular scoliosis, it is more associated with CP kids, SMA. These are all children who are severely affected mentally also, and they have curves not only in the spine, but they also have a pelvic obliquity with high frequency of concurrent kyphosis. Syndromic scoliosis, these are Marfan's, Ehlers-Danlos, these have multiple flexibility issues. They are generally flexible curves. The evaluation and diagnosis of a child with EOS basically is X-ray whole spine, MRI whole spine plus minus CT depending on what type of subtype it is, and an ultrasound abdomen to look for any renal anomalies or any other malformations which are associated with the formation. Thoracic insufficiency syndrome, I've spoken about it, that on the concave side of the curve, which usually the lung will get constricted with multiple lips can be getting fused, and which will lead to a thoracic insufficiency syndrome. Generally, if a curve is above 70 degree, it will most likely be associated with thoracic insufficiency. So we also look at Reser's grade and standard grade, but that is more for adolescent idiopathic scoliosis rather than for EOS, where the grade doesn't matter because the fusion is the plates are still growing. Looking at the surgical management, so currently my experience is with just 3 cases of bracing. These are not my cases; these are just images that we have taken up from some good papers. The 3 most common type of brace is the Milwaukee break, Boston break, and the third one is the Wilster brace, and these 3 braces are just able to prevent the progression, but are not going to treat it in any way. How to choose whether a patient can be braced or not? It's based on a lateral bending film. If the curve is mobile and flexible and getting corrected on a lateral bending film, brace will work. 3D braces are great. Cast treatment wise, we have Min Mehta's cast from UK, which has been used for very, very young children. Cast is changed every 3 to 4 months. Minimum of 5 casts are required. It's based on elongation, derotation, and flexion technique. A 13-month-old child with infantile idiopathic scoliosis. This is a child with the scoliosis. The MRI is normal, no other deficit. This is the type of casting that happens. We leave the lung space open for the child can breathe. The cast is changed every 2 to 3 months. Till it gets corrected, and this is the type of correction that we can expect with simple casting in case of early onset scoliosis. Gravity halotraction is another mode of treatment which is available, especially for the neuromuscular subgroup of early onset scoliosis. It is very helpful in correcting the very stiff curves that are coming. Short exercises, we don't have scientific evidence to suggest that it is working. Last part of my talk, we have 3 surgical treatments: hemiephysiodesis, hemivertebral resection, and growth-friendly surgeries. They are restricted only when the curve magnitude is more than 30 to 40 degree, or if the progression is noted at follow-up to increase more than 10 degree. Hemiephysiodesis is nothing but stapling of the hemiphysis. It's done by the lateral approach. Hemivertebrectomy works well when the child has crossed 3 years of age. A short segment fusion will help in prevention further progression of scoliosis. Growth-friendly surgeries are distraction-based versus compression-based. The distraction-based are traditional growth rod systems versus the magnetic ones which are available. The rib-based systems are not available in India, where they are expanding the rib to improve the pulmonary function. The compression-based systems are stapling, tethering, Sheila technique, Luke rod. Sheila technique is nothing but fusion at the segmented level, just last 3 slides. with sliding hooks kept superiorly and inferiorly. So as the spine will grow, the rods will slide along as is seen in the X-ray, so that the growth can be achieved for the child. Loop trolley is nothing but sublaminar wiring. This is vertebral body tethering, which is done by the lateral route. And the last slide is the main intention of treating EOS is to promote ribcage expansion and lung development in these children. Results are still tricky, and ongoing studies are there to test whether it's really effective to treat EOS. Thank you.
Thank you, Dr. Tarang. It's a great lecture. Anyone wants to make some question here? No one? Okay. This panel was really important. It highlights the importance of prevention. In Brazil, most of these topics are discussed under pediatric neurosurgeons. It's a great idea to bring for Spinal Congress this discussion. For pregnant women, our legislation adds the folic for everyone. Even in foods, in farináceos, there is a law that must add also acid folic. So increasing the diagnostics of antenatal spinal dysraphism, early diagnostic is mandatory, and we must develop more training centers for open intrauterus surgery, and we have to work together to make these efforts be worldwide. As I am here representing N20 in Brazil, I hope these lessons can bring around all the BRICS country and N20 countries. Thank you.
Thank you. Thank you very much. Now we'll close the session.
Thank you for the opportunity. Thank you.
Thank you all the speakers and the chairpersons for running the session. For wanting of time, we are just continuing the session. We move on to the third session, that is pediatric CVJ and spasticity. That is the last session for the day. I would request Dr. Venugopal, Dr. Parthik Band, Dr. Jagnath Lal for chairing the session. Sir, please come onto the stage.
Okay, I think we are running late, and we start this session with the pediatric CVJ anomalies by Dr. Raju Subha.
Afternoon. Good evening, sorry. So I'll be talking on pediatric CVJ in front of two giants sitting here, Dr. Muthu Kumar, Dr. Sushil Patkar. I'll not go into those areas. So not more of a theoretical, it's the issues which we face with pediatric CV junction anomalies, which we will be going to discuss. And so this is a complex area, embryologically, anatomically, and biomechanically. So clinical features often result from three biomechanical processes: the instability, deformity, and the neuroaxial compression. These are three things which we look at. And different sorts of different craniovertebral junction anomalies will affect individually different places. Fundamentally, the ligaments, the important ligaments and the development has to be kept in mind, because the developmental pattern of these CV junction anomalies also tailor our treatment. If you look at the ossification pattern of C1 and C2 is slightly different. C2 is more complex than the C1 development. And when you talk of pediatrics, the age is more important. And the ossification happens from 6 months to 13 years of age, and for different stages. So our fusion, decompression, and everything has to be tailored according to that. The neurodevelopmental outcome evaluation in these children are mandatory. Head control, sitting, locomotion on flat surface, standing and walking has to be taken into consideration. And as I told you about the age of development, when you try to manage this CV junction, set of investigations mandatory like the MRI, MRV, if you're dealing with the occipital bone, a CT, 3D CT with an angio, a mandatory. I'll come down the line, I'll tell you why important it is. Dynamic motion study of the either an X-ray or a provocative test are required in some cases. On-table SSCPs and may be required. So if you come to the most simplest management of CV junction, you can look at this. Neural compression, yes, no. Yes, with instability, yes, decompression, fusion. No decompression without fusion. And if there is no neural compression, just observe. This is the most simplest of the classification when we talk of bony CV junction anomalies. And then this soft tissue, the Chiari malformation comes, they also come under CV junction anomalies, but I'll not be discussing much. And the traditional foramen magnum decompression, duroplasty, resection of tonsil. If it is a second acquired Chiari malformation, then taking care of the primary cause, very important. And of course, I will not deal into C1, C2 fusion for Chiari malformation for better reasons. And Chiari malformation 2 also is same way, dealing with if it's a primary or acquired, we have to deal according to with that. There is a challenge in instrumentation in children. Everyone who does this pediatric CV junction, you know that the diameter of the pedicle, the smallest screws available for the pedicle is 3.2 mm. And nowadays, 3.5 was the standard, but nowadays 3.2 is available. Bone maturity and fragility is an issue, and the presence of syndromic anomalies. Even after rigid internal fixation, the fixed occipito-cervical and atlantic distance increase in close to half of all the children which were treated early in life. In children, anatomical considerations are relative size of the head compared to the spine. They are large heads. And when we are thinking of transarticular screws and these things, this can be a limiting factor. Coming with the simplest of example which we get, it's an 8-year-old boy, starting with in between some examples. Traumatic AAD with rotatory subluxation, and many of us will see this in day-to-day life. So we went with a posterior approach only, C1, C2, reduction and fixation. So issues in this case were, if you can see, we have put a screw. There's a small pedicle. There is anatomical distortion. We use navigation. But the good thing is that some amount of medial breach is allowed in these cases when we go for a posterior fixation. And we should not be bothered about the diameter. If it is around 3 millimeter also, if there is a small amount of medial breach, we can go ahead with it. This is the simplest of the case of rotatory subluxation, where bit amount of traction and opening of the joints takes care of the things. The challenge comes here, AD with Down syndrome. The syndromic children are very, very challenging. 9-year-old female with compressive myelopathy. This is a case which I have done around 10, 12 years back. So simplest of the thing, we posterior decompression and fusion. And but the child continued to have these compression persisting. So we did a in the second stage, after the fusion has happened, we went and did a transoral orentomy, which was more challenging in a child with Down syndrome because of the other issues. This is another case, AAD with basilar invasion with severe compression. Again here, there was the issue of anomalous vertebral artery and crossing across the joint. So in this case, we did a OC2, C3. And because of this anomalous vertebropathy, the pseudo joint also could not be open. So we didn't achieve a reduction in this case. We just went ahead with the fusion in this case, and then followed by a transoral odontectomy. If you have an O-arm or a 3D C-arm in these cases in the OT, it's very, very helpful because a preoperative CT planning sometimes may not be matching when you take it onto the table, and it may not be suffice actually. So an on-table navigation is sometimes useful, and this is opening up of the joint, in pedicles, in the anomalous vertebral artery, same case. I'll not go into detail, and then followed by transoral odontotomy. This is a post-op odontotomy done and a posterior fixation has been done. Similar cases. Now comes an interesting case, 2.5-year-old girl, acute onset gait imbalance, right-sided weakness with slurring of speech. This child, on the MRI at 1.5 years of age, was incidentally detected to have a Chiari 1 malformation. And CSF flow study showed a restricted flow out to the cervicomedullary junction. And child was under regular neurosurgical follow-up. If you see here, she has some amount of hypotonia, and there was right hemiparesis. The neurologist diagnosed as acute onset right ataxic hemiparesis with right human facial palsy. These are the anatomical things, and all these things discussion. And etiology could be a vascular thing, inflammatory or demyelination. So there was a small infarct here, cerebellum, and the initial MR angiogram was normal. So CT of the CV junction with flexion extension was done, which was normal. And if you see here, the Chiari 1 deformity associated with erosion of dense and transverse ligament hypertrophy was diagnosed based on the MRI. Child underwent a foramen magnum decompression along with the decompression surgery. Post-op was put on Philadelphia Keeler. Weakness improved at discharge. 20 days post-op, she developed a left hemiparesis, which progressed to quadriparesis, bulbar dysfunction, and then speech also regressed. Repeat MRI didn't show any acute changes. All other investigations are done. So next we thought of provocative angiography. So dynamic digital subtraction angiography was done. So this is a left vertebral artery with the head in neutral position. Left vertebral artery with neck turned to the left, and left vertebral artery with neck turned to the right. So this becomes the provocative is sometimes helpful. And similarly, right vertebral artery in neutral position with head turned to right, head turned to left. So bilateral vertebral arteries are getting occluded when there is a turn to the opposite side. So this becomes a classical case of a Bauer-Hunter syndrome. So we analyzed that. Surgical intervention, simple C1, C2 fixation was done, and child did well after that. So we had similar, then started observing. We knew that there is vertebral artery angiogram has to be studied in all CV junction cases. But provocative angiogram was other thing which came into the play gradually. So when we looked into the, we had a series of around 8 cases of posterior circulation stroke following a CV junction anomaly. Out of those 8 cases, 4 cases were of Bauer-Hunter syndrome. So this is a management algorithm, and this was published on cryptogenic. 6 out of 14 cases posterior circulation stroke, we had a CV junction anomaly, and plus we have 2 more cases. So only provocative X-ray is not sufficient in suspected case of posterior circulation stroke. Sometimes you have to go for a provocative angiogram. There are other controversies. I'll not go into this issues. I'll just go for the conclusion. So developmental anatomy of CV junction we have set to dictate the choice of methodology of treatment, and provocative testings are required in those. It's challenging. Internal fixation fusion gives good long-term results, and complex anatomies may require intraoperative technology and guidance, like an OARM or an 3D CARM. Techniques for pediatric population, including your implants, is still evolving. Thank you very much.
Thank you, Dr. Subrat Raju, for that wonderful presentation. Pediatric CV junction anomalies are a difficult territory in spinal surgery. May I invite Dr. Muthukumar to give any comment on this, on your experience?
Among pediatric CV junction anomalies, syndromic anomalies constitute a special problem. Especially one child was the achondroplasia, isn't it, or Down syndrome?
Down syndrome.
I think that child had probably impingement from the posterior arch of atlas. Because many children with Down syndrome, the posterior arch will not only be bifid, medial end of the posterior arch will be impinging inside.
Narrow canal.
Be narrow. It will be, posterior arch will be bifid. Then the medial end of the bifid posterior arch will be impinging on the cord. So did you remove that?
The first stage surgery was that only actually.
Okay.
The first stage surgery, which I told you, we knew that there is a compression, there is an ADV, so we thought that we can manage within a posterior. So we did a decompression and fixation. The Down syndrome child.
Down syndrome.
Yeah, in first stage we did a decompression and fixation. Foramen magnum, C1 arch.
Your 8 cases of
Posterior circulation stroke.
I think this is a fairly large series. The only other series which I often remember is from and sometimes ago.
That we published already.
This is good. If possible, send me a copy of that article. Very nice.
Thank you, Dr. Subodh. Yeah, please.
There is one paper from Brazil saying that in pediatrics, CV junction anomaly type 1, they do ultrasonography of the CV junction. If the CSF flow is less than 3 millimeter per second, then they don't open the dura, just do body decompression. And when it is more than that, they on the reverse actually, they do open the dura when it is less than 3 millimeter per second. And if it is more than that, they don't open. Do you have any experience about it?
No, we don't do an you're talking of the Chiari malformations.
Yeah.
Duroplasty.
Duroplasty. So the most of the cases for our practical understanding, we strip off the outer layer of dura. Strip off the outer layer of dura and leave it. If there is a good pulsation, we just leave it. We don't open the dura and duroplasty. My experience is that.
Thank you very much. Now I invite Dr. Bala Murugan S. from Chennai. He'll be speaking.
Question. In Bow-Hunter syndrome, recently I operated one case of young patient around 18 years with Bow-Hunter. He had additional dissecting aneurysm. That before doing surgery, it is stented. Then after that, we fix it. Have you any experience about that?
No, we didn't have any aneurysm.
Next topic is surgical challenges in pediatric CV junction surgery.
Good evening, everyone. First of all, I want to thank the organizing team and Manas sir for giving us the opportunity to talk on our surgical experience in the pediatric CV junction anomalies in our tertiary care institute, Madras Medical College. Why it's a surgical challenge? CV junction, always it is a surgical challenge, especially in pediatric population, because of the excessive mobility of the bone, and the arrangement of the bone is like that. It is a flat, and there is laxity of the ligament. This is the main reason for the surgical issues. And so whenever if you have any suspicion, especially in trauma and also in congenital variations, always look for early diagnosis. Have suspicion, do proper evaluation on that, and then only we have to plan. Because most of the times abnormal anatomy, abnormal vasculature will surprise you at the time of surgery. Intraoperatively also, positioning, blood loss, and the bony maturity plays a major role. I will discuss in later slides. Post-operatively also, our goal should be a proper fusion rate at the end of the surgery. And we have to avoid pressure ulcers because it will lead on to infection at the later stage. During the evaluation, you have to concentrate more on CT and MRI. Whenever if you are planning for a CT, always take a lateral mid-sagittal section with flexion extension views. And please do 3D reconstruction if you have suspicion of any assimilation of the atlas over the axis or assimilation with or occipitalization. Do 3D reconstruction. That too, in coronal cuts, you can very well identify the pathology. And whenever you are going to do a CT scan, we have to concentrate on CT angio to find out the abnormal vasculature. MRI scan, it is always diagnostic, and you can very well address the compression, signal changes, and especially in MRI, you have to give concentration on transverse ligament and alar ligament integrity. This is very, very important. I will discuss some of our cases.
trauma, and congenital variations. C1 and C2 fractures, always look for transverse ligament injury because it is a dense ligament. It will hold the dens at the odontoid at the place. If there is a fracture, look for transverse ligament injury because transverse ligament injury, if it happens below the 8 years, there is due to the high fulcrum of motion, most of the patients will develop instability. So if there is a transverse ligament injury along with the fracture, always plan for surgery. It's a case of a child, Anushri. Actually, the patient has been treated outside conservatively for 4 months and came to us with the progressive quadriparesis and severe pain. We did, and we could able to see the partially fused C2 at the level of odontoid type 2 fracture. And we did the C1, C2 fixation for this child, and the patient recovered. This is another one boy. Jaydev is an 8-year-old boy, came with RTA with fracture C2. So what we did is, we did thorough evaluation and we found that the excessive motion happening, and apart from that, there was a fracture lamina of the C4. This is the MRI, lamina is impinging and there is fracture is there. So we did C1 lateral mass and C2 pedicle screw fixation. But post-operatively, the patient complains of keep on complaining pain. So post-operative X-ray showing the whole segment is moving over the C3. That is the reason that this instability is causing all the problems. So what we did, we have incorporated C3, C4 also here, C1 to C4 fusion, and the child recovered well, pain gone. So always concentrate on look for transverse ligament injury. If there is no fracture or suspicious of fracture, or if there is a suspicious of transverse ligament injury, later on it will lead on to instability. Even without fracture, sometimes the transverse ligament injury will lead on to subluxation like this. This is one such child, Gautam. This patient, no fracture, but trivial injury 1 year back, slowly developed quadriparesis, and this is the CT and MRI of the child. Instability is there, and we did C1, C2 fusion. So coming to the congenital anomalies, we have to concentrate on, especially if there is os odontoideum or basilar invagination, assimilation, these things we have to evaluate thoroughly. Os odontoideum is nothing but the whether it might be a orthotopic type or dystopic type. Orthotopic type is the dens will be in the normal position. Dystopic variety will give more problem because it will be moving and it will produce more compression from the ventral aspect. At the same time, the posterior arch of the atlas will give compression from the posterior aspect, and it will lead on to progressive quadriparesis. And always look for bifid spine if there is os odontoideum, that too in syndromic children, because whenever the child is having a bifid spine, it should form a ring at the age of 3. If there is no ring formation after the age of 3, definitely the child will develop instability at the later date. So please monitor this and check for the instability. Dynamic images will help us in this scenario. If there is instability, we have to do fusion. If it is a irreducible instability is there, we have to fusion. If it is irreducible, then we have to plan decompression along with the fusion. This is one such case of os odontoideum. Veronica, a 5-year-old child, had a os odontoideum with subluxation. Dynamic images shown that very well. Significant compression over the cervicomedullary junction, and we did the C1, C2 fixation for this child. Standard procedure, and the child recovered well. Always the congenital anomalies are very challenged because basilar invagination, assimilation, syndromic children, all these things need elaborate evaluation, because atlas assimilation mostly in conjunction with basilar invagination and Klippel field. Most of the time, due to the reduced posterior fossa volume, hindbrain herniation also common in this scenario. And the atlas assimilation, later on it will lead on to atlantoaxial instability. Slowly the child will develop basilar invagination, reducible. If you are not properly treat these children at the age of, after the age of 14, 16, it will produce irreducible basilar invagination and progressive neurological deficit. Whenever you see a case, if the patient is having torticollis child, look, it might be due to unilateral assimilation.
Four types of assimilation is there: unilateral, bilateral, focal, segmental. If there is torticollis, it is due to unilateral. So before entering into the basilar invagination, you should know about the craniometric lines and all. This is for the residents. We are concentrating Mecrae and we are following the Mecrae and the Wackenheim's clival canal. So basilar invagination is nothing but abnormal odontoid process invaginating into the posterior fossa, usually and commonly associated with occipitalization, assimilation and block vertebra. 1/4 of the children will have Chiari, and some of the cases will have, and most of the time platyphasia also will be there, and it will produce the angle will be more, and the indentation over the medulla or cervicomedullary junction will be there. So what to do? Approach. So many authors, different approaches are there, either anterior or posterior. Based on that, we have to select. If there is assimilation, you have to check. This is a case of assimilation. C1 is assimilated with the check with the coronal axis. You can very well see the assimilation. So most of the time, rotatory component is also present in this scenario. So intraoperatively, you have to correct it. If you are taking dynamic X-ray or CT, please plan for CT angio also to look for vasculature abnormalities. So many vascular abnormalities have been described in literature and the textbooks, including the fetal pica. This is one such case. Dhanush, a case of basilar invagination. This patient came to our OP with respiratory distress with quadriparesis. Immediately we intubated the patient. We did tracheostomy and we have stabilized the patient for 5 days. After that, it thoroughly evaluated. There was a complete narrowing at the level of the foramen magnum. So what we did, endoscopic assisted microscopic excision at the level, but we could not able to achieve complete removal of the dents. So what we did, posterior approach again. We did foramen magnum decompression and then occipitocervical fusion. Slowly the boy improved, the neurological status slowly improved, and he is in the follow-up now. This is another one case of platyphasia with basilar invagination with assimilation. See the interesting finding. The tip of the dents is touching the posterior lip of the foramen magnum. There is no space for the cord. Here also there is a minimal space for the cord, and the MRI shows significant compression there. So we are worrying whether to go anteriorly. If you drill, if you give too much compression, it will damage the thing. So what we discussed the options with the parents, and we have gone for the posterior approach, occipitocervical fusion. We have informed them later the child might require the anterior approach for transoral approach, but the child recovered well. Still she is in the follow-up. We have not done any anterior approach. So while putting screws like this, most of the times if you put screws like this, it will go for screw breakage. This is a practical point. Whenever you are selecting for a pediatric case, go for this type of screw in the ankle. Nowadays screws are available and you can select this kind of screws to avoid screw breakage. And whenever you are planning for the screws also, putting the screws also, CM is a 2-dimension image. If our target should be the reaching the anterior tubercle, but post-operatively if you take CT, the picture will be like this. So be careful and look for spina bifida in especially pediatrics. And syndromic children, especially Marquez kind of children, will be very difficult to treat because multi-segment, multi-organ disorder with so many congenital abnormalities will be there. But as a neurosurgeon, the skeletal dysplasia is a worrying factor for us. And thoracolumbar scoliosis will be there, bullet-shaped vertebra will be there, instability will be there. Just two cases, sir. So first thing is it necessary to operate? That is what the anesthetist and the pediatrician will ask you, because most of these cases will develop cervical myelopathy, respiratory insufficiency will be there, cardiac abnormalities will be there, and so anesthetic consideration is also there, difficult intubation due to cervical instability, and most of these cases will have chest wall deformity, so it is very difficult to position the patient. Due to the short neck, very difficult to put the screws also, and screw holding capacity is also a major question mark. But our goal is to protect the spinal cord, to relieve the compression, at least to give a proper quality of life for the rest of the life. So either you have to plan for foramen magnum decompression with fusion, either C1, C2 or occipitocervical fusion, depends upon the bony maturity. This is only two examples. This is Sudesh Kumar, 8-year-old boy with progressive quadriparesis, hypertonia, hyperreflexia. This is the classical. And we did C1, C2 fixation and neurological status recovered. Here you can see the bifid spine. If you are planning for the same angle, where will the screw end? It will go here. So always before going for surgery, take proper CT or X-ray and find out what is the bony, whether it is matured or not. Based on that, we can plan. This is another one child, Yogeshwari. The same findings, quadriparesis with Marcus. Diagnosis as a case of Marcus, but we could the bones are not properly matured, so we have planned for occipital cervical fusion. That too, intraoperatively we struggled a lot. Finally, we ended up with laminar screw on the left side and laminar wiring on the right side, and the child recovered well. We did rib bone graft for the children. So in adult case, we can have a transarticular screw. We can put translaminar screws we can put, but in children our choices are very narrow, either occipital cervical fusion or the C1 C2 fixation, or as per Sushil Parkar advice we can go anterior approach also. So to conclude it, whenever there is a trauma at the level of CV junction or congenital anomaly, have a high suspicion. Always take dynamic images if you are planning for CT. And to rule out assimilation, we have to plan for coronal CT and 3D reconstruction. Always check for vascular abnormalities. In MRI, please rule out transverse ligament injury, and the positioning and the blood loss is very important. And bone depends upon the bony maturity. You can plan your choice procedure of choice. Thanks for the opportunity. Thanks for taking
Thank you, Dr.
Thank you, sir.
As we exceeded the time, we should go for the next talk. Dr. T.S. Vasan will talk on 3D printed module in syndromic AAD.
Good evening, ladies and gentlemen. I thank Dr. Manas and his team to give me this opportunity. I would like to share our initial experience in surgical management of pediatric syndromic craniovertebral junction anomalies using a 3D printed module in a tertiary care center. The challenges and complexity of managing pediatric craniovertebral junction anomalies, has already been told by the speakers, is precisely diagnosing the CVJ instability. And in this age group, apart from having a slender, small, and even sometimes cartilaginous bones, the conceptualization of preoperative radio images to 3D hypothetical images in the mind comes only by experience. To this end, the 3D animated module will simplify understanding the pathological biomechanics in all the three planes, and its reusability as well as the multi-angle specimen observation of anatomy, and one can easily rotate the vertebral bodies in the with the physical specimen and understand the spatial relationships before being to plan optimal surgical strategy, and also it reduces the learning curve. I want to exemplify with these things with my three cases. First case was a 12-year-old male who presented with the neck pain and restriction of the neck rotation with the neck tilt of 4 years duration, and headache and weakness in all the four limbs falling forwards for 2 years. And he was almost bedridden with an inability to walk for over a week before he presented to us. Power in the right upper and lower limb was 3/5. Left side was 2/5, and wasting of the upper limb muscles. There was a left side ptosis, facial asymmetry, and vertical nystagmus with only 50 degrees of neck rotation was possible, and the deep tendon reflexes were all hyperbrisk. The MRI scan showed tonsillar herniation with a card hyperintensity at C2 and absence of posterior arch of C1 and a retroverted dens, and there was a crowding of the foramen magnum with the obstrict, the dilatation of the fourth ventricle. Dynamic CT scan showed platybasia, basilar invagination, and absence of the posterior arch of atlas, including the posterior tubercle, corresponding to the type E classification of Curarino, there was a C23 block vertebrae, so corresponding to the, akin to the Klippel-Fill deformity. The challenges in this case was the anterior lateral mass of the atlas was totally anterior to the C2 parts, and abnormal course of the vertebral arteries over the joints, which was hardly could be seen. And the 3D printed module clearly showed us the anatomy with one can see the lateral mass of the atlas totally anterior to the C2 parts in the superior facet, and this gave us proper information before the surgery to for the entry as well as the trajectory of the screw placement. The patient underwent suboccipital craniectomy and occiput plating along with the lateral mass screw fixation to the C23 as well as the C4 lateral mass screw placement with a reduction of the basilar invagination under traction. This is the post-operative CT images, bilateral C2 pars screws as well as the C4 lateral mass bilateral screws with post-op day 1 image of the patient. My second case was a 7-year-old male presented with the chief complaints of the weakness in the left upper and lower limb for over 6 months. Power in the left side was 4/5 and with the hyperbrisk reflexes. The MRI cervical spine showed retroverted dens with AAD, the compressive myelopathy for a length of 2.3 centimeters, and anteroposterior diameter at foramen magnum was just 2.3 millimeters. And there was a widened cervical spine, subarachnoid space spine, as well as the lordosis of the cervical spine was reduced. The CT cervical spine showed the atlanto-occipital assimilation, which is quite common in the general population, almost 2.8%. There was a retroverted dens with AAD and other congenital anomalies like dextroscoliosis of the cervicothoracic spine, etc., were also present. The CT angio showed overriding of the left side vertebral artery over the C1, C2 joint, which was once again, it was clearly seen by the 3D module, the configuration of the left side vertebral artery along with the assimilation of the atlas. And the patient underwent C1 lateral mass and C2 pass screw placement under traction to reduce the AAD. And intraoperative X-ray shows the pen-filled dissector inside the C1, C2 joint, which was drilled, and the bone chips were placed for the fusion. And we always used rib grafts in all these cases for permanent fusion of these surgeries. And we have used 14 to 16 mm long pediatric lateral mass screws available with a 2.5 dia. And we used fully threaded screws. Postoperative, this is the CT scan showing the C1 and C2 lateral mass screws in place. And after a week, the patient was discharged and in good condition. My third case is an 8-year-old female patient who presented with weakness in the right upper and lower limb of 6 months duration. Power in right upper and lower limb was 4/5, and deep tendon jerks were hyperbrisk. MRI scan showed os odontoideum, and dens was posteriorly subluxated with the cervicomedullary junction kinking, and the T2 hyperintensity extended right from the cervicomedullary junction up to the C3 vertebral body level, and there was a loss of anterior subarachnoid space. The CT scan confirmed the os odontoideum, and which was subluxated right side laterally, and with the BI with the retroflexion of the os odontoideum, failure of the fusion of the hemiarches of the atlas, C2-3 partial block vertebra, and other congenital anomalies akin to the Marcuse syndrome were present in this case. And CT cervical spine with angio was normal otherwise. Once again, the 3D module showed clearly the subluxation of the right lateral C1C2 joint with right side tilt. And the intraoperative picture, the BI was reduced under traction and C1C2 screws were placed. And this is again the intraoperative picture with the instrumentation as well as the bony fusion done. Post-operative CT and the X-ray cervical spine shows instruments in situ. And this is after a year the child is going back to the school. To conclude, 3D physical module translates the 3D imaging very well for the proper understanding of the C1C2 facet dislocation or vertebral artery anomalies, aberrant arteries, or type of correction required, etc. It is convincing that it will definitely improve the results, especially in complex pediatric TV junction the pathology, giving ready-had information before and even during the surgeries. It provides excellent tool too that for education of junior neurosurgeons. I thank you for the patient hearing.
Thank you very much, Dr. Vasan. It's a very beautiful talk.
Thank you, sir.
And I routinely use 3D models for all my CV junctions,
3D,
irrespective of the type of cases. It's not really the visual appreciation of the 3D, the way it has developed in recent past in radiology, but when you have the model in your hand, your proprioceptive knowledge is absolutely fantastic, and whatever you touch and whatever you do, you're going to do the same thing in the operation theater.
And even in the OT itself, you can
Yes.
keep it
Yes.
next to you and keep seeing that. So.
I use it very routinely. There are many models are coming, many designs are coming. The machines that make are of different types. The basic thing is the FDM model, fusion deposition model, and then DLP model, SLA, SLS. Why I'm able to say so much is because we were the first to do the cranioplasty 25 years ago with rapid prototyping technology. That time 3D printers were not available, but now 3D printers are available, and
Yes.
probably I think the appreciation, and we are ready to start working on that much more practical. And I think I will go to the next. Is there any comment from the floor? Thank you, Dr. Vas.
Thank you.
Now, an important person is going to talk to us now, Dr. Purohit. Dr. Purohit is my old friend, and I have to stand up and say, welcome. The reason why I wanted to do a small introduction, 25 years ago, there was only one person who was talking about something for spasticity, and that was him. So we need an applaud first before he starts the talk. Right. I'm not talking each and every hospital he traveled. Like Professor Ramani went on a spree to make neurospine a stop in the country. Dr. Purohit was going everywhere and teaching how to do spasticity surgery. And so that was the kind of person who is going to talk to us in front. Welcome you, sir. Thank you very much.
Thank you very much, my dear chairpersons and the august audience here. And with all the blessings of Dr. Shastri, one of my inspiration here, and thanks to Dr. Manas, jahan man mein aastha ho, wahan pe manas. So thank you very much for all of you. And there is a limited time, so let's go ahead a little faster and see that what best justice we can do in the 10-12 minutes. So neurosurgery in spastic dystonic disorders, I'm mainly talking about. There are so many methods by which we can relieve the spasticity. And it is very difficult for each and everyone to know all the types of the surgical procedures. So if you can see over here, right from the, is there pointer? So something on the brain, something on the spinal cord, something on the spinal reflex arc. So some of the methods are intracranial on the brain, that is CNS. Some methods are on the spinal cord stimulation, etc., on the spinal cord, and another is the intrathecal baclofen pump. So these green ones are the non-ablative procedures like botulinum toxin here. So whole of this passage of the transmission of the impulses, one can see that the non-ablative procedures can be performed there. Whereas there can be intracranial procedures where also one can produce the lesioning, or one can be selective posterior dorsal rhizotomy, selective motor fasciculotomy, or some of the orthopedic surgical procedures. Now, this is the spinal reflex arch, which we mostly work on this nowadays, and then we are weakening the excessive impulses which are going to the muscles. These are the neuroablative procedures where I just now mentioned about the, well, most of our talk will be on the sensory rhizotomy or motor fasciculotomy, and somewhat on the baclofen pump and botulinum toxin. But still, to the younger generation, it has to be known that science is still searching for the best treatment, that is the how you can replace the damaged portion of the brain, and that is what is still lacking, and this will take a little more time. But we do not advocate stem cell therapy for the brain pathologies of this kind of static encephalopathy. Very important is that not only spasticity, but you have to know various other types of the pathophysiological impairments like dystonia and ataxia, etc. Because something will work, some surgery, something will be contraindicated. Say sensory rhizotomy is contraindicated in ataxic cerebral palsy. Well, topography, again, whether both the lower limbs or all the limbs or focal, one has to be. Associated means how much is the motivation, mental subnormality, etc. Based on that, one has to decide. Complications, say multiple contractures, this spasticity alone removal will not work. So these are the various pathophysiological types which one neurosurgeons and neurologists have to learn, and associated all various types of the disorders also play important role in the prognosis. Like this, multiple contractures will also play the role whether you should remove spasticity in such a condition or not. So good clinical knowledge is very important, finding out that whether it is really harmful or not, or it is an helpful spasticity or dystonia. Well, these are some examples to, before I go for the procedures, that how pre-op condition, and then you are able to fit the orthotic also. This is stage procedures that one after another with some of the gap with the sciatic or tibial SMF and then soft tissue release. And when they keep growing, yes, you need the multi-stage, multi-level neuro-orthoplastic approach. I repeat, multi-stage, multi-level neuro-orthoplastic approach has to be in our mind, not the single-stage, multi-level orthopedic surgery. Sam Lowe's, which has become very famous, and they say, why every birthday we should operate? So this is what we are trying to propagate and inform to the scientific, that when they are keep growing, whatever is required to be sacrificed or removed or is harmful, that should only be cut. In a garden, if there are some of the branches are coming in your way, just cut them. Don't think of well in advance that, oh, this might come and I should cut it off. That way, we are trying to inform the scientific society, perhaps which is much more orthopedic dominant one. So let's see if all of you get also motivated. We should be able to say that neuro-orthoplastic, multi-stage, multi-level neuro-ortho approach. So this is how after surgery you can fit also these things. These are some of these pre-op and then post-op, how the SMF can improve their hand functions of ADL. In adults, now I have just now in last 2-3 months, 2 20-year-old girl and another is a 36-year-old married lady. or tried to hang themselves and it was unsuccessful hanging, and they have come with lot of spasticity, spasms. So CV junction, one is the how they commit the things, another is how the disease at the CV junction causes the spasticity problem, and sometimes we try our best, but still some kind of an iatrogenic problem can occur, or a residual problem in the form of an spasticity can be there at the CV junction, because you were talking just now a lot about CV junction. So I just gave you a few examples. Or there can be a cervical pathologies, even after surgeries, they may have spasticities and spasms. What surgery to be done? This person again with the cervical problem, spasms, not only spasticity, which is a monosynaptic pathway, spasms are polysynaptic pathway. And the management will differ, the goals will differ, results will differ. So this is say non-ablative procedure. We will always like to do that one first in a dystonia or generalized dystonia and spasticity. Better is to try, if possible, about the baclofen pump. And this is what trial is done. And recently now we are going to operate in Mumbai, where because of the thoracic disc, there was insult to the spinal cord, and 64-year-old person is having lot of spasms. He is in such painful agony. When we did the trial, he started telling happily to his daughter, yes, now I am happy to say good morning. That is what is possible even in the either disc itself of the thoracic causing the problem, and you do the successful surgery, but still the residual problem remains. You are also responsible to treat totally the patient and then see that you can do or you can refer correctly. So in this, now when we are planning, we don't want to open the spine. Minimally invasive spinal surgeon is going to assist us, and then we are going to put the catheter in such a way that minimally invasive way a spinal surgeon can push the catheter perfectly without any kinking there. So the role of you people also who are mostly dedicated to spine, and this is what a trial was done and how she was, and now so happily she sat down. This is after the baclofen pump in this girl, and this is, you might be knowing it, how we put the baclofen pump, how it can be monitored well. But there are, yes, complications in the children, much more common, seroma, etc. Now coming to the selective motor fasciculotomy, and I think it will be taking a lot of time. Just a moment, if I can run it fast. This is for a sciatic nerve that we expose the sciatic nerve, its fascicles there, and after the fascicles are exposed, we can see many of these fascicles. This is the tibial nerve in popliteal fossa, and you can go specifically to each of the muscle and section the some of the fascicles. From aesthetic point of view, from functional point of view, this wrist is not that much functional. This wrist is functional. Just removal of this by just median SMF and or ulnar, you can help them tremendously. These are some of the examples there. This is the rhizotomy with which we started. Sorry, this is again tibial, the setup. And this is rhizotomy. This is the position. And this is what is the posterior root, anterior root. And this is what rootlets, which we will section. And is there a video there? These are the post-ops. Sorry, I think there can be a video there. Yes. So we can see that how durotomy done, and then we take, and then on the table we stimulate and see the responses. The one which is clinically found to be very hyperactive ones, that will be sectioned over here. So on the table, you will be able to dissect those posterior sensory root and then rootlets and perform this surgery over there. Diffusion and so much. Okay. So this is the dissection which is done over there. This is from one of the boy which has now recently come, and he is doing very good after rhizotomy. He is now 24-year-old. somebody can help me. The rhizotomy was done and then he showed the improvement. Now this is 10 years back. Recently he is with us and he is going to get married and he is having hardly any kind of an residual problem. Well, with so many of these procedures, whether it is the botulinum toxin or ITB, intrathecal baclofen, or SMF or SPR, the problem with the families is that when they go to each one of these specialists, the one who knows what kind of a thing he knows, he says, this is the best one. So if you go to a rice shop and the person has got only one kind of a rice, he says, mine is the best one. So I request that we have to dedicate ourselves in such a way that we know not that perfectly each and every kind of a surgery, but we should be knowing what are the other options possible. So I say the professionals are biased with what they know and the families are confused as to what is best for their child. And they keep running around and most of the time of the development is lost there. So it's very important to know about this particular thing, that there are so many options possible, and in these so many options, one has to know at least one or two methods and then should know the indications of the others one. And all that will depend on your motivation, that even these people have so much handicap, but yes, still they are productive. And I know that in this particular field, when we started in 1988, I, as a neurosurgeon, was not knowing what is cerebral palsy and what is SPR. From there, we started our journey, and one after another, we developed so many these procedures and learned about it. The problem with this is an static encephalopathy or myelopathy. It's not a progressive one. So what happens that they are going to live and live. But then at the same time, it is not a kind of a life. Akbar says to Anarkali that Salim tumhe marne nahi dega aur hum tumhe jeene nahi denge. So the disease doesn't kill them, but the kind of the morbidity which they have, the life is miserable. Once you go into this field, the families, everybody get affected, and a slight blessings of us and some possibility of improvement motivate them for the physical therapy, which is the ultimate thing to improve the balance and the control. And Raghavinder was telling me, which I showed this slide perhaps many years ago, that how hard work this lady is doing, changing the shape of an iron into a useful utensil. And that is what we can do when these children do not have the good formed limb, deformed limb which they have. Our hard work is definitely going to help it. When I used to go to the school in my childhood, on roadside, this picture, these people used to work, and this is from Haldigati, Rajasthan. So we started in Tokyo also. We gave a time. That time nobody was doing any kind of a surgery. Thanks to Dr. Jogi Patisapu, he invited in Florida, and we gave the lecture on this SMF. He is doing SPR, but not the SMF. Many camps all over the country, around 70 we conducted in my 30 years of career during the NIMS. And ultimately, the happiness is everything in life. And somebody said that, why don't you take up this particular subject? Then my wife said, this is very difficult. There is no patient there. As such, you are not able to run your clinic here in Hyderabad. Then she said, why don't we go to a village? We went to a village thinking there will be no competition. We will have a lot of work. We invited the farmers. They came after eating everything. While going, they said, doctor, you will die of starvation in our village. He said, how come I will die of starvation? That was not my condition even in Hyderabad. They said that here in our village, we do a lot of yoga and hasya yoga and whatnot. So nobody falls sick. But to my fortune, one funeral was going from there. I said, see, your villager has fallen sick. That is why he died. No, he said, doctor, you have mistaken. He is not our villager. He is the doctor who was practicing before you here. The laughter, this endorphin releases spasticity. Please remember, physical and mental tension, the nociceptions. So it is also necessary pro-nature therapy to these families. Families I am talking about, not the individual one. is necessary. So we all should learn about those relaxation therapies, and Hatha yoga is one of them, which is my one of the favorite thing. Dr. Shastri just now asked me, first you tell me joke and then only you go there. Thank you very much to whole of the team who invited me and given me this opportunity. I tried to do a little bit justice to it, but I'm open to any questions.
Thank you very much, Dr. Purohit. Surgeon far ahead of time, because spasticity now, past 1 decade, we are doing extremely well. But in those days, 2-3 decades ago, he was the only cameo was going around the country telling what is result me. Thank you very much. And I think we have running short of time, and then we can move on to the next talk by Dr. Arvind Das Prabhu to speak on the intradural extramedullary Ewing's sarcoma, case report, and review of the literature.
So, good evening, everyone. So, I am here to present a case report on intradural extramedullary Ewing sarcoma. So, as to why I am presenting this case report, it's estimated that 0.5 to 2.5 individuals in a bunch of 100,000 people are expected to have a spinal tumor. So, that makes spinal tumor a rare entity, and finding an Ewing sarcoma in the spinal tumor makes it even more rare, and finding an intradural extramedullary Ewing sarcoma makes it a rarest of the rare of the rare. So that's why I'm presenting this case. So the whole story is about this child, a 12-year-old male child coming from southern Kerala, who presented with a history of occipital headache. He presented to us with occipital headache and some stiffness of the neck associated with pain over the cervico-occipital region, which had been like progressing over the past 4 months. He also had weakness of bilateral upper limbs, and we found that he also had profound weakness of bilateral upper limbs associated with the hypotonia and hyporeflexia as well. So we put him to an array of investigations, and his imaging came out positive for a intradural extramedullary lesion. It was spanning from the odontoid tip to C7, and which was contrast enhancing and heterogeneously T2 hyperintense lesion. And our first differential was schwannoma. So we took him, we put him on a bed, and we operated on him. We did a C2 hemilaminectomy with the C3 to C7 laminoplasty, and we took out the whole tumor. We did a gross total decompression of the lesion. So the frozen report was round cell neoplasm. So we waited for the pathology reports to come, and the whole pathology report was positive for a malignant round blue cells, which was suggestive of Ewing sarcoma. There is a CD99 positivity as well, and we did a FISH analysis as well, and it had come positive for a chromosome translocation of the EWSR1 gene on chromosome 22. All of this pointed to Ewing sarcoma. And next step, obviously, we sent him to adjuvant therapy. We sent him to a different institution because our institution does not offer radiotherapy and chemotherapy. So he was being on their follow-up. For the past 3 months, he's been followed up. He has undergone 2 cycles of chemotherapy, which was vincristine, adriamycin, and cyclophosphamide, alternating with etoposide and ifosfamide. So currently, he's recovering well. He's having upper limb powers of 2/5 now, and he's improving. So this was the story. And coming to the discussion,
Our case report is one among those limited case reports on this matter, and the commonest site for these kinds of lesions is the lumbar region, followed by the thoracic and the cervical spine. Our child had a cervical spine disease, and most of the cases in the literature, they have been reported in the first and third decade of life. And I mean, between the first and third decade of life, and our child had like the highest incident was in second decade, and our child was also like in his second decade. He was 12-year-old, and classic Ewing sarcoma, which has a only diffuse membranous CD99 positivity. It was recorded in our pathology reports, and he also had an EWSR1 gene translocation. So the current consensus is that for a normal Ewing sarcoma, the treatment would be neoadjuvant chemotherapy upon diagnosis by biopsy. But all these cases of intramedullary lesions, they have been like diagnosed only after he has been operated. Like only upon the pathology reports, they have been diagnosed as an Ewing sarcoma. So giving a neoadjuvant chemotherapy is not in the question. So all these patients are subjected to adjuvant chemotherapy, which is like currently there is no like tested and like formulated chemotherapy regimens available. Most of the people giving chemotherapy, they used various regimens and combinations of drugs. And Izubuchi et al., he has published a journal paper in a journal on clinical oncology, and he has reported that intradural extramedullary Ewing sarcoma has a poorer prognosis and conventional localized Ewing sarcoma than conventional localized Ewing sarcoma, and has a 5-year overall survival rate of 65 to 75%. Spinal Ewing sarcoma is aggressive, and patients typically have a short survival rate. It was like acknowledged with the paper from Bachi et al. It was published in Journal of Clinical Oncology in 2018. So concluding, intradural extramedullary Ewing sarcoma is an extremely rare malignant tumor which requires multimodal therapy with the craniospinal radiotherapy and systematic chemotherapy, and it has a very poor prognosis as stated by the literature. So newer regimens and newer chemotherapeutic strategies need to be like devised, and these are my references. Thank you.
Dr. Arvind, good presentation. Extradural Ewing sarcomas are more common because of the osseous origin, and they are very radio resistant. Do you have any evidence or literature on radiotherapy for intradural Ewings?
Actually, there are multiple papers. They have shown that Ewing sarcoma is like radiotherapy has like a better prognosis in Ewing sarcoma, but as to how much radiation is to be given, it's not been documented. In this paper by Izubuchi et al., published in 2020, they have like diagnosed that. They have like told that there is a 25 gray RT that has been given to their patients post-op, and they have seen a better improvement in the prognostic outcome.
Thank you very much. So we'll call the last presenter of this session, Dr. Shreyas Thiruvengadam. He's presenting on metastatic intramural primary spinal osteosarcoma. Dr. Shreyas, this side.
Oh, of course.
As we are running short of time, I request you all to keep to the time, and we have one more session before the dinner.
All right. Thanks for the opportunity to present here. I've come from quite far away. So pardon me if I trip over my words. I was just hoping to give a brief presentation on intradural primary spinal osteosarcoma as a case report, followed by a literature review. I am quite certain that all of us are just as hungry, so I'll promise to keep this as brief as possible. Now, with regards to osteosarcoma as a whole, we all understand that it's a primary bone malignancy. It arises from mesenchymal stem cells, and it's got a strong affliction for long bone metaphyses. In reality, the differentiated nature of these tumors make them quite hard to treat. The incidence is thought to be around 2 to 4 cases per million annually, make up a mere 0.5% of all malignancies. So, again, going back to the long bone metaphyses, they generally tend to occur in the proximal humerus or tibia, and you can see there highlighted that spinal osteosarcomas are extremely rare, and having extraosseous osteosarcomas, and in this particular scenario, an intradural spinal osteosarcoma is really obscure. And again, going back to the dedifferentiated nature of them, it makes targeted treatment quite hard. So curative intent really requires quite aggressive surgical resection and often preceding and a postoperative chemotherapeutic regimen, as well as due consideration for radiation therapy as well. And looking at limbic osteosarcoma of the high-grade subtypes, the 5-year survival is thought to be around 35%. But to be honest, this data is quite dated, and with the advent of stereotactic radiosurgery and better surgical techniques, the survival rates are improving. But in reality, spinal osteosarcomas have an even worse prognosis because of, one, the technical difficulty in resecting them, a very high recurrence, as well as the metastatic susceptibility. Moving on to the case itself, we have a not-so-pediatric patient this time. She's a 28-year-old lady who came in with a couple of weeks' worth of progressive right lower limb weakness. She had several episodes of fecal incontinence and had a subjective L2 dermatomal hypoesthesia. On exam, her cranial nerve and upper limb exams were completely normal. Her left lower limb was completely intact. But in her right lower limb, she had a dense monoparesis, scoring 2 or 3 for most myotomal movements. She did have normal tone, normal reflexia, but had reduced light touch sensation between L3 and S1. But going back through the patient's history, we found that she had a diagnosed left proximal humerus high-grade osteosarcoma. It was diagnosed 2 years prior to this presentation. The histopathological subtype was thought to be a dedifferentiated mixed parosteal high-grade osteosarcoma that was limbic in nature. After a wide resection of the lesion, she underwent intense chemotherapy and radiation to the humerus itself. And then a year after that, she presented with a T10 classical sensory level. And on initial investigations, you can see the MRI down on the bottom left of the screen there. She's got sort of a Bilski grade 2 tumor that's centered in the T10 vertebral body. And so we performed a tometer procedure on this young girl and did a T10 on-block spondylectomy and a T8 to T12 pedicle screw fixation for stabilization of the spine. And intraoperatively, we noted that the tumor was quite adherent to the anterolateral aspect of the thecal sac. And during the process of creating this plane between the tumor and the thecal sac, we inadvertently caused the durotomy, which we primarily repaired. You can see on this bottom right image there, she had pretty good placement of the screws and the corpectomy cage. And after surgery, she recovered reasonably well with an intact neurological exam, with the exception of some subtle hypoesthesias, the T10 level and down, with intact sphincter function. And she then had about 58 grades of radiation to her to the surgical bed and was initiated on second-line chemotherapy. And then going back to this presentation again, she's now presented obviously with dense monoparesis of the right lower limb. So that prompted further investigation in the form of an MRI of her spine. And we can see there that centered around the L2, L3 level, there's a recurrence of a lesion, but this time it's intradural. And so we then took her back to theater, did a L2-3 laminectomy, the midline durotomy, and piecemeal debulking of this fairly heterogeneous tumor, which, as most osteosarcomas have, had quite a few calcifications within it. Lots of soft components, as you see, with immature bone and osteoid components. And we sacrificed the L2 nerve root on the right, but still managed to get near gross total resection of the tumor. And the histopathological diagnosis was consistent with both her prior surgery from the T10 tometer procedure, but also her proximal humerus surgery. And postoperatively, the patient had a slight improvement in the neurological function, a subtle improvement with the right lower limb power, but she did lose hip flexion as a result of that root sacrifice. And despite having ongoing urgent continence, she did reasonably well from a rehabilitation perspective. The patient then underwent a repeat dose of radiation to this particular surgical bed and was initiated on last line chemotherapy. So just to wrap things up, I went through and looked at all of the published literature in intradural primary spinal osteosarcomas, and really there's only 5 cases that have been published, of which 3 were in humans, the other 2 were in dogs, and for some reason it seems to be quite common in canines. Going back to the humans, we can see that in the first 2 cases there, in 2008 and 2013, both of these were elderly patients who had prior exposure to ifenadilate contrast agents, which are oil-based and thought to be a cause potentially for her to have developed this lesion. In both of these, the hypothesis is that you can cause pretty significant adhesions within the spinal canal, and as a result of that, you can have metaplasia, which then results in the development of intradural tumors of various sorts. And then in 2019, Mehra et al. Published about this elderly gentleman, again, who had a primary osteoblastic osteosarcoma that was found to have no other partner lesions anywhere else. And then finally, there's then our case, which is the 4th published case ever of intradural spinal osteosarcomas, but the first ever case report of intradural metastasis from a primary lesion elsewhere. And our hypothesis really is that during the tometer procedure, by creating a durotomy, we introduced intradural dissemination via spinal subarachnoid spaces, much akin to when patients have other forms of neuroaxial malignancies, for example, like ependymomas. And I think this is certainly more likely than a hematogenous spread, wherein I think it would have been quite unlikely for the patient to have developed a isolated intradural lesion. Finally, just to wrap things up properly, I guess there are 3 main take-home points. The first really is that this particular case shows us again that osteosarcomas have an ability to metastasize to unusual sites, particularly through unusual metastatic mechanisms. The second point really is that, interestingly, despite the radioresistance that we ascribe historically to osteosarcomas, we didn't have any T10 recurrences despite the patient having presented 2 years after her initial operation. And perhaps this raises the point that with newer radiotherapy modalities, perhaps they're not as radioresistant as we initially thought. And finally, the last point is more a question as opposed to a lesson, and it raises the consideration for perhaps whether we should have considered whole spine irradiation, particularly in this young girl's case, given that there was a durotomy. And although we did not breach the tumor capsule, I think in high-risk osteosarcomatous cases where there's tumor capsule breach, if there's durotomies or if there's an inability to achieve good surgical margins, whether we should consider radiating the whole spine despite its drawbacks. But on that note, given I've run over time, I might open the floor to questions.
Yeah. Is there anything to ask from the floor side? Very rare presentation. Yes. Reduce it. The point is that how much resection you do around, right? That's what you're trying to say. That.
Yeah. So in the initial operation from that T10 tometer procedure, although we couldn't get margins per se, we developed a plane circumferentially around the tumor. There was a costa transversectomy on both sides. Developed a plane between the tumor and normal tissue, being the anterior longitudinal ligament. And upon removal of the bone, we couldn't see any macroscopic evidence of residual tumor. So that initial thoracic surgery was also a gross total resection.
And do you mean after this case? Do you mean that once you get the E-wings, that you would like to do the very aggressive radiotherapy?
Yeah, I certainly think so, particularly in young patients who have got an established high-grade osteosarcoma.
Any other questions from Pro? Okay, thank you. Thanks
for the opportunity.
Venkatam, thank you very much. I think we conclude with this session now. Then we go on with the next one. Dr. Manas?
Yes.
Thank you very much. Thank you.
Thank you, Dr.
Thank you,
Manas,
sir.
for the opportunity. Thank you.
Thank you, sir, and thank you all the speakers. Now we are heading on to oral poster presentations. That is the last academic session for the day. I would request judges, Dr. Subodh Raju, Dr. Komal Prasad, Dr. Naveen Mehrotra, sir. Sir, please come forward. Sir, have a seat in the sofa. Sir. I request all the presenters So to be ready, Dr. Aaron Fernandez, Dr. Amit Kumar Totakura, Dr. Rahul, Dr. Vishnu, Dr. Saurabh, Dr. Vishal Paul, Dr. Nishant Patro, Dr. Swami. So every one of you be ready for the presentation. Thank you.
Call one presentation. Just call the first one. Yes.
No questions. 14.
Only 8 are.
I request all the presenters to come forward. Next presenter, Dr. Amit Kumar Thotakura. Please come on.
Good evening, everyone. My name is Dr. Aaron Fernandez. I'm a neurosurgery resident at CMC Vellore. I'll be presenting a case on cervical Gossipoma, a case report, imaging features, and a review of literature. First introduction, Gossipoma is a mass within the body comprising of cotton matrix surrounded by foreign body reaction. The imaging features are variable. So usually it is a T1 hypointense, T2 hyperintense with a peripheral ring of enhancement. The incidence was reported as 0.7 in 10,000 patients, but probably underestimates because of underreporting. This is a case report wherein a 48-year-old male, he had presented with us with progressive myelopathy. Despite a surgery, a C3-4 anterior discectomy was done elsewhere. He presented with us with a neuric grade of 3, where he was having signs of spinal cord disease with difficulty in walking and to do his day-to-day activities. Local examination, there was no sign of infection. So we did an MRI cervical spine, which showed a T2 hyperintense left anterior epidural collection in the left side with a contrast enhancing rim. Our differential diagnosis included was maybe it is an abscess which has formed over there. So we took him off for surgery. We removed the C3-4 construct was already placed there, and to our surprise, we found a foreign body which was placed over there. We took the foreign body and the biopsy revealed a granuloma. This is the preoperative X-ray where you can see the construct done elsewhere. This is the X-ray. Normally, this is a CT axial and sagittal. In the literature, it has told that in the CT we can see some gas bubble appearance, but here we didn't see anything of that sort. This is the contrast MRI where you can see the axial and sagittal where there is a contrast enhancing rim. In the post-operative, this is the intraoperative picture where you could see the gauze piece over there. This is the cranial part and this cranial part. This is the gauze piece which we removed. This is the post-op MRI where you can see the cord has been decompressed and there is no compression over the cord. And this is the post-op X-ray where you can see the construct is well placed and in alignment. Now the main thing of this presentation was the review of literature. So we went across literature retrospectively and found 9 case reports wherein we told all the case reports suggestive that the foreign body will look as a T1 hypointense, T2 hyperintense with GADO enhancement. The basic, I want to conclude by saying that I always suspect Gossipoma when the lesion is T2 hyperintense, T1 hypointense with peripheral ring enhancement in post-operative patients. Thank you.
Dr. Amit, please.
Good evening, everyone. I would like to present a topic. Wrong level surgery is very rare, but it is very problematic to the patient and as well as surgeon. It poses legal problems also. So to prevent wrong level or mislevel surgery, multiple methods have been reported like skin marking, metallic coil placement, marking wire, etc. Of all those things, the advantages have been taken and disadvantages have reduced. And we planned a study to note the safety and efficacy of preoperative thoracic spine marker placement using LP needle. All the patients admitted to our NRI hospital from 18 to 75 years age with dorsal spine pathology were included. Regions where spinal fixation are required with CM, they are excluded. Patient is taken to radiology department. Radiologist keeps the spine marker preoperatively under the CT guidance at the level of the lamina. And after that placement, patient is shifted to OT, cleaned, exposure is done, tip of the needle is marked, and then surgeries proceeded further. Around 18 patients were included, lesions ranging from D4 to D12. The pathologies ranging posterior elements, OVL, IDM lesions, vertebral body lesions, all are included. There is a good intra-op correlation between alpinidal and level lesion in 16 patients, 89%, though 2 patients required extra 1-level laminectomy because of miscalculations. In conclusion, this is a safe, reliable, and cost-effective method to identify correctly. Wrong level surgery can be avoided. No need of C-arm, small skin incision, and less operative time are the advantages. So the disadvantage, like radiologist, should be there on the OT day, and patient feels some discomfort. The marker place. Thank you.
Nextly, Dr. Rahul P. Riker.
Good evening. I'm going to present a case that is a rare neonatal thoracic myelomeningocele. Myelomeningocele. Meningocele accounts of about 3.15 cases per 1,000 live births, out of which 1 to 5% of all the thoracic 1,000 live births of these thoracic myelomeningocele is rare neural tube defects, out of which 1 to 5% of neural tube defects are seen in thoracic level. So here we present one such case and its surgical management. Objective is to assess the surgical outcome. So a 28-day-old male baby presented to our neurosurgery OPD with fluctuant transilluminant swelling in the thoracic region, roughly 10 into 10 into 8 centimeters in size. Infant was a second born of non-consanguineous marriage through C-section. Power of lower limb were 5/5 according to MMRC grading. Pre-operative baseline investigation including imaging was done. MRI showed hyperintense lesion on T2, and brain MRI showed no obvious abnormalities. Surgical management, elliptical incision around the base was taken, and blunt dissection was done to separate the sac and the skin. Neural tissue was safeguarded and sac excised in total without injuring the spinal cord. The incision closed in layers without tension. The post-operative period was uneventful. Results. Post-surgical recovery, the baby had exhibited excellent recovery post-surgery with no complications. The incision site had healed well, and there were no signs of infections or CSF leak. Neurological functions. Follow-up assessment had shown baby's neurological function to be normal, and there have been no indication or motor or sensory deficits, which is a promising sign for further development. Developmental milestones. The baby is meeting developmental milestones as expected for their age, which is encouraging for long-term outcomes. Continued monitoring will ensure the developmental progress remain on track. Conclusion. The 28-day-old baby with thoracic meningocele has shown excellent recovery following successful surgical intervention with no complications and normal neurological functions. The prognosis is very promising and the baby is meeting developmental milestones as expected, highlighting the effectiveness of early diagnosis and comprehensive care. Thank you.
Dr. Vishnuvardhan.
Good evening, everyone. I'll be presenting a case report on CV junction tumors and the diagnostic dilemma. So, current times with the technological advancements that we rely on, mostly we are relying on radiological imaging for our planning of the surgeries, and oftentimes we are misguided by the radiology, and we find something surprising in the case that we usually operate. So here is a similar case report. A 60-year-old lady. She had a suboccipital neck pain with bilateral C2 radiculopathy for the last 3 months and painful neck movements, and also spastic quadriparsis for the last 1 month. So with a short history, we had taken a clinical diagnosis of a CV junction anomaly, probably a neoplastic etiology, or it could be an infective pathology or an inflammatory lesion. So the radiology was suggestive of a large lesion in the CV junction, which was well defined. It was intradural and extramedullary, and it was suggestive of a posterior spinal artery aneurysm with the thrombus within it. So we had done a MR trick sequence. Spinal DS was planned, but because of the cost restrictions and the patient's KFT, were not able to do it. So tricks is time resolved imaging of the contrast kinetics, where we can get a Doppler-like study of the vessels that we usually see. So there was a flow through the lesion, suggesting the possibility of a thrombosed aneurysm of the posterior spinal artery. So with this being a rare case, so we were very hesitant while operating also. Here we can see that we have performed a C1 posterior arch removal and a C2, C3 laminotomy. And we can see in this starting image that it is covered by the arachnoid. So following the excision of arachnoid, we can see that a well-defined lesion. And intraoperatively, we couldn't find any vascular communications. And it was just a plain nerve sheath tumor of the C2 nerve root. And it just popped out of the place. So the cord was repositioned, and we can see in the cross section that there is a thrombus within the tumor. This being a cystic schwannoma with a hemorrhage within it, so it is very rare actually. And the HP is also suggestive of a cystic schwannoma. So such lesions may be misdiagnosed, which can delay or prevent optimal treatment. A spinal DSA would have clinched our diagnosis, but because of the restrictions, we couldn't do it. So the imaging armamentarium should be inclusive of both invasive and non-invasive modalities if and when needed. Thank you.
Next, Dr. Vishal Paul.
Good evening, everyone. I'm here presenting a case of rare case of
Vishal Paul.
Vishal Paul, sir.
This is here, Saurabh Rana.
Dr. Vishal Paul.
Saurabh Rana. Oh.
Good evening, everyone. Here I'm going to present a rare case of skeletal metastasis of a neuroendocrine tumor. Actually, neuroendocrine tumors are a group of malignancies which arises from neuroendocrine cells, mainly from the liver, from the GIT and or the respiratory system, or sometimes from the thyroid or the adrenal. And it's if it is metastatic, it usually spreads to liver, lymph node, and the spleen. Now, skeletal metastasis is very rare in case of neuroendocrine tumors. It is seen that in about 10 to 15% is metastasis into skeletal tumors. And here I'm going to present a case of a 59 years old male who came to us with a history of neck pain and spastic quadriparesis for 4 months. We did MRI of the patient, which showed that there's a contrast enhancing compressive myelopathy as C5 posterior element. And we have planned for surgery. We did C4, C5 laminectomy with a near total excision of the tumor. Intraoperatively, we found the tumor was eroding the C5 spinous process with spreading to bilateral lamina, and also it was attached to dura. So the tumor was pinkish and moderately vascular and tenacious. The squash cytology came out to be a round cell tumor. And so we gave out the rest of the tissues for biopsy, but the biopsy came out to be metastatic small cell type of neuroendocrine carcinoma. To rule out the primary, we did immunohistochemistry and also PET scan, which came out to be the primary was both pancreatic head tumor and also thyroid was involved. So it's seen that the neuroendocrine tumors metastasis occurs depending on the size of the vertebra. If it is for skeletal metastasis, the larger the size of the vertebra, the larger the involvement. So more commonly the lumbar followed by thoracic, and to the cervical spine it is very rare. So till now, 47 cases have been reported of skeletal metastasis by neuroendocrine tumor, and of them, 10 cases have been of the cervical spine metastasis, and all of them, most of them involved the vertebral body. This is the first case which involved the posterior element of cervical vertebra without involving the vertebral body. So, and also skeletal neuroendocrine tumor are osteoblastic, but in my case it's osteolytic, as we saw in the PET scan, also the intraoperatively. So that's a very rare case. That's what I was about to report. Thank you.
Next, Dr. Nishant Patro.
A very good evening to everyone. Myself, Dr. Nishant Patro. I am here to present a role of transthoracic approach in tubercular thoracic spine. Introduction. The thoracic thoracotomy techniques allow surgeons to assess the ventral thoracic spine for a wide range of spinal disorders, including tumor, degeneration, trauma, and infection. It also allows direct visualization of the anterior thoracic spine for optimal lesion resection and the placement of anterior graft and instrumentation. Here I present a series of 3 cases which were operated in our institution. My first case is a 20-year-old female who presented to us with bilateral lower limb weakness and urinary incontinence. After clinical and radiological examination, he was diagnosed as a case of tubercular spine along with kyphotic deformity. Here we can see there is a we approached a case transthoracically and placed a cage in the level after corpectomy. Similarly, rest 2 cases we also approached the same transthoracic approach in patients of Cox spine. All the 3 patients were diagnosed as a case of Cox spine clinically and radiologically, and they were operated in right lateral decubitus position with single lung ventilation, and all the cases ICDT was inserted and which was removed post-operatively on 3rd day. So to conclude, the transthoracic approach for dorsal spine is safe and effective procedure, but requires careful coordination by thoracic surgeons, neurosurgeons, and anesthetics. Accurate and meticulous surgical planning and careful surgical technique is the key to yield a good outcome to reduce the risk of complications. Neurosurgeons should be aware of this approach and should use it without hesitation. Thank you.
Last presenter, Dr. Swami PT.
It was the
Hello, sir. Good evening. Myself, Dr. Swami. Thank you for the opportunity given to me to present this case, a case report of sacral chordoma with scoliosis. As you all know, sacral chordoma is a common primary sacral tumor, but also it may be either associated with the reactionary scoliosis. But in this case, a patient had a scoliosis which was not related. There was no spasm of the muscle, or there was no reactionary scoliosis. So I am presenting a case of 54-year-old male patient who presented with the complaints of low back ache for several years. He presented with swelling in the gluteal region for last 3 months. He presented to our OPD in a wheelchair. He was unable to walk with a power in the hip region of 3/5. He had hesitancy of micturition and dribbling of urine. On examination, he had a wasting of right hamstrings with grade 3 power of hip region. And we got an CT scan and MRI to evaluate further. CT scan showed there was no reactionary spasm of the paraspinal muscles, and there was a rotation of the vertebra. L3, L4 vertebra were rotated. So it was a dual pathology with sacral chordoma with associated scoliosis. So the main problem or the things we discussed before approaching to the surgery was, even if it is a reactionary scoliosis, if we correct the main pathology, scoliosis will correct on its own. But since this patient has a rotation of the vertebra, we have to address the both entities together to give a better functional outcome to the patient. So he underwent a subtotal excision of the sacral chordoma. As it was a very large size, complete excision was not possible. We did a subtotal excision with stabilization and correction of the scoliosis of the patient. Post-operatively, patient has a very drastic, very good improvement. He was able to mobilize with minimal support. He had a better functional outcome. To conclude, this case demonstrated a rarity of coexisting conditions of sacral chordoma with spinal deformity. The stability of sacropelvic fixation on a corrected and deformed spine differs, because if we have fixed that sacral chordoma, with a scoliotic spine, patient would have further difficulty in the function. So we corrected both scoliosis and the this sacrospinal fixation was done. So patient had a better functional outcome. On follow-up also, patient came walking to our OPD on the follow-up. Thank you, sir.
Thank you. That brings us to the end of the first day's scientific proceedings. We will now have a cultural program and a dance by the Sri Bhaskara Academy. This will be followed by dinner, for which everybody is invited.
Now it is a time for us to relax back and enjoy our cultural dances from Sri Bhaskara Dance Academy. I would request Sri Satvika Garu, Kuchipudi dancer with 17 years of experience, B-grade artist from Doordarshan, and performed on stage more than 1500 programs across the world. And Sri Satvika Garu is being awarded with Nandishwar Purashkar. I would request Sri Satvika Garu to come onto the stage.
I'd just like to clarify, dinner is for all delegates, not just the faculty. So I know what it says in the book, but everybody's invited.
Good evening, all. Myself, D. Satvika, disciple of late Sri Musunuri Indira Garu. Today, we are here to perform a Kuchipudi dance recital. We are going to begin with the blessings of Lord Sri Ganesha. We are going to perform on Ganapati Talam, Ragamalika, Talamalika. Thank you. Thank you so much. The next performance is going to be Deepanjali. Thank you. The next performance is a special performance where the students are going to perform on mud pots while holding the by holding different pots on their heads and candles in their hands. They're going to perform a few karanas in front of you. Thank you.
We had requested the dance means group. They are not professionals, but they are students, but they do very well. But I requested to select dances which involves balance because our theme is spine. So that's how they've selected this kind of dances. So I request all of you to encourage them very well.
Thank you, dear children. You have really done an excellent performance. We all have forgotten, the stress from morning. Now we are just taking a small break between. So we are moving on to the next dance performance. After having such an uplifting and productive day, I request everyone to witness most respected event, the ceremony of felicitation. It is our proud moment to be here around, and we have a distinguished legends who have had a great achievements to their credit and hard work to shape neurosurgical skills till today. Indeed, it's my great pleasure and deep delightfulness. With this pleasure, I would call upon Dr. Mana sir and Dr. Savitri Sastri sir to come onto the stage to lead the ceremony of felicitation.
It's no longer, conferences are no longer limited to cities, states, and even countries. It is a matter of great pride, privilege, and pleasure that we have faculty who have agreed to come from great distances, from South Korea, from the United Kingdom, from Brazil, and from our closest neighbors, Nepal. We would like to felicitate our visiting international faculty, and for that, I would like to call on stage Dr. KVRS Shastri. And from Seoul, Korea, Dr. Si-Hun Kim. I request Dr. Shastri and Dr. Manas to felicitate Dr. Si-Hun Kim. Uh, Thank you so much. Actually, I've never expected this the a gift and this the ceremony. You know, as the one of the lifetime member of NSSA India, it is always the great pleasure to me to be part of this the conference annually. So again, I'd like to thank, I'm very much grateful to Dr. Manas and Dr. Sastry again. And uh, it is always great to see you all at the annual meeting. Thank you very much. Thank you, sir. I'd now like to call upon Dr. Moda to come onto stage. And he will be felicitating Dr. Pandurang Kulkarni from the United Kingdom. Dr. Kulkarni has had a long association with NSSA.
Of course, it's nice to be here. It's a lot of pleasure to join back in SSA conference. Thanks, Manas and Savitra, organizing all this fantastic function. It's going very well, and my best wishes to all of you. Everything goes well. Thank you.
I'd now like to invite Dr. Purohit. Dr. Purohit, sir. And Dr. Purohit will be felicitating Dr. Krishna Sharma from Nepal.
Good evening. Thank you very much, Dr. Manas, Dr. Shastri, and the team. I've always felt a part of the family with this patient. I've been with them, with us, since a long, long time. So I feel I'm part of the family, and I'm really honored to be facilitated by the society. Thank you, Dr. Manas. Thank you, everybody. Thank you so much, sir. Thank you.
Thank you, sir. I'd like to invite Dr. Suresh Nair to the stage, please. He will be felicitating Dr. Aprajay Golash from the United Kingdom. Thank you, sir.
Good evening, everyone. Such an honor to be here. It's rather weird to represent as the president of British Association of Spinal Surgeons when I feel truly Indian. So thank you for the honor, and I'm thoroughly enjoying this. Thank you.
Thank you for coming.
I'd like to call on stage Dr. Kale, who has just arrived. And he will be felicitating Dr. Amit Thapa.
Thank you once again. On behalf of Nepalese Society of Neurosurgeon, I bring greetings to all of you. I cannot just explain in words, but it's the greatest day for me, being honored by my teachers, by mentors. It's been now 18 years since I have been like in association with them. And for me, India is just a second home for us. Thank you once again for this honor.
Thank you so much. I'd now like to invite Dr. Selvan to stage. Dr. Selvan will be felicitating the person who's traveled the farthest to get here, Dr. Marcos, all the way from Brazil. Dr. Marcos represents the Brazilian Spinal Surgery Society.
Yeah, I really crossed two oceans to come here, but it's a great pleasure to see your gentleness to having me here. It's impressive the friendship between Indian and Brazilian neurosurgery, and I hope we can work to have a official meeting together, two great societies in the spinal field. Thank you.
Thank you, everyone, once again. Now we are moving on to the next dance performance.
Before they go for the next set of dances, we just want to appreciate their effort. The Guru, please sit down. Can you get them? Dr. Sastri, sir, please come. They're all school students. Can you introduce them, all of them?
Taniksha, Srihita, Aradhya, Navyasri, Sharanya, Tanusri, Sriswita, Lakshmi Pranati, Pregna, Sahasra, and myself, D. Satvika.
Yeah, thank you. Thank you for coming. I had only spoken to her phone. I had selected the group after seeing a video at another function. And then I had requested if she can do something with Kuchipudi and classic and Odissi together. I hope you are doing something fusion of Odissi and Kuchipudi in Kuchipudi. Okay, thank you.
Our next dance performance by Sri Satvika Garu.
కదికదొం తకతొం తకదిరన కనకమణిమయను పురచరణ తకదికతొం తకతొం తకదిరన కనకమణిమయను పురచరణ తకదికదొం తకతొం తకదిరన కమల భవనుత శాశ్వత చరణ తకదికతొం తకతొం తకదిరన కమల భవనుత శాశ్వత చరణ తకదికతొం తకతొం తకదిరన కనకమణిమయను పురచరణ తకదికతొం తకతొం తకదిరన కమల భవనుత శాశ్వత చరణ తకదికతొం తకతొం తకదిరన కనకమణిమయను పురచరణ 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 తదండ దండ తజన్ను జన్ను తదిమ్మి దిమ్మి తదిత్తగదిన దొమ్మ తదండ దండ తజన్ను జన్ను తదిమ్మి దిమ్మి తదిత్తగదిన దొమ్మ తదండ దండ తదిత్తగదిన దొమ్మ తజన్ను జన్ను తదిత్తగదిన దొమ్మ తదిత్తగదిన దొమ్మ తదిత్తగదిన దొమ్మ తగదిన దొమ్మ తగదిన దొమ్మ తగదిన దొమ్మ தத்தித்தகதினதும் தித்தகதினதும் தகதினதும் ததிங்கிணது தகதிங்கிணது தகதிகதிங்கிணது தித்தகதினதும் தித்தகதினதும் தகதினதும் ததிங்கிணது தகதிங்கிணது தகதிகதிங்கிணது தித்தகதினதும் தித்தகதினதும் தகதினதும் ததிங்கிணது தகதிங்கிணது தகதிகதிங்கிணது தகதிகதோம் தகதோம் தகதிரனா கனகமணிமயனு புரச்சரண தகதிகதோம் தகதோம் தகதிரனா கனகமணிமயனு புரச்சரண தஜம் தா தகிட்ட ததித்தங்கிணது தகதிகதிங்கிணது தஜம் தா தகிட்ட திம் 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 தஜம் தா தகிட்ட ததித்தங்கிணது தகதிகதிங்கிணது தஜம் தா தகிட்ட திம் 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 தின்னக்கிடத்துக்கு திம் 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 தின்னக்கிடத்துக்கு திம் 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 தின்னக்கிடத்துக்கு திம் 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 தின்னக்கிடத்துக்கு திம் திப் தின்னக்கிடத்துக்கு திம் திப் திப் தின்னக்கிடத்துக்கு திம் திப் 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 தின்னக்கிடத்துக்கு திம் தின்னக்கிடத்துக்கு திம் திப் தின்னக்கிடத்துக்கு திம் திப் திப் தின்னக்கிடத்துக்கு திம் திப் 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 தின்னக்கிடத்துக்கு திம் தின்னக்கிடத்துக்கு திம் திப் தின்னக்கிடத்துக்கு திம் திப் திப் தின்னக்கிடத்துக்கு திம் திப் 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 தின்னக்கிடத்துக்கு திம் தின்னக்கிடத்துக்கு தக்கதிக்கத்தொம் தக்கத்தொம் தக்கதிரனா கனகமணிமயனு புரச்சரண தக்கதிக்கத்தொம் தக்கத்தொம் தக்கதிரனா கனகமணிமயனு புரச்சரண தஜம் தா தகிட்ட ததித்தங்கிட்ட தஜம் தா தகிட்ட திம் 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 தஜம் தா தகிட்ட ததித்தங்கிட்ட தாம் ததொம் ததிம் தத தஜம் தா தகிட்ட ததித்தங்கிட்ட தஜம் தா தகிட்ட தஜம் தா தகிட்ட தஜம் தா தகிட்ட ததரி தத தன தத தத்த ஜனி தத ஜனி தத தத்த தன தத தன தத தத தன தத தன தத தித்தா தஜம் ததிகிண தித்தா தஜம் ததிகிண தத தஜம் ததிகிண 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 தத தித்தா தஜம் தக ததிகிண தித்தா தஜம் தக ததிகிண தத தஜம் தக ததிகிண தக ததிகிண தக ததிகிண தத தித்தா தஜம் ததிகு தித்தா தஜம் தகதிகு தகதிகு தகதிகதொம் தகதொம் தகதிரனா கனகமணிமயனு புரச்சரண கல்வித கலிகனுஷ ಧ್ವನಿಮಾರ್ದನ ಕಾಳಿಂಗನಾರ್ದನ ಕವಿತ ಜನಾರ್ದನ ಕಲ್ಪಿತ ಗಲಿಗನುಷ ಧ್ವನಿಮಾರ್ದನ ಕಾಳಿಂಗನಾರ್ದನ ಕವಿತ ಜನಾರ್ದನ ತಾಂ ತಕಿಟ ತಕ ತಕ ಧಿಮಿ ತಕ ಜಣು ತಕ ಸರಿ ಮಗರಿ ಸರಿ ಮಪ ತಾಂ ತಕಿಟ ತಕ ತಕ ಧಿಮಿ ತಕ ಜಣು ತಂಜಣು ಸರಿ ಮಗರಿ ಸರಿ ಮಪ ತಜಣು ಸರಿ ಮಗರಿ ಜಂ ಜಂ ತರಿ ತದಿತ ಕಿಣದ ಪ ಮಗರಿ ಸರಿ ಮಪದ ತಜಣು ಸರಿ ಮಗರಿ ಜಂ ಜಂ ತರಿ ತದಿತ ಕಿಣದ ಪ ಮಗರಿ ಸರಿ ಮಪದ ಮರಗದ ಮಣಿ ಮಗ ಚೇಲ ಮರಗದ ಮಣಿ ಮಗ ಚೇಲ
Thank you all the children for your excellent performance and your guru as well. Thank you once again. Now we have come to the end of the today's complete sessions. I request everybody to just enjoy your dinner and see you all tomorrow. Have a great night. I request all the participants to be here by 8 a.m. tomorrow morning and people who have their presentations to be here by 7:30 to load their presentations in the preview. Thank you everyone and great evening.